04. This public body is authorized to meet electronically. This is a committee meeting with hearings on bills and possibly executive session voting. Please note there is no physical location for the members of the public to observe and listen contemporaneously to this meeting. However, in accordance with the emergency order, I am confirming that all members of the committee and select legislative staff have the ability to communicate contemporaneously during this meeting through the Zoom electronic meeting platform. The public has access to listen contemporaneously and, if necessary, participate in this meeting by the Zoom platform or by telephone. All necessary access information has been made available in the House calendar and through the electronic calendar on the General Court website. The notice for this meeting complies with House rules and RSA 91-A. Anyone who has a problem accessing the meeting should call 271-3660. In the event the public as a whole is unable to access this meeting, the meeting will be adjourned and rescheduled. Christina Dyer, the committee researcher, will be the staff assisting us. Please note that all votes are taken during this meeting by roll call votes. We will start the meeting by taking roll call attendance. When each member states his or her presence, please also state whether there is anyone in the room with you during this meeting, which is required under the right to know law. All roll. Representative March.
Good morning. This is Representative Marsh. I am currently home alone in my home office in Brookfield.
Representative McMahon.
Here.
Representative Nelson.
Here.
Are you alone?
I'm in Brookfield and I am alone.
Representative Upton.
Hello, I am in Fremont and I am home alone with my daughter's homeschooling in the next room.
Representative Gay. Here. Representative Cushman.
Present.
Representative Folsom here. Representative Kelsey.
I'm present in my home in Bedford. My husband and my daughter are in the other part of the house.
Representative King.
Here.
Representative Colfault. Representative Colfault.
Yes, I am here in my home office in Wilton, and there are some other people in the house, nobody else in the room at this time.
Representative Weber. Representative,
Yes, I'm here. I'm at home and there is no one else in the house.
Representative McKay. Representative McKay. Representative Snow. Representative Snow. Representative Knirk.
Excuse
Yes,
me,
I am
Representative
here.
Snow said he'd be joining us shortly. He had a bit of a health emergency that he was dealing with, and he'll be right in.
Okay,
This is Representative Knirk. I am here. I'm home in my study in Freedom, and my wife is elsewhere in the house, leaving for work later.
Representative Holloway.
Here, at home in my office in Lee, New Hampshire, alone.
Representative Cannon.
I'm home alone in my home in Somersworth.
Representative Nutter Upham.
I'm home in Nashua, alone in the room, but not in the house.
Representative Shapiro.
I am in my home office in Keene, on my own.
Representative Woods.
Present at my study, at my home in Bow, and my wife is someplace else in the house.
Representative Merchant.
Here, I'm in Claremont, New Hampshire in my home, and my wife is somewhere else in the house. Okay, and the Chair Pearson,
I'm here in Concord with my colleagues.
would Representative Marsh please let us know when Bill appears?
Yes. Yes, the clerk is asking Representative March, you let us know when other committee members appear.
There are enough committee members here, so with that, I will call the public hearing to order for House Bill 75 and recognize Representative Pearson to introduce his bill.
Thank you. You've received the testimony on this bill. It is substantially the same bill that came through this committee 21-0 last year and was approved on the consent calendar in the House and went to the Senate to be tabled with many other good bills. Essentially, there's two parts to this bill. First of all, the New Hampshire Commission on Deafness and Hearing Loss, which I chair, had a political subcommittee that I appointed a year and a half ago to look at various possible pieces of legislation. One of the items that came up was the title of our committee. The title of the committee as it exists now refers to medical conditions, not to people. Other titles were suggested. I asked a few members of this subcommittee to do an informal poll in the deaf and hard of hearing community in New Hampshire to see what their pleasure would be. And I asked a few other members of the subcommittee to investigate to see what other states call similar commissions to ours. The overwhelming choice for the rename was the New Hampshire Commission for the Deaf and Hard of Hearing. It's a positive, proactive title that speaks about people. Along the way, this group wondered if we could form a commission or a committee out of a bill to investigate how the services for the deaf and hard of hearing are being conducted in our long-term care facilities in the state. After much discussion and consultation with those who have been in the House a lot longer than me, the conclusion was, instead of having something separate, let us invite representatives of the three major long-term care facility organizations to join the commission. I spoke with the person who leads the county nursing homes, the person who leads the private nursing homes, and the person who leads the extended care facilities that are not so much nursing homes. Each person thought it was a good idea to have a representative become part of the commission to bring that perspective to the various things under consideration, and especially on those times when we were looking at the extended care facilities and the services they provide. In each case, it was apparent to me, something that I've experienced in a lifetime of visiting people in the nursing homes, that most nursing home administrators really care and are trying to do a good job, but they're willing to learn things that they didn't know before in terms of caring for their people. So this bill seeks to rename the commission and add 3 members, as I just delineated. That is my testimony, Acting Chairman.
Thank you, Representative Pearson. Before I take questions, I will recognize Representative Snow to tell us where he is and whether he's alone so that we're compliant with 91A. Ken, you just muted yourself. You were unmuted before.
Okay, am I okay now?
You're fine.
Thank you.
Yes, this is Representative Snow from my house in Manchester. My wife is in the vicinity. I apologize for being late. We had a small little health thing we had to take care of this morning, and it's all set now and everything's fine. Thank you. Sorry.
We understand and we're glad that you are fine. Representative
go on.
Weber had told us that you were going to be delayed. With that, I'll ask if there are any questions for Representative Pearson. Seeing none, I'll thank Representative Pearson for his testimony and recognize NDHHS for their testimony.
Can you hear me?
Yes, we can.
Good morning, members of the committee. Thank you for allowing me to speak. I apologize for getting my testimony request in at the very last minute. I just saw that this was having a hearing this morning, and it's a very important bill. My name is Jules Good. I do work for Northeast Deaf and Hard of Hearing Services, but I'm here representing myself as a private citizen. I am deaf. I live in Concord, New Hampshire. First of all, I would love to just voice my support for the renaming of the commission. I think it's super great that you're centering people like me instead of medical conditions, so I really appreciate that. In my role, I also do work with a lot of nursing and extended care facilities, so I also appreciate that you're adding their perspectives as a part of the committee. One thing that I would like to recommend as a suggestion for an addition to the bill would be to add a member of the public who has lived experience as a deaf-blind person. So the deaf-blind community is definitely a part of the deaf and hard of hearing community, even though they kind of bridge, between the deaf and blind communities. They're still very much a part of the work that we do and need to be represented in committees such as this. You may notice in HB 631, which you'll be hearing later this week, that bill is relative to standards for interpreters for the deaf and hard of hearing. They are adding into that bill language to talk about interpreters for deaf-blind people as well. So I think it's only appropriate that we include deaf-blind citizens in our in the language for this bill as well, being that they're being discussed so close together. So I am happy to take any questions you have about this. I am using the captioning service, which I'm so happy is being provided. That's so great. So it may just take a minute for it to catch up with what you're saying before I can respond. Thank you.
Bill, you were muted.
The clerk wishes to speak.
Thank you. The spacebar trick was not working. Does the committee have any questions?
Yes, Representative Marsh.
Go ahead.
Can the witness please state her name and organization again? We did not catch that. Slowly.
Yes, could you please state your name and organization again slowly for the clerk?
Yes. My name is Jules Good, Jules, last name Good, Good. And I work for Northeast Deaf and Hard of Hearing Services, which is abbreviated NDHHS.
Thank you, Jules, for your patience. We are a little slow sometimes. We're older. Are there any other questions for the witness? I thank you again for your testimony, and I will now recognize Henry Lippman, who had his hand raised.
Excuse me, Mr. Chairman, I think it was just me moving my mouse around. I must have hit the raise hand button. I apologize.
It happens all the time. We're all working this out as we go through. If there's anybody, other members of the public who wish to testify, would they please raise their hands so that we can recognize them? Christina, I see no hands raised.
I don't see any either.
Thank you. And with that, I will close the public hearing on House Bill 75 and open an executive session on House Bill 75 and recognize Representative Pearson for a motion.
Thank you, Acting Chairman, and to address the comments of the person from Northeast Deaf and Hard of Hearing, we are under consideration of adding for the deaf and the deaf-blind to our commission. Discussions have been begun, and this is something we wish to not just add a member, but significantly recognize that need. So thank you for that testimony, and it is a work in progress. I move on House Bill 75 ought to pass.
Thank you. Is there a second for the motion? Recognize Representative Woods is getting his hand up first as seconding the motion. Is there further discussion towards the motion?
Point of order,
Go ahead.
if we're going to amend this, the changes that you want to make are not an amendment?
We're not making any changes to the bill. We are taking under advisement for us to eventually bring forth an amendment, but not now.
We can amend here or another session. Not to this.
No, we will bring in something else in a later
Okay,
date.
thank you.
Yep, the motion on the floor is ought to pass. If you wish to have an amendment, you would vote in the negative and then bring an amendment forward. And that would certainly be one result that could be possible from this. Is there any other discussion? Seeing none, I'll ask the clerk to call the roll.
Thank you. Representative Marsh,
Representative March votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay. Yes. Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Popa,
Yes.
Representative Weber.
Yes.
Representative McKay, yes.
Yes. Representative McKay, yes.
He is not voting. I don't believe he did vote because the voting had started.
Oh, okay, okay. Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Gannon?
sorry.
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Chair Pearson? Yes. The roll, with the roll call, the vote is 20 yeas and 1 absent.
Therefore, I declare that the motion passes in the vote of 20-0. Is there any objection to consent?
No.
Seeing none, we'll put this bill on consent and I will relinquish the chair to Chairman Pearson. Thank you very much.
Thank you, Representative Marsh. We now call our committee session back. We introduced House Bill 600, fiscal note relative to funding for newborn screening. And I would ask the bill's prime sponsor, Representative Marsh, to present your bill, please.
Thank you, Mr. Chairman. Good morning. For the record, I am Representative William Marsh, representing 7 towns in Southern Carroll County. Relevant to this bill, I also chair the New Hampshire Rare Disease Advisory Council. I'm pleased today to offer for your consideration House Bill 600 relative to funding newborn screening tests, which I filed at the request of the New Hampshire Hospital Association. New Hampshire's newborn screening program is a wonderful program, and the intent of this bill is not to change the program in any way. For instance, in the last year, one of my ballot clerks in the town of Brookfield had their first grandchild. The child was diagnosed with spinal muscular atrophy, a test newly added to our newborn screening panel, and successfully treated with genetic therapy. This baby now looks forward to a normal life. Without treatment, SMA is universally fatal. The issue that I have with the program is how they send out their bills. Under current law, DAHHS bills hospitals for the filter paper on which blood samples are submitted for testing. The cost of this filter paper has doubled in the last year, and I understand it is now approximately $210 per piece of paper. It is expected to increase as more tests are added to the newborn screening panel, which is reasonable and expected as more genetic diseases are, they develop treatments for these diseases. Filter paper is a supply, and a bill for filter paper cannot be submitted to insurers. There is no charge at this point in time for the test performed. We are simply asking the commissioner to restructure the current fee so that these bills can be submitted to insurance. Instead of billing for filter paper, the invoice could read newborn screening panel. This is already done in other states. For instance, in the state of Texas, effective January 1st, 2001, that being 20 years ago, HCPCS code S3620 was implemented for newborn metabolic screenings. Minnesota uses the same billing code. You can see this on their websites. An American Academy of Pediatrics document about 1 month preventative visits recommends HCPCS code S3620 for newborn screening if not already performed, and a list of CPT codes, most notably V77.7, special screening of other inborn errors of metabolism. Coverage for pediatric preventative services has been mandated by federal law without copay or deductible since 2014 pursuant to 45 CFR 147.130. This bill does not mandate any change whatsoever in insurance law. Regarding a proposed amendment to add the words collection fees, that does not work for a great many reasons, the major one being that the federal law I just cited mandates coverage for preventative health services and says nothing about collection fees. Passage of this bill will help maintain the economic viability of the various birthing centers in New Hampshire because we will allow them to recover at least some of their costs. Thank you, and I'll be glad to take questions. I believe we have lost the chair.
No, the chair's right here.
Good.
I'm just giving people a chance to figure out if they want to ask you a question. Looks like they don't. So thank you for your testimony. And I would like to call upon Paula Minahan from the New Hampshire Hospital Association, who has signed up to testify. Ms. Minahan.
Good morning, Mr. Chairman, members of the committee. Can you hear me?
Yes.
Great, thank you. For the record, my name is Paula Minahan, Senior Vice President, State Government Relations with the New Hampshire Hospital Association, representing all our hospitals. And we are very supportive of HB 600, and we do thank Representative Marsh for sponsoring this important bill, as along with the rest of the co-sponsors. I have to say, Representative Marsh did such an excellent job at explaining this. I really don't have much more to say except everything that he said. That was really well presented. This is a very important bill to our hospitals. As Representative Marsh said, we are not looking to change the program at all. We are looking to just essentially ensure that the state law is aligned with the federal law and allow for the hospitals and the birthing hospitals and birthing centers. Not every hospital, as you know, provides birthing services, unfortunately, but have the birthing centers and birthing hospitals be able to bill for these screening tests and get reimbursed, and not dictating what they'll get reimbursed. Again, just allowing for that opportunity to do that. And as he indicated, currently the way the program is structured, essentially the hospitals and birthing centers pay for the filter paper, which effectively pays for the program. Again, we're just trying to allow that opportunity to have them be able to bill. We do believe it's a very important bill to balance the fees needed to support the program with the ability to recoup some costs. And we ask the committee to vote ought to pass. Happy to answer any questions, and thank you very much.
Thank you, Ms. Minahan. Is there any questions for the one who just testified? See, the chair recognizes Dr. Sai Charala, DHHS, who has signed up to speak. Dr. Charala.
Can you hear me?
Yes.
Yes.
Thank you. Thank you so much for having me here. For the record, my name is, good morning, Representative Chairperson, Representative Pearson, and the committee members. For record, my name is Dr. Sai Charala. I'm the Bureau Chief for the Bureau of Population Health and Community Services and the Division of Public Health Services. I want to thank our Vice Chair, Representative Marsh, who has been very proactive and collaborative partner on these topics. And also want to thank him for organizing a meeting between Public Health, our Medicaid, and New Hampshire Hospital Association to discuss the proposed legislation. So just to give you the background, the current legislation amends the existing law to make clear where the fees are charged for the hospitals and newborn screening. I just want to thank the committee for giving me this opportunity just to provide an overview of what's the function and funding of our program for the New Hampshire newborn screening program. So newborn screening program, has Representative Marsh mentioned, is an essential preventive public health program. It's a population health program, population-based program. It's a complex integrated system. So what we are trying to do is to get an early identification of some of these metabolic disorders, genetic disorders, so that way we can timely and have it timely as well as an early intervention. And that actually can lead to elimination or reduction of death and disability. So for every time we see, what we do is when we see an abnormal screening, we actually link the infant to their subsequently to receive any kind of diagnostic test as well as refer them for the appropriate treatment. So what we do in New Hampshire newborn screening program is approximately we have around 12,000 births every year. So we are responsible for assuring that all the infants who are born in New Hampshire are screened at birth for any of these inherited medical disorders. So what we do is we take few drops, not we in the sense in the hospital, they take few drops of blood, and actually few drops of blood are taken from infant's heel at 24 to 72 hours of birth on a filter paper, and that's actually sent to a lab for testing. And this process is done before the infant leaves the hospital or the birthing center, because timing is everything in this situation, because some conditions need to be identified within the first week of life. And this all happens under our state legislation. Families may refuse the screening if they wish to, and we are responsible for handling all the screening results, follow up on the out of range results as needed, like following up with the pediatrician to let them know about the condition, as well as providing those resources to the families and to the pediatrician. So what we do in New Hampshire is we screen for 37 conditions. Not only these, we also screen for critical congenital heart defects as well as newborn screening. So we have an advisory committee under the legislation that actually provides recommendations to our state program on what kind of clinical, educational, or operational aspects of the program is. And this committee actually meets biannually. We also provide an annual report that's required under the legislation to Health and Human Services Oversight Committee on previous year's newborn screening program activities. Coming to the funding, how this is actually funded, newborn screening program in New Hampshire does not use any state or federal funds. Rather, it is a non-lapsing newborn screening revolving fund. It's funded by filter papers. Currently, the cost of filter papers is $146, not $200, but $146. And it's paid by the participating healthcare providers. These include our hospitals, birthing centers. So, and basically the filter paper is used for blood spot testing. So we have around 17 hospitals that are part of this group. The current cost, annual operational cost for the newborn screening program is $1.8 million. And the funds are used to pay for the cost related with a contract that we have with University of Massachusetts Medical School, which runs our newborn screening or our lab program. So they are responsible for testing, screening, and shipping and supplies. The fund also supports a 1.5 FTE personnel for the program, a database system, as well as a medical consultant. So our understanding with our current legislation is it will not impact the process by which how the program is funded, but more clarity on and also that the fees, how the fees are collected. But also important thing is that this will not have a direct fiscal impact on the newborn screening program. So thank you for giving me this opportunity to talk about newborn screening program in New Hampshire. And please let me know if you have any questions.
Thank you, Dr. Terrell. Are there any questions from the committee for the one who just testified? Seeing none, I thank you for your testimony, and the chair recognizes Heidi Kroll, who is a lobbyist for America's Health Insurance Plans. Ms. Kroll.
Good morning, Mr. Chairman. Are you able to hear me?
Yes, thank you.
Okay, good. Thank you very much. Yes, thank you. Good morning, everyone. My name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I represent America's Health Insurance Plans, otherwise known as AHIP, which is the trade association for the health insurance carriers. And I think there will be a few other carriers who testify here today as well. We're just kind of scratching our heads on this one, I guess, confused, and I think looking for some clarification. Our understanding is that the carriers do reimburse for a bundle of newborn screening tests, reimburse the hospitals or the birthing centers for that. To the best of my knowledge, talking with some of the New Hampshire AHIP members, none of the hospitals or birthing centers approached the carriers to indicate that the reimbursement for those bundle of services was, in their opinion, not adequate to cover the cost of the filter paper. And so I guess we're just a little concerned that perhaps we're having a situation where rather than kind of going through the normal contracting process and procedures that hospitals and carriers engage in, that we're looking for a legislative solution or intervention. So I may be misunderstanding the situation, but that's our concern, I guess, is that we're looking for a legislative solution when maybe there could have been one outside of the legislature. We're just simply working in the normal contracting that happens between hospitals and the carriers.
Thank you. Well, could I ask Representative Marsh if you would address that?
Yes, I'll be glad to address that, although I think Paula Minahan would be a better person to address that. It is my understanding that insurers are not reimbursing for the filter paper because they're not being sent any bills for the filter paper. So I will yield my time to Paula Minahan.
Paula Minahan, please.
Mr. Chairman, this is Heidi Kroll again. I guess I would just say that I think the concern is that carriers are paying for the bundle of newborn screening tests, which presumably is an all-encompassing payment for that bundle, and we're not when services are reimbursed by carriers. There's not kind of a parsing out of all of the individual parts and pieces that go into a particular service or a particular test. So, for example, the cost of a syringe goes up or something else changes. That's kind of typically not a separately billed item just because one little piece of a test has gone up. So it's, again, it gets back to this, you know, we're paying for a service, we're paying for a bundle. And I think, at least from the carrier's perspective, we assume that that's encompassing everything, staffing, supplies, it's got a piece of, you know, to help hospitals with overhead, et cetera. So at any rate, that's our concern, is that it's really kind of not how reimbursement works, from at least from the carrier's perspective. And again, I think there were other New Hampshire AHIP members who will testify today, but that's what I wanted to share with you this morning.
Chair had recognized Paula Minahan to speak. Is she on the call?
Thank you, Chairman. Can you hear me? I was
Yes.
having trouble. Sorry about that. So I think, you know, there's more discussion that we can have, but I think Representative Marsh explained it pretty well. Because of the structure of how the filter paper is paid for, you cannot turn around and put filter paper on a bill and bill the carrier. So I think there's just a little misunderstanding, honestly, and I think we can have that discussion, but the carriers are not acknowledging that because there's not a mechanism to be able to effectively, properly, and clearly, without having any billing fraud, to ensure that those costs are recognized. You create, as Representative Marsh identified, there are codes that can be billed, but we need the structure, if you will. We need the law to be able to allow for that. Right now, the carriers really are not seeing this charge because of the way it is currently paid for. So we're just trying to create a mechanism so that those some of those costs can in fact get negotiated with the carriers. We're not saying this is a mandate at all. I think we just need to have further clarification. I talked with the CFOs at the hospitals, and they explained what I just explained to you, to me. And I think there's just needs to be a mechanism, again, to be able to effectively and legally bill the carriers for these services. And there may be some hospitals that have negotiated something and been able to kind of tease out something for some of the newborn screenings, but that is not universally how the hospitals have done it. So that's all. We're just trying to clean it up so that it's more clear. That's all.
Thank you, Ms. Minahan. The chair now recognizes to testify Sabrina Dunlap.
Thank you, everyone. This is Sabrina Dunlap. I'm Director of Government Relations at Anthem. I would echo a lot of what Heidi said. I think we're just unclear on why this issue has come up. And I spoke to our contracting folks, and this has not come up on the contracting side. So it just seems odd. Insurers haven't been engaged till this point, and it seems like on the reimbursement issue, we would have been engaged. And I'm just not clear on why legislation is needed here. Even hearing Paula's answer there, because it's something that needs to be negotiated. I'm not sure what a bill would do on this. Also not clear how the bill would play out as a practical matter. It's just not clear to me what that mechanism is or why it's even needed. So anyway, just wanted to raise those concerns with you. So thanks very much.
Thank you. Chair recognizes Henry Lipman from DHHS.
Good morning, Chairman Pearson and members of the committee. My name's Henry Lipman. I'm the Medicaid director for the state, and understanding what Representative Marsh and Paula Minahan relayed. I think from the Medicaid program perspective, we're concerned what we see out there with respect to the number of birthing obstetric opportunities there are in the state of New Hampshire are declining, and that being able to recover some of the costs related to this testing will be a small part in trying to maintain an adequate network for Medicaid beneficiaries. The places where obstetric services are disappearing are more in the rural areas as well. There are concerns about the continued viability of obstetric services in other locations. So I think if providing some compensation in this area would be supportive to maintaining it, and the department, I think, is supportive in working something out here.
Thank you, Mr. Lippman. Is there anyone else who wishes to testify?
There is Andrew Hosmer and Krista Gilbert with their hands up.
Andrew Hosmer, did you say?
Yes.
Yes, the chair recognizes Andrew Hosmer. Would you let us know whom you represent, please?
Mr. Hosmer, you'll just have to unmute.
Thank you very much. Thank you, committee. My name is Andrew Hosmer. I represent Harvard Pilgrim Healthcare. We are signing in opposed to this bill. Much like AHIP and Anthem, this was not an issue that we were aware of, and certainly think of it as an item that can be negotiated between the carriers and the providers here. We think the bill as written, I think it creates more confusion on our part than it does direction. And certainly we think we'd look for an opportunity to sit down with the providers at some point here and craft a solution outside of legislative mandates. So without taking up too much more of your time, I appreciate the opportunity to speak, and thank you.
Thank you, Mr. Hosmer. Christina, who is the other person wishing to testify?
Krista Gilbert.
Okay, and the chair calls upon you. Would you please spell your name and tell us who you represent?
My name is Krista Gilbert, Krista Gilbert. I'm representing myself. I want to share that I have several connections to the rare disorder community. Though I am representing myself, I am the state ambassador for the New Hampshire Rare Action Network, which is an advocacy branch for the National Organization for Rare Disorders. I am on the Rare Disease Advisory Council, and I am the vice president of the New Hampshire Rare Disorders Association. I just want to share that I'm in support of this bill. The newborn screening is a diagnosis conditions and is a life-saving disability preventing measure. And I believe that this bill would provide sustainable funding that would make it easier to add new tests to the panel. This year, 3 new tests were added to the panel. And as Representative Marsh stated, there was someone this year that was diagnosed with spinal muscular atrophy, which allowed that individual to be treated with a new medication that was really life-changing for that child. So I just want to speak in favor.
Thank you very much, Krista. Does anyone on the committee have a question for the one who just gave testimony? I thank you for your testimony. Christina, is there anyone else?
No other hands raised.
Say that again, please.
Nope, there are no other hands.
Thank you very much. With that, I close the hearing on House Bill 600 and at the request of the sponsor, move into the executive session on the bill. And I would give Representative Marsh as the prime sponsor the first opportunity to speak in executive session. Representative Marsh.
Thank you, Mr. Chairman. I will move ought to pass, and when I have a chance, I'd like to speak to my motion.
Do we have a second?
Second.
And that is-
Representative Merchant, second, please.
Thank you. Representative Marsh.
Thank you, Mr. Chairman. Those of us who've been on this committee for some time know that our bills frequently provide the impetus for issues to get resolved that have not been resolved or even shown any sign of being addressed in the past. And I am really thankful for the insurers for appearing today. And I do believe that as this bill moves through the process, this may get resolved offline, and it may get resolved to the point that the bill no longer needs to continue to move forward. That being said, I think we need to continue this bill moving forward so that we maintain and support our hospitals. We all know that we've had a hospital closure recently in the middle of the state of New Hampshire. We also know that Frisbee Hospital recently has stopped their labor and delivery program. I believe that is the case. If we don't support those places in our state where babies are delivered, there won't be any place in our state to have babies be delivered. And that is a real health problem that we need to address. So I think this is a very small step towards supporting those institutions. And I'm hoping that the rest of the committee will agree with me. Thank you very much.
I heard the word amendment floated sometime in the last 20 minutes. Is there an amendment coming forward from anyone? I don't have it if there is.
Not to my knowledge, Mr. Chairman.
Christina, are you aware of an amendment coming to us on this?
No, I am not.
Thank you very much. Anyone else in the committee wish to speak?
Representative Knurk has a question.
Representative Kennard?
Thank you, Mr. Chair. I actually would just like, because it seems like the conflict here comes down to the question of, do hospitals realize they can bill for the filter paper? Do they bill for the filter paper? And I think Representative Marsh answered that question briefly earlier, but could he elaborate just a bit more so we can understand? Because indeed, if they simply aren't because it's not allowed, then this bill really needs to go forward to allow that. Could Representative Marsh clarify this issue a little better?
Yes, I'll be glad to do that. Filter paper is clearly a supply, just like a syringe would be a supply or a diaper would be a supply. Hospitals do not bill separately for supplies. However, this cost of the supply has been increasing at a very rapid rate because it is being used to pay for a test. The test being the genetic test run on the blood. What we are asking, very simply, is that the invoices change to read metabolic screening panel so that it is clear what the invoices are for. Once that is done, there are billing codes associated with that title, and at that point in time, negotiations can occur between the various insurers and the hospitals, and they can resolve this issue. We're not asking for an insurance mandate. We're not asking for any money to pay for this. We're not asking to change the program in any way. We just want to change the title on the top of the invoices.
Are there any other questions from the committee or state?
Mr. Chair,
Yes, Representative Merchant.
if I could speak to my second, please. Sort of reinforcing what Representative Marsh is saying, I don't see this as a quote mandate, except allowing for the ability for the biller to include a mechanism to address the issue about the supply that goes into the testing. And to Representative Marsh's point of view, I totally agree that currently we bill for procedure codes and we bill for things that are related to a service, not so much per se for supplies. And this fundamentally allows for that to occur. It does not interfere with the ability between the insurance company and the hospital to negotiate the price on the invoice. That's still left to them through the normal market channels we have today. It just recognizes that there is a cost and allow for that to be able to be included on the invoice to the insurance company. Thank you, sir.
Thank you, Representative Merchant. As a part-time CEO of a facility that has 3 primary care providers, I can tell you, but I won't, difficulties that we sometimes have that seem to get resolved when legislation starts showing up. So it could well be the case that as this bill goes through the various hoops, that negotiation will be satisfactorily begun and concluded. But it's good to have a bill to help the process go on. So I underscore Representative Marsh on that from seeing it on an almost daily basis. Anyone else in the committee wish to speak? Seeing none, the motion,
Representative Nelson has his hand up.
I'm sorry?
Nelson.
Representative Nelson.
I was muted. I apologize. I have a question. I said, how many tests are done? It's one draw, number one, of blood for a newborn. How many tests are now done on that one draw? And how long, when they go to read these tests, do they just put it in the machine and Zappo, they come out with something? I have no idea.
Mr. Chairman, Dr. Chirala will be the best person to answer that question.
Dr. Charlie, you may be recognized to speak in the executive session.
Thank you so much for that question, Representative Nelson. We currently we have approximately 12,000 births in New Hampshire. So we run basically almost 12,000 tests. Sometimes they might be higher because for any child, sometimes the blood spot is not enough. So we might have to repeat, or if they are premature, so we would have to repeat some of those tests. We have a contract with University of Massachusetts Medical School that runs the test. We actually currently do 37 tests, 37 newborn, different kinds of 37 different conditions that we test for. So, and no, we basically can zap them and get the results. It takes time. It takes roughly 24 hours time to get those results out. And that information comes to us, and our newborn screening nurse program consultant basically calls up based on if the screens are at a different level or abnormal screens. We actually follow up both the reach out to the family as well as to the pediatrician for next steps. And we also link those families for the further screening and further testing as well as the treatment.
Thank you very much, Dr. Terrell. Anyone in the committee wish to speak? The chair recognizes Representative Cushman.
Thank you, Mr. Chairman. Representative Marsh, I'm just wondering, so if these newborn screenings are mandated, am I correct in that assumption?
The individuals have the right to refuse the test. That is rarely done, but it is allowed.
Okay.
Follow up?
So this is a routine screening though that most parents will consent to. And is it Medicaid does pay for this but they're not paying for the paper because of the billing problem. Just trying to really.
We had discussions about this at the Rare Disease Advisory Council, and according to Henry Littman, they consider the fee bundled into their per diem under the Medicaid rate, and if it were recognized as a separate test, they say that they would enter into negotiations such that the per diem would go down and the test rate would then be present. And that's fine. That's their process. I'm perfectly happy for them to go through the process, and that really has nothing to do with the bill. What we just want is for the test to be recognized as a test and billed as such.
Thank you.
Anyone else? The motion is ought to pass, made by Representative Marsh and seconded by Representative Merchant. And would the clerk please call the roll?
Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Upton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Olson, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Kofal,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Kirk,
Yes.
Representative Soloway,
You're on mute.
Representative Soloway,
Yes, yes.
thank you. Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson,
Yes. The bill passed 21-0. Any objection for it to go on to consent? We close executive session and move on to House Bill 187 relative to the emergency powers of the Commissioner of Health and Human Services, Representative Mark, prime sponsor. Would you introduce your bill, please?
Thank you, Mr. Chairman. I am pleased today to offer for your consideration House Bill 187 relative to the emergency powers of the Commissioner of Health and Human Services. And I will remind the committee that I did send out an amendment last week. I believe it's 0161H, which I intend to be introducing at the same time as this bill. This bill does not address the governor's emergency orders. Other bills do that. I don't think they'll come to our committee. This bill addresses emergency orders from the Commissioner of the Department of Health and Human Services, of which they were 2, and they come under a separate RSA, that's RSA 21P. On April 3rd, the Commissioner issued an emergency order regarding the prescribing and distribution of chloroquine to treat COVID-19. On September 1st, she rescinded this emergency order. The bill also deals with various powers under the public health and infectious disease laws. Let me go through the bill and hit the highlights. Page 1, lines 13 to 14, you will note that we strike "and any other law to the contrary." As some of you may be aware, certain members of my family fell victim to the Holocaust. The role doctors and nurses played in the Holocaust is exceedingly troubling. I am troubled that current law allows emergency orders in New Hampshire to supersede certain criminal laws. Not that I believe our commissioner would ever do that. So in principle, I think we need to strike those words from the statute. Page 1, lines 17 through 23, you can see the current law, which I believe was appropriately used to limit the distribution of hydroxychloroquine under the emergency order. The commissioner identified a shortage and she took actions to prevent it from affecting patients. But I'm not convinced that the legislature intended to give the power to the commissioner to prevent the prescribing of a drug that medical professionals had reason to believe might be effective. Changing restrict to prioritize and adding lines 24 to 25 in the belt and suspenders approach we've all become accustomed to clarify that the legislature is not granting that power. During bill drafting, the need for input into the vaccine distribution plan became evident. Reviewing the statute, I saw that we had an existing ethics committee, so I called John Williams and asked who was on it. He told me that this had been put in place at the previous pandemic for H1N1, but there were no current appointees. The governor subsequently reconstituted it. To be ready for the next pandemic, we reference that in lines 26 to 29, and I will discuss that further in section 3 of the bill. Page 2, lines 16 and 17, we're changing none of the language of the existing statute, but we are changing the reference. This is very important, actually. The language of the current statute clearly states that an individual may refuse treatment, but the current reference, RSA 141C 15(6), states any law enforcement officer shall take such individual into custody and transport the individual to the place or facility where the treatment is to be provided. Those two things contradict each other. RSA 141C 16 clearly gives individuals the right to refuse treatment and remain in quarantine, and I believe appropriately so. The other reference, RSA 141C 20C, are the current grounds for refusing vaccination and is an appropriate reference here. Page 2, line 29 and on is new language. One of our objectives, by our, I mean one of the objectives of House leadership, is to make sure that emergency orders are subject to legislative oversight. We currently have an HHS Oversight Committee, so we do not need to create a committee for this purpose. With a current membership of 5, a 2/3 vote would be 4 out of 5 members. That's an exceedingly high threshold. Chairman Pearson and I met with John Williams and others from DHHS last Wednesday, and we agreed to language clarifying that legislative oversight for orders under sections 5 and 6 shall be by the Ethics Oversight Committee, which we will discuss in section 3. That was the origin of the amendment that I circulated last week. We agreed at the same meeting to delete section 2, as people subject to orders already have defined rights to appeal. So I will just ask you to ignore that section. We're going to remove it by amendment. Section 3 of the bill is a rewrite of the Ethics Committee established for H1N1 to accomplish 5 things. 1, the committee should actually have appointees and exist when it is needed. By appointing legislators to the committee, we can make sure that will happen. Number 2, the committee should review investigations, orders, and treatments ordered to make sure they've been done appropriately and fairly, as some have questioned whether that is in fact the case. Number 3, last year's committee members know we were contacted by an individual representing a disabled individual who felt that their rights were violated as a mask order prevented them from getting needed medical care. We discussed having a commission to address such concerns. This ethics committee, already in statute, seems a logical place to address such concerns, and we've charged them with doing so. Number 4, the governor used the State Disaster Medical Advisory Committee to reconstitute this ethics committee to create the vaccine distribution plan. It was appropriate and it was well done. There is currently no data to suggest that the current vaccines prevent the spread of disease. The data shows that they prevent serious illness in people who get this disease. If there were such evidence, it would be debatable whether the vaccine should first be deployed to protect the most vulnerable members in our society or to interrupt the vectors that spread disease. The intent is that when plans have to be made for the next pandemic, the appropriate discussion happens by an appropriate body. Number 5, the department felt that the police and fire members of the prior incarnation of the Ethics Committee did not bring a lot to the table, and they asked that we remove them from the committee. The amendment we agreed to on Wednesday rewrites the section to be less burdensome to the Ethics Oversight Advisory Committee by using aggregate and de-identified data. I believe with the current surge in COVID-19, that burden would have become burdensome with the number of cases going forward. Last, we've been in discussion with the Speaker's Office regarding the membership changes to HHS oversight in last year's House Bill 1245 on page 9. We do not believe those changes were intended to remove minority party input from HHS oversight, and the amendment adds a section to undo those changes. And I thank Representative Pearson for that language. Thank you, and I'll be glad to take questions.
I have a question, Representative.
Yes, Representative Nelson.
Two questions, Representative Marsh. In an emergency, a dirty bomb or something like that, and you don't have time to gather people together through this committee, what would happen? Outright emergency, the decision has to be made within a couple hours.
Nothing would be different compared to the current procedure. All the legislative oversight by this bill is done retrospectively and after the fact. So therefore, we have put it in place that whatever decisions were made will be looked at to make sure that they've been done correctly and fairly, but nothing would prevent emergency actions from needing to be taken in a short period of time. So we don't want to interfere with the operations of the department in any way.
Thank you.
Representative Weber.
I did not have my hand up. It's Representative Nutter Upham who is raising her hand. And she's raising her physical hand rather than one of the ones on the screen.
For Representative Nutter Upham, sorry.
Oh, thank you for taking my question. Representative Marsh, I have the original bill and your amendment, and there was I just want to make sure, is there any place in this bill that forces someone to take a vaccination?
There's nothing in the bill that forces anyone to take a vaccination. The Commissioner of Health and Human Services is currently allowed to order treatment under the infectious disease statute. And not that I believe she's ordered anybody to have a vaccination. So that is currently allowed under current law. And she would continue to have the ability to order a treatment under the law as amended by this. However, we would clarify the fact that a person so ordered would have the right to remain in quarantine and refuse treatment. Whereas, as I pointed out in my testimony, there's currently there's conflict between the language in the bill and the statutory reference, which would not allow that to happen. So I think that the overall intent of the bill is to support the right that individuals have a right to refuse treatment, although they may need to remain in quarantine if they refuse treatment for the protection of the public.
Okay, thank you very much for clarifying that.
Anyone else in the committee? The chair recognizes Melissa St. Cyr from the Department of Health and Human Services, who's going to speak against this. And the chair recognizes you to speak.
Thank you, Mr. Chair and members of the committee. For the record, my name is Melissa St. Cyr. I'm the Chief Legal Officer for the Department of Health and Human Services. And we did work with Representative Marsh and others on the committee to adjust certain sections of this bill. And there is one section that I think we still have some concern with. And I would like to actually turn my time over to Trish Tilley. I certainly can speak after she's done, but Tricia Tilley is the Deputy Director of, for Public Health. And she's going to raise her hand and take my time if the committee will allow.
That is acceptable to the chair, and the chair recognizes Patricia Tilley to speak.
Good morning. This is Tricia Tilley. Can you hear me?
Yes.
Great. Good morning. Thank you for the opportunity to speak about the fundamental powers of the department to control, mitigate, and prevent infectious disease during public health emergencies. As you know, my name is Patricia Tilley, and I'm the Deputy Director of the Division of Public Health at the Department of Health and Human Services. These powers to isolate, quarantine, or control access to an exposure are designed to protect the public, to protect you and me, and by preventing exposure to people who have or may have a contagious disease or places or conditions that are unhealthy. The Commissioner also has the authority and duty to control and potentially ration the use or sale of life-saving pharmaceuticals, and to prioritize which groups may have access during a public health emergency, as described by Representative Marsh's introduction. These powers are designed to be used sparingly and only in extreme cases. As Attorney St. Cyr can better explain in the details of the legal language, there are current safety nets for due process already built into the statute for individuals directly impacted by an official order. Individuals may request a hearing in Superior Court in accordance with New Hampshire RSA 141C, as Representative Marsh also noted. Never in our lifetimes have these powers been so visible and so needed to the extent that we are seeing today. The Commissioner's authority is an important tool in our toolbox to swiftly control outbreaks and disease, and we have used the expertise of epidemiologists, physicians, and others to help guide us through these complex ethical decisions. Even in the emergency we are currently experiencing, there have only been 2 official orders under P21 made by the Commissioner of DHHS. We have worked closely with the sponsor of the bill, and we welcome the notion of review by Joint Legislative Oversight Committee, as well as the Ethics Oversight Advisory Committee, to review patterns and to make recommendations. We understand that it is not the intent to create a committee by which swift and urgent decisions are made in real time to keep the public safe or to routinely overturn these emergent decisions. We all agree that the privacy and health information of individuals must be maintained. We look forward to the opportunity to working with committees as described in the bill, but we are still concerned about the ability of Joint Legislative Committee to overturn decisions made by the Commissioner. Attorney St. Cyr will be able to walk us through the details of the legal language in both RSA 21P and RSA 141C. It's important to keep in mind the difference in the types of orders that are made. So we have one set of orders that have been made through the emergency powers, as Representative Marsh described, that talked about the prioritizing of pharmaceuticals. And then we have another set of orders of quarantine and isolation that are generally fall under RSA 141C. And those orders are related to keeping people safe from infectious disease and ordering folks to quarantine or to potentially to receive treatment if not quarantine. So I'm going to hand the time back to Attorney St. Cyr. She can point to the specific references, but we wanted to come today and say that we appreciate and we are willing to work hand in hand with the sponsors of this bill. We think that there's an opportunity for us to move forward, but we still have concerns about the ability to overturn decisions of the Commissioner. Thank you.
Representative Marsh, do you wish to speak at this time or after Councilor St. Cyr speaks?
Let me just say that we did meet, and I believe that the department and those of us who met with the department agreed on almost every point. The only issue that we did not reach agreement is on page, it's on page 2 of the bill. It's on page 3 of the PDF, line 31. And that would be the language that says, and may be rescinded by a 2/3 vote of that committee. And at the end of the day, this is a balance of powers issue. Either the legislature has the right to say no when something is extreme by a supermajority vote. It's a very high supermajority vote, actually, or they do not. And that's a fundamental policy decision that needs to be decided. And I do not anticipate that the department will ever agree with us on that. And we'll just continue to discuss this going forward. So thank you very much.
Point of procedure, Mr. Chairman.
Guys.
Normally, we have a sponsor testify and then other people testify, but I don't remember any time in the past when the sponsor has been recognized to answer each subsequent person as they testify. That would happen either at a subcommittee meeting or at an executive session. And I think it's a bad precedent to be setting to allow the sponsor second dibs and third dibs and fourth dibs. It is, of course, up to the chairman, but I just note that for the record.
Thank you, Representative Weber, duly noted. The chair recognizes again Councilor St. Cyr.
Thank you so much, Mr. Chairman, members of the committee. So for the bill, Representative Marsh is correct. It is paragraph 8, where the committee would have the ability to rescind an order that was created by our commissioner through obviously the use of experts and otherwise to, we would like to change that to recommendations. The Oversight Committee right now for Health and Human Services obviously is the Legislative Oversight Committee for the department. The statute specifically says that it's to support cost-effective, comprehensive, coordinated care. It's also to promote greater efficiencies, consolidating and centralizing reporting requirements and other responsibilities of the department to avoid duplication in efforts. And so I just want to note that typically our relationship with Health and Human Services Oversight Committee is for that purpose. We do a lot of reporting to them, and they definitely are involved in the work that the department does, providing recommendations. And so we think that that would be an appropriate amendment to this bill if that we could change that rescission, being able to rescind our experts' decision-making around this to just being recommendations made to the commissioner by the Health and Human Services Oversight Committee in that paragraph. I think our other concern, other than just that language, is that it seems to be very broad. It says any emergency order issued under this section. And when speaking with Representative Marsh, he made it very clear that the expectation wouldn't be to review every order, and that paragraphs, what was previously paragraphs, or maybe they still are, paragraphs 5 and 6, where it's talking about ordering somebody to go through some type of medical treatment, as well as compelling an investigation if we're investigating a facility for not doing appropriate care or whatnot around the emergency, that those two would kind of be carved out in the amendment. Those two would be carved out and they would be subject to oversight by the Ethics Committee. But I also think that other than just those two paragraphs, there are other things within the 21P53, which is what we're amending here, that there are some powers, just specifically paragraph 1, where the commissioner has the responsibility and authority to carry out all public health activities within the state. If while carrying out all of her public health activities, her at this point, that those would be subject to rescission. Any decision made under paragraph 1 would be subject to rescission. And I understand from Representative Marsh that that's not the expectation, but I do believe that currently as drafted, it is much more broad than what we had discussed. And so I'm just concerned from a legal perspective that there is a breadth to this order or to this bill that would allow for orders to be overturned for essentially anything that the commissioner has a responsibility for. So that's just all I have to say. I'm certainly happy to answer any questions that you have.
Any questions from the committee? Representative Cushman.
Thank you, Mr. Chairman. Representative Marsh, can you please just clarify for the committee exactly what your amendment changes about the bill? Like briefly, just exactly what is different?
Representative Marsh.
Yes, I'm right here. Just let me bring the amendment up on the screen. It'll take me a second to do that. Okay, I now have on my screen Amendment 0161H to the bill, which I circulated to the committee last week. If anybody doesn't have it, send an email and we can do it. First of all, we deleted section 2 of the bill, which would have given more appeal rights to people who were subject to emergency orders under paragraphs 5 and 6 previously mentioned, because we realized that they already have those appeal rights. And so therefore that section of the bill becomes unnecessary. Second, we added a paragraph 9 after paragraph 8 being the paragraph that has the rescinding clause in it that everybody is questioning about. And paragraph 9 specifically carves out orders issued under paragraph 5 or 6, as Attorney St. Cyr said, and assigns that oversight to the Ethics Oversight Advisory Committee, which is precisely what she said. Then we moved what was previously section 3 of the bill up into section 2 because we had deleted section 2, and we reworded the charge to the Ethics Oversight Advisory Committee to make clear that these that their oversight was being done in aggregate with de-identified data, and that language came from the department, and we agreed to it entirely. And the last thing is we added a section to the bill to change the membership of the Health and Human Services Oversight Committee because a number of us separately have realized that that may be problematic for a great many reasons. And this is the only bill currently in the legislature, to my knowledge, whereby it would be germane to change the membership of the Health and Human Services Oversight Committee, because we're talking about a charge to the Health and Human Services Oversight Committee. So that, very briefly, is what the amendment does.
Point of order again, Mr. Chairman.
Yes.
I believe it was the department who was testifying, and we have now had the sponsor of the bill, helpful and clear as he is, and I applaud him for that, has now testified 4 times on the bill. Questions as they come in during hearings should be only to the person who is currently testifying. And when we get through all the testimony of all the people who want to talk to us, that's the time for us to have the discussion among ourselves about clarifications, changes, and other things. But it is inappropriate to have the bill sponsor testify repeatedly. Thank you.
Again, duly noted. Thank you. Representative McKay. Thank you, Mr. Chairman. Representative Marsh introduced the amendment. I haven't heard a motion to introduce this amendment. He was attempting to explain it, lest when we go through the bill, we read things that won't be there.
My concern is that we're discussing something that's not in front of us. I'm not talking, procedurally. But I think the proper thing would be for him, because I like the amendment, that it should be actually presented to us as an amendment.
I believe in the exec session it will be. Let me.
And if I may, Mr. Chairman, we have always allowed sponsors to bring an amendment with them when they presented the bill initially and to run through it as part of their initial presentation.
Christina, please bring up Mr. Michael Walsh. Thank you.
If Mr. Walsh is available, would you please raise your hand?
Mr. Chair, I had my hand up for a question to the previous witness.
Let's see if Mr. Walsh is here, and if not, I'll recognize you, and if he is, I'll take you next.
I do not currently see Mr. Walsh.
In that case, the chair recognizes, it sounds like Representative Knurr.
Yes, sir. Yes, my question is for Melissa St. Cyr. Her comment toward the end was she felt that this was too broad. My question is, can you give us some guidance of how it might be narrowed in a way that would be acceptable to DHHS?
Yes, thank you, Representative Kinner, for your question. We believe that the rescission makes the power too broad, the ability to rescind. So if the paragraph was adjusted, that any emergency order issued should be subject to review by the Joint Legislative Committee and recommendations made to the commissioner, that would be acceptable language and would obviously stave our concerns, but we would welcome recommendations by the commission to hopefully give us any feedback related to orders that may have been issued by the commissioner that they feel were not done appropriately, didn't take appropriate information or whatnot. And so that would be our recommendation.
Any follow-up?
No, thank you.
Welcome. Anyone else in the committee with a question for Mr. St. Cyr? The chair then recognizes Kevin Casserly, who wishes to testify.
Chair, were you waiting on me?
I didn't understand you. Say again?
Were you looking for the next speaker?
I was calling on Kevin Casserly. If he is not present, then is he present?
I do not see him. If
Then
you are there, okay.
Then the chair recognizes Heather Evans, who has signed up to speak.
I do not see Ms. Evans.
That exhausts the list that was printed out for me earlier this morning. Is there anyone else from the public who wishes to testify who has signed up since then?
We have Thomas McLeod.
The chair recognizes Thomas McLeod.
Yes, Mr. Chairman, my name is Thomas McLeod. I reside in Mount Vernon, New Hampshire. I am the chair of the Liberty Defense Fund in New Hampshire and the part of the leadership team of Health Freedom New Hampshire. Today, I'll testify as a member of the public. Mr. Chairman, the amendment that I have here appears to address the main concerns I had with the bill. In particular, the concern was the original bill appeared to make court jurisdiction discretionary because of the words, if the petition is granted. Now that section has been removed and it defers to the original language in 141C. So I strongly support the bill. I feel it's a necessary clarification of the existing powers of the commissioner, and I also support the amendment. And with that, I'll end my testimony. Thank you.
Thank you. Would you accept a question from a committee member?
Absolutely.
Does a committee member have a question for Mr. McLeod? Sir, for your testimony. Christina, are there any other people who wish to speak?
I see no raised hands.
Thank you very much. And with that, I close the committee hearing and I open an exec session on this bill. And I should have done some of the things I did before, and with apologies to the committee and appreciation to its former chair. Do I hear a motion? Representative Marsh, would you like to move your bill?
Yes, Mr. Chairman, I will be glad to do that. I will move ought to pass with amendment, and the amendment number is 0161H.
We're first going to move, I got this wonderful instruction. The motions are first, move to adopt the amendments. So that is the motion I take now, I believe.
Yes, so move.
Thank you. A second? I saw.
Second.
I saw Representative Soloway. Now, I'm going to discuss this, but Representative Morris, anything you wish to add?
I am not certain that the committee really wants to exec the bill at this time, but I'm satisfied personally with Amendment 0161H. I believe it addresses all of the department's concerns, with the exception of their one concern that they do not wish to have the oversight committee to have the authority, even on a supermajority vote, to rescind an emergency order. And I believe that to be used very occasionally and by a supermajority vote, it is an appropriate a power for the committee to have. So I would prefer that the bill move forward with that clause in place.
Anybody else wish to speak to the amendment? Representative McKay.
My general feeling is that there is some value in this, and then there are some problems with this. I would prefer in the executive session that we retain the bill rather than vote either way.
Representative McKay, we have a motion on the floor about the amendment, but then when it is time to consider the bill as amended, that I believe then that would be a good time for that.
I just want to sneak it in.
You get that in there, but thank you. Yes, Representative Gay.
I don't know if I'm supposed to thank you for taking my question or my statement.
Thanking me is always a good thing, but I don't know either, but go ahead.
Okay. The impression I'm getting is that the amendment did a good job of removing some things that felt onerous, but it retains the real point, the whole point that I can see of this bill is to give legislative oversight to decisions. Earlier, even though it was meant in the best and motivated by very high intentions, one of the statements, one of the decisions by the commissioner this year outlawed the use of a medicine that has since been proven to be effective. And so that really should not have stood. This is the only way to prevent that from happening. So I totally support the amendment because I totally support the bill.
Thank you, Representative. Anyone else wish to speak?
Mr. Chairman, Representative Weber has her hand up.
Okay, I can't see it from here. Representative Weber?
Thank you, Mr. Chairman. I was just wondering if we had time to work on the bill, or is this a bill that needs to be exec today?
It does not need to be exec today. My concern, and I have to balance not wishing to do rush jobs with the fact that not only was the calendar extremely tight, we still do not know if we're going to be meeting in any capacity tomorrow. I don't know how many days I'm being assigned, so there is a concern. I might underscore what people have been saying, that really it is, do we or do we not believe that with a high bar threshold, the oversight committee should have some say in rescinding? I think That's it. That's
Right,
what-
I understand what the concerns is. I was just trying to find out if we had time. But I realize that this vote is on the amendment. And so I will state that I think the amendment solves certain issues that have already been raised to everybody's satisfaction. So I am going to state that I will vote for the amendment. And then when we get to the bill itself, we can discuss whether we want to go forward or whether more work needs to happen.
And may I will ask you a question, please, because I couldn't find it in Mason's. I'm a co-sponsor of the amendments. Do I, as co-sponsor / chair, have the right to speak for about 30 seconds?
Absolutely. When we get to executive session, everybody can speak, and the chair, or at least the former chair, often drafted amendments and spoke to them. And it's only in the hearing that we are deferential to the rights of the public, so that the sponsors are not, given both the opportunity to be a sponsor and a questioner.
Thank you for that. And again, I appreciate what you said earlier, and I apologize for shouting over you.
It's quite all right. But you go right ahead, and whatever your opinions are, everybody has a right to their opinions in an executive session.
As my mother used to say, you have the right to be wrong. All right, here's my 30 seconds on the amendment. A 2/3 vote is a high bar. And in the amendment, we have given some appointed authority specifically to the minority leader, which wasn't there before. Secondly, at least some of the oversight committee people are medical people in some capacity or another. So it is not an oversight committee being made of farmers and mechanics and speaking to medical people. It's not quite that. And then thirdly, this is a safety valve. I've got 2 pages of people who signed in favor of this right. Citizens or the citizens legislature to have the ability to overrule a government edict. Quite honestly, safety valves are very important, because if you put too much steam, pressure in a container with no vent, eventually it might blow. And I don't want that. So to have, at least on paper, the knowledge to people that it is possible for the citizens to say, wait a minute here, I think may provide a safety valve without it being, the inmates taking over the asylum part of the image. So for that reason, I not only support the amendment, of course I do, I wrote it with Representative Marsh, and after we talked to DHHS. Representative Coppola, you had your hand up, please.
Yes, thank you, Mr. Chairman. I believe that this amendment moves the bill in the right direction. I also agree with Representative Gay that to do anything to change the existing measures in the bill and the amendment for a 2/3 supermajority would essentially remove the fundamental purpose of the bill, which is to provide legislative oversight. For what it's worth, I'm actually not totally comfortable with the idea of a 2/3 supermajority. I will vote for the amendment, and I will vote for the bill because I think that it moves things in the right direction. I will also point out that the 2/3 majority, because there are 5 members, actually is a de facto 80% majority. So I think that as it is currently written, it is entirely reasonable to ask for that. I think it would be even more reasonable to ask for a smaller number, but I would support the amendment as it is. I think a lot of work has gone into this bill. I think it moves things in the right direction, and I support the amendment.
The ability of the oversight committee to rescind kicks in simultaneously with the increased number of people. So there'll be 7, not 5. Maybe you can do the math in your head, but 2/3 of 7
Okay, thank you for the clarification.
is less. Others, Representative Cushman.
Thank you, Mr. Chairman. I just want to speak in support of the bill, and as amended. In the amendment, sorry, I support the amendment, and I think it's a good start. It's a step in the right direction to rebalance the powers here.
Others. On the amendment, 0618, House Bill 187. The clerk may call the roll.
Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Copal,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirp,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes. 21-0 on the amendment.
Mr. Chairman,
Representative Moore.
I make a subsequent motion of ought to pass as amended.
OTPA, is there a second?
Me.
I saw Representative Cushman first. Representative Cushman.
Second.
Now we can discuss the bill as amended. Representative McKay.
Thank you, Mr. Chairman. Could I hear in the amendment, the actual language that increases the members of the Health and Human Services Oversight Committee? Don't have the amendment.
You don't have the amendment, do you? Okay, does anybody have an extra amendment? Are there amendments over there? It would be 061H. Let's see if we've got it.
Mr. Chairman, that would be 0161H.
0161H. Okay. This is what you did vote on.
The amendment here,
Okay, thank you very much.
Page 3, line 32.
Page 3, line 32 in the amendments. To this question.
Well, the whole section. 2 from the Senate, 5 from the House.
Mr. Chairman, would you like me to just read it?
I think he's found it. But you can read it out loud too.
I would appreciate it because I'm having a problem.
The changes are, as you know, or as you may not know, in one of the omnibus bills, the membership of the Health and Human Services Oversight Committee was reduced from its former 5 House members to 3 House members, which creates enormous amounts of concern in terms of representation, both from, the various committees and also for the minority. And so this would put it back. It leaves the Senate at 2, which is where the Senate wants to be. It would have 5 members of the House of Representatives, 3 of whom are from Health and Human Services, and 1 from the House Finance Committee division responsible for Health and Human Services, which is essentially as it is now, but with the clarification that it's from division, I think it's 3. And then 2 members of the House of Representatives, 1 of whom shall be appointed by the Speaker and 1 of whom shall be appointed by the leader of the minority party. And these 2 are going to serve as alternates. So at a time when we cannot get a full complement, which is practically every meeting for one reason or another, there are 2 dedicated alternates to sub in for the 5 members that we have now. So we're basically returning it to the way it was, with 5 members, 1 of whom's going to be from finance and 3 of whom are protected from Health and Human Services. And then we are adding the 2 alternates, 1 from each party, so that they can be appointed if needed. Is that a fair summary, Representative Marsh?
7. Isn't it 7?
Read it.
And there are also 2 senators. We didn't change that.
So there are 7. Yes.
So there are 7 people in all, which means you need 5 to vote to overthrow.
That is the super majority, super.
Anyone else on the committee?
I believe Representative Salloway was asking a question. No? Sorry.
See him. I recognize Representative Salloway.
He's waving off.
Okay, I still recognize him. Yeah. Anyone else? Representative Bushman,
So just to speak on the bill now.
please. As amended.
As amended, I support this bill. We've seen some overreach during this emergency. I feel we've seen the rights of prescribing physicians to order medications that they deem appropriate to treat patients be restricted. We've seen that the legislature has had little to no power over emergency orders. And I personally would like a lower majority on the oversight committee, but I think that this is a good start. So thank you.
Thank you. Anyone else? The chair recognizes Representative Bolton.
Thank you. I am also in support of this bill as amended for the reason that the chair gave of it being a safety valve for the people who are so frustrated that they have no control. And that is what I have seen out our way develop into anger. And just knowing that there is going to be a safety valve, that they actually have some way of recourse, will bring a whole lot more comfort and will dial down the anger and frustration that has been felt.
If there's no other questions or statements,
Representative Snow has his hand raised.
Representative Stoll, there you are.
For purposes of clarification, we now have 5 members and 2 alternates. Are the 2 alternates clearly identified as alternates? And do they sometimes show up at meetings and find out that everybody else is there, so there's no purpose in their being there?
I see the purpose of the alternate as if the chair of the oversight committee understands the day before, somebody's going to be on vacation, somebody's sick, then an alternate would be asked to come in to fill that spot.
So ordinarily, okay. So then the 2 alternates are clearly identified, but they would not attend a meeting unless invited to attend and would not participate in other meetings. Is that correct?
I would invite them to attend.
And participate, but not vote.
I would invite them to participate and only vote if they take the place of one of the statutory members, to be there, their wisdom and everything except voting.
And they are clearly identified, so they know they may not get to vote.
Yes.
Thank you.
Shapiro.
Thank you, Mr. Chairman. First of all, I want to thank Representative Marsh for being so attentive to detail and so attentive to explaining the detail, which I'm still not sure I understand, but I appreciate it. Also for creating the high bar for overturning an emergency decision by HHS. Given my appreciation for those things, unlike some of the other people who have spoken, I probably am more concerned about the lack of forceful guidance from our state government rather than overreach. And I understand we have different ideological points of view. I think there are times when the governor could have been more forceful in terms of emergency orders to keep the state safe. I have a specific question that's I'm not sure is germane to the specifics of the amendment and the bill, but it did get brought up initially, and I think it's maybe part of the subtext of the bill, which is the whole issue of the potentially ordering vaccines, creating a mandate for vaccines. And I know that Representative Marsh, you, I think in response to a question early on in this hearing, talked about the fact that if vaccines were mandated, which they are clearly not, and nobody has talked about wanting to do that, as far as I know, you said even if that was the case, that people would have the right to refuse, but that they would be, somehow they would be obligated to quarantine themselves if that was an order. If I'm understanding this correctly, they would be obligated to quarantine themselves. If that scenario even came up, how would that quarantine be enforced, or would it be enforced?
May I respond, Mr. Chairman?
Yes, sir.
Yes, as I stated in my testimony, under existing law and under the law as it would be amended by this, if we do enact it into law, the Commissioner of Health and Human Services retains the right to order treatments. Those treatments include vaccination. Under existing law, we clearly have the statutory language that says that a person has the right to refuse such a treatment. However, the statutory reference in existing law then directs that person to a justice of the peace who shall order the person, there's no discretion given, to be brought in and the treatment be given. So I think it is at least debatable that under existing law, the commissioner could, in fact, mandate vaccines and order whomever she wants to have that done, and there would be very little in the way of recourse. That might be found differently in the courts, but it's at least confusing. If we pass this bill as we have amended it, then it is abundantly clear the commissioner retains the ability to order treatments, but it clarifies the fact that people have the right to refuse treatments and remain in quarantine, which, if nothing else, gives the courts time to rule on the subject before anything is actually done to anyone, which I think is a very sensible measure. We did not remove the ability of the Commissioner of Health and Human Services to order treatments in the first place. I agree with other people that I think that that would be a step too far and interfere with the operations of the department, which we do not wish to do. So this bill was a very fine balancing act.
Representative Weber.
Can I have a follow-up?
Yes, you may have a follow-up. I apologize for not giving you that chance, Representative Shapiro.
That's okay. I certainly think it makes sense to take the contradictions out of the bill, that it doesn't make sense to say that somebody can refuse treatment, but then law enforcement in some way can have them not refuse treatment. So I think taking the contradiction in law is out of the bill, out of law is important. But in the scenario you described, if someone was to refuse, if an order was given for treatment and a citizen refused treatment, what would the measure to enforce quarantine be, or would there not be any?
Representative Marsh.
The measures to enforce quarantine are not addressed in this bill in any way. Honestly, I do have a bill in relative to health officers that's going to municipal and county government. My opinion is that arguably it could have gone to this committee, but it's going to municipal and county government, which will involve local health officers more directly in enforcing quarantine orders. And I agree with you that that is a very important issue, but it is not a subject of the bill before you right now.
Thank you very much.
Representative Weber.
I think my comment probably relates back to Representative Snow's question about the composition of the Health and Human Services Oversight Committee, which of course is a whole different issue from the committee that would be making these decisions. I was just going to point out that we have any number of committees like JALCAR already who have appointed specific alternates. And generally speaking, they either go to or monitor all the meetings so that they will be familiar with the actions that have happened in the past, and that they will be ready to step in if they need to step in. But it's not a new concept for a number of the committees that we have. So I just wanted to clarify that. Thank you.
Representative Acton.
Yes, thank you for letting me speak. I come at this, I'm in support of this bill, and I come at this as somewhat of a moderate on the issue. I have no problem wearing my mask. I'm already set up to get my vaccine in March. I generally supported the governor, but in this case here, it's not a conceptual thing we're working on. The decision to ban hydroxychloroquine was a very questionable act. There was a lot of research that shows that this was working, and it appeared to be politically motivated. And so I think we definitely need some type of checks and balances from the legislature on decisions like this, because we don't know what kind of pressure is being applied to the Health and Human Services Department from the federal government or whatever other entities. We need to be able, as a legislature, have a say in big decisions, because hydrochloroquine may have helped patients who didn't get that help, and that was a really questionable call. So I hope we can pass this. Thank you.
Thank you. Representative Snow.
Yes, this is really just a follow-up to my last question. We now have 7 members of the Health and Human Services Oversight Committee. If 4 of the regular members and both alternates show up, who chooses which of the 2 alternates will now be the voting member? That could lead to some criticism if somebody feels the wrong one was chosen.
You could indeed. I believe that would be the choice of the chair.
The choice of the chair.
Yeah.
Thank you.
Representative Woods.
Thank you, Mr. Chair. Did you say Representative Woods or?
I did.
Oh, thank you. This is just a sidebar question almost. Was there consideration on the Ethics Committee to have a medical ethicist on board? Not that the folks identified wouldn't act ethically, but sometimes another dimension is brought into consideration by a real formal ethicist.
May I answer that question, Mr. Chairman?
Yes, you may.
Yes, the Department of Health and Human Services did mention that, but then they informed us that they were not prepared to bring the language forward at this time, and that they were perfectly content with bringing that language forward in the Senate, and perhaps we will continue to negotiate on the membership of the Ethics Oversight Advisory Committee.
I brought that question too because I have taught ethics, and there are sort of protocols in doing ethics that sometimes coincide with common sense and sometimes don't. So I brought that point too. I would like, not in this bill, but going forward, to look again at what the ethics committee will bring in as experts when they're discussing ethical questions. So Representative Woods, I'm tracking with you. Thank you. Representative Merchant.
Thank you, Mr. Chairman. Wanted to commend Representative Marsh for what you're doing. One of the things I just wanted to bring to the attention of the committee, when we had the hydroxychloroquine issue, one of the unintended consequences that we had was that many patients that were on chronic therapy for rheumatoid arthritis, because all of a sudden the supply chain, a drug disappeared literally. And patients who needed it routinely for the underlying long-term chronic condition were faced with a consequence. There was no alternative to it at that point in time. So Representative Marsh, I totally support a physician having the ability to prescribe based upon the patient. However, I do have a concern as a pharmacist about how do we prioritize drug therapy and the availability of those drugs in order to take care of the patients, how we prioritize that accordingly. Because unfortunately, one of the ways we dealt with it was the restriction, which then put a halt to it. So I'm fundamentally okay with prescribing it, but how do we help the pharmacists in the community to be sure that patients who are on chronic medications like this are in fact able to get the medication?
Thank you, Mr. May I respond?
Yes.
Yes. I think, as I made clear in my testimony in this bill, what the Commissioner of Health and Human Services did to prioritize the distribution of chloroquine and hydroxychloroquine, I think was totally appropriate and was well done. That being said, I think that for her to say that one could not prescribe the drug, which would, for instance, allow a patient to order a drug from a mail order pharmacy out of state, was inappropriate and an overreach, because there was never mentioned in this statute the ability to restrict prescribing. So I think we're, again, trying to walk a very fine line here, and we've done our best to thread the needle.
Thank you.
Representative Cushman.
Thank you, Mr. Chairman. I just want to speak to a concern of one of the representatives a little while ago about enforcement of quarantine, worrying that there was no way to do such, but it is already written into statute that they will use the least restrictive means possible, and that a person should be able to choose where they have their quarantine. But if it is written into RSA 141C under section 13, that if anyone refuses to cooperate with the quarantine orders, the commissioner may issue a complaint that's sworn before a justice of the peace, and they can give it to any law enforcement officer, who then has the ability to take that individual into custody and transport them back to where they were to be quarantined. So just to alleviate that concern.
Thank you.
It's in there.
That's helpful. Anyone else? The motion is ought to pass as amended. House Bill 187 amended by 161H. Ought to pass amended as amended. Moved by Representative Marsh, seconded by Representative Cushman. Would the clerk please call the roll?
Representative Marsh votes yes.
Representative McMahon.
Yes.
Representative Nelson.
Yes.
Representative Acton.
Yes.
Representative Gay.
Yes.
Representative Cushman.
Yes.
Representative Folsom, yes. Representative Kelsey.
Yes.
Representative King.
Yes.
Representative Kofalt.
Yes.
Representative Weber.
Yes.
Oh,
Representative McKay.
No.
Representative Snow.
Yes.
Representative Knirk.
Yes.
Representative Soloway.
yes.
Representative Cannon.
Yes.
Representative Nutter Upham.
Yes.
Representative Shapiro.
No.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson,
Yes. 19-2, unless the committee successfully talks me out of it, I'm inclined not to put it on consent because I think
Yeah.
the issue is such that we should discuss it on the floor.
Mr. Chairman, I agree. It should be on the regular calendar.
As do I.
Yes.
Thank you. I would have objected to consent as well.
Regular calendar. Before we have a 5-minute break, somebody from the fourth floor brought down Representative Knert's amendment to the next bill that we will be hearing. And everybody in the room here has received a copy of Amendment 0032H. Have the people at home received it?
Mr. Chair, may I speak that I had sent it out by email a couple of days ago, but seeing what happened in the previous one where some people didn't have the amendment, I sent an email, sent it over and asked them to please come down with a few copies for the people that were there in person. Everybody else should have it on their email.
Well, I didn't want to proceed if we didn't know where this was going. Thank you. We will take a 5-minute, we have now finished the executive session. Now we're taking a 5-minute break.
Yep.
Ah.
Ken, you're not muted.
Ooh.
Ooh. You're welcome.
I enjoy you being with us. I do. Careful here on the foot. I see you. It's a tricky one right there. Our sales.
No, it's rolling.
Jesus, it's just, it's anything for sale, man, and above the price.
Well, no, you see it sometimes, it's utilized as by realtors trying to promote a competitive bidding. I call it a pseudo auction.
Yeah.
But notwithstanding that, but the rates where they are, not more for homes.
Yeah.
The affordability issue is right available and it's available now.
You folks in that conference room, just be aware, we can still hear you.
Is it interesting?
Good, well, we're here to help.
My assessed value went way.
Yeah, but the city do a rebound.
I think it's. Well, but that,
So that's to make sure that we can also that the budget obligations fairly based on valuations. But
there's the property tax.
yeah. So that's another, well, as you know, that's all I'm saying. But the heat of the rate, mid 2.5, sometimes depending on what you buy. One of the incentives where you can own it versus renting, it's not What's substantial? Because if I can't qualify.
So I've got 400 units in.
Oh, yeah.
Tend to allow more than people. It's so- it's like a bunch of things considered.
But so you want to do it?
Yeah.
And but can you allow mentally challenged folks to feel you be like overseer as a trauma that happens.
It comes to me eventually.
Just remember, if someone needs a touch, it's here.
The sister and stand up and sitting up, smoking with a head under the snow. I can't stand it. So great. This one police came. Said, do you think you need help?
And that was one of your budgets.
Yeah.
Yeah.
What a challenge. She's trying
The public hearing one.
I don't know. Do you have a break? That's the representative.
Let's just say some other government run. And what a humble is to do.
Yeah.
I'd say, I mean, meeting
That's expensive.
Oh, yeah. I'm glad you offered. That's tremendous.
Well, it sure would be nice if we could move that screen to the middle of the room.
It would.
So much bigger.
I think the problem with that is gonna be the camera. Because when you move that, the camera comes with it.
Can they really see us? Because we're so tiny in that.
Just as well.
They probably see the chairman.
Not very well.
That's okay.
I'll just leave them all three. That way.
I've had it for a while this week, that's why I haven't got back to it. I wanted it like lunch.
Sure, I tried to call you.
Yeah, I know.
Okay, and later I thought, well, that was a dumb thing to say on the recording.
I get 200-300 minutes.
Well,
Yeah. See, the trouble is, if we give money to the Republican and the Democrat, you get even from Hawaii. And there's an emergency and by 3 o'clock, they set up the this crazy stuff. I had enough trouble supporting people in Hampton.
I didn't know you were getting stuff. I was feeling
I
you
just-
from Hawaii.
I have a company that manages my computer. They just threw out 14,000.
Representative Marsh.
Yes.
I just get 150.
Sorry about that.
Hey, there's no way I can read. I tell people,
Beth, I got your email. You don't need to cause feedback.
read.
Oh, so let's talk about it.
Okay.
I don't think so. I think it's just.
Open the hearing to House Bill 604 FN, and would Representative Knurk introduce his bill, please?
Yes, sir, Mr. Chair. Let me just pull it back up here. Okay. This bill will look familiar to those of you who were on the committee last year, and I sent out a rather long and detailed information on it to everybody before so you could review the amendment and the bill and try to make sense out of it. One thing that, oh, I'm sorry, for the record, I'm Representative Jerry Knurk, Carroll 3, Madison, Tamworth, Albany, and Freedom. Now, one thing that COVID-19 has taught us this year is the importance of vaccines and the need for their widespread use. Vaccines really are one of our most important public health tools because they prevent millions of illnesses and save numerous lives each year. What this bill does is to substantially decrease the costs of vaccines to our insurers and hopefully increase vaccination rates. The bill establishes a public-private partnership between DHHS and the insurers to enable the insurers to access a federal program to purchase adult vaccines at about 1/2 of what they normally pay. This universal purchasing program is in bulk and only available to governmental units, not to the insurers individually or the providers individually. This program will allow the insurers, and therefore ultimately all of us who pay the premiums, to save millions in vaccine costs. All administrative costs of this program are covered as this program is designed by the insurance companies. Currently, there are 3 other states that do this: Alaska, Rhode Island, and Vermont. So what this does is this bill extends to adults the already existing very successful program for purchasing pediatric vaccines in New Hampshire. The implementation should be pretty straightforward using the existing things we've learned in infrastructure of that pediatric program. The pediatric program was established in 2002. The insurers are assessed a fee for each insured pediatric life. Those funds are then aggregated and sent to DHHS to purchase the vaccines at the significantly discounted federally negotiated vaccine prices. In so doing, in the pediatric program, the state purchases about $38 million of vaccines for about $28 million, a savings of about $10 million or 26%. These vaccines are then distributed to the providers free of charge to administer to the patients. New Hampshire achieves a very high pediatric vaccine rate with this program. The New Hampshire Vaccine Association is a nonprofit corporation that was created to actually just do the job of assessing and collecting the funds from the health insurers. So in drafting this bill, I used the language of 126Q, which is the pediatric statute, in collaboration with Beth Daly, the chief of the Bureau of Infectious Disease Control in DHHS, Patrick Miller, the CEO of the New Hampshire Vaccine Association, and Heidi Kroll, who represents all of the insurers with AHIP. This bill amends the existing statute to cover the adults up to age 65. After that, Medicare Part B and D cover many vaccines, and we really can't tamper with a federal program in terms of its funding. All of the vaccines recommended for adults by the CDC would be covered. The CDC has already determined those vaccines to be cost effective and recommends them, and those recommendations were sent to you as well in a link. COVID-19 vaccines are not specifically included in this bill because they're not yet on the CDC list, and they're currently being provided at no cost by the federal government. But at some point, the federal government will stop providing those vaccines for free, and they will likely then be on the CDC list, and they would then be covered by this bill as well. And indeed, depending on the duration of immunity that is achieved by the current COVID vaccines, they may become routine boosters done every year, and that might really increase the volume of adult vaccines. That we don't know. The key thing is that the recent experience in the COVID vaccine rollout has demonstrated great demand for the vaccine. So the New Hampshire Insurance Department last year for this bill, that was when it was called HB 1655, they looked at what the cost benefit analysis would be to roll this bill out to adults. They used claims data from 2018. They demonstrated that the insurers paid on claims $8.2 million for vaccine material. That was a billed amount of $13.5 million, but they paid claims of 8.5 because nobody really covers, of course, the billed rate. And they noted that the CDC contracted prices for state vaccination programs are on average half of that is paid for the same vaccines in the paid claims data. So that demonstrates an expected cost savings to the insurers with this program of about $4 million for about $8 million of vaccines. Since the total administrative costs for the adult portion of the program, that's the new portion, are $400,000, and those are fully covered by the assessment on the insurers, there is no cost to the state for this, and the insurers invest $400,000 to realize a $4 million savings, a 10-to-1 return on their investment, so really not a bad deal. Besides that direct savings of the bulk purchasing at a discounted rate, the potential also exists that we might increase vaccination rates. This would result in further savings from the avoidance of medical costs from complications such as hospitalizations for flu and other diseases. Now, those on the committee last year, remember, we passed it out of the committee, we passed it out of House, but it died a COVID death. Even though I was encouraged by some people just to put the bill back in as it was, every bill can be made better by continuing to work on it. So I continued to work on it in the summer and the fall and even in the winter here, and finally reached wording which is acceptable to DHHS, the Medical Society, New Futures, and the insurers. Unfortunately, the work with the insurers was still going on after the bill had been signed off, so I did have to provide that amendment, which is 2021-0032H, which I have sent to you, and that amendment covers some changes we made to satisfy some concerns of theirs. So basically, as far as the language, a lot of times you'll just see the phrase "and adults" added because that rolls it out. There are a few things that are a little bit different, and there's one, I'm going to point out a few that are different from last year. If you turn to page 1, lines 10 to 12, that is different than last year. The current language in statute has to do with calculating the medical loss ratio, which is the percentage of premiums used for healthcare, not for overhead. But that language was superseded by the ACA. When that was pointed out last year, we just removed the language because we felt it was really not necessary. However, given concerns about the potential repeal of the ACA by the Supreme Court, we opted to put that language back in with the introductory phrase that it is in effect unless preempted by federal law. There's another spot that we had to put that language in, and that's on page 2, lines 27 to 30. Again, all those details are in the written testimony I sent to you earlier. There at page 1, lines 17 to 20 just makes it really clear that the DHH costs of administering the program are included in the assessment to the insurers so that the costs of DHHS are covered fully. The reason that's important is a little bit of a kind of sloppy wording when it was passed in 2002 for the pediatric program said administration, and that was interpreted to just mean the actual administration of a vaccine by a provider. And so this corrects that. In 2020, there were concerns raised about the liability risk to the state for any adverse vaccine reactions proposed by particularly 2 vaccines, the polysaccharide pneumococcal vaccine and the zoster vaccine, because they're not included in the vaccine injury compensation program that covers childhood vaccines. Our solution last year was to exclude those 2. Now, the risk of liability for the state is really vanishingly small, as they're really only a purchasing agent. They're basically helping the purchase. And the taking of adult vaccines currently and in this program is voluntary with informed consent obtained. Given the importance of the 2 vaccines, particularly pneumococcal vaccine during COVID, in preventing costly hospitalization and death, we felt that our better solution was to continue to cover all the CDC recommended vaccines, and we inserted language removing liability from the state. That language is already in statute for the New Hampshire Vaccine Association. That language is on page 3, lines 11 to 14. So that just simply mirrors the statutory protection of NHVA only for the state. On page 3, lines 17 to 20, again, reinforce that the vaccine fund raised from the assessment covers the administrative costs. If you turn to the amendment, again, 2021-0032H, it makes the following changes. On page 1, line 17, another spot I just happened to miss the word adults and adds that in. Page 1, line 28, this is on the amendment. I'm referring to the amendment numbers here. Page 1, line 28 of the amendment to page 2, line 5 sets a cap on the DHHS program costs, subject to adjustment for inflation and program volume. There was no cap before. Now, you may notice here that the costs suddenly say 848,000, whereas in the fiscal note it says 364. The reason for that difference is this represents the total DHHS costs for both the pediatric program and the adult program. In other words, this corrects that little bit of a glitch that didn't allow DHHS to put its costs into the assessment in the original pediatric bill. It shifts their administrative costs for the pediatric program to the insurers, who again are comfortable with this language. It's actually a fairly small amount, but nevertheless. Page 2 on the amendment, page 2, lines 11 through 14, are added to ensure transparent accounting of the DHHS program costs. All this is publicly available information, but it is buried away in various minutes and so on in the New Hampshire Vaccine Association, and they wish to have it quite clearly identified. It's a 2-page report that is released and on their website under their annual report. And so this would be clarified as far as what the costs are. The New Hampshire Vaccine Association already puts in their costs, but this would also clarify the DHH costs. Now, there's another issue on page 2, again on the amendment, page 2, lines 17 to 22. That just ensures protection for the insurers that they won't be billed by providers for a vaccine for which they've already paid in the assessment. And then the last thing, page 2, line 23, set the effective date as upon its passage. This is to enable DHHS and NHVA to start working to set up the program, which will take time to implement. We did discuss this last year, and we pushed it way out because we were thinking about having it when the program is up and running. But what we really need with the effective date is allowing the work to begin at its passage. There will be a certain sequence, there's a sequence to the assessment and the processing of the funds and getting it back that will ensure that this won't really be running for a couple of years probably, but they need the authority to move. An analogy on that is the therapeutic cannabis law. It was passed in 2013 with the phrase, upon passage, it's effective. But we know that that program wasn't really finally fully functional till 2016. So this does not imply that immediately this is all going to be happening. It gives the authority. Again, if we look at the fiscal note on the original bill, it's important to realize that 100% of the DHHS administrative costs of this program are returned to DHHS as revenue through the vaccine fund raised by the insurance assessment. It is completely budget neutral. All funds assessed in the year preceding the purchase of the vaccines, as the funds are assessed in the year preceding the purchase, the assessed funds will be available through the New Hampshire Vaccine Association to DHHS to cover the program startup costs. And in the amendment on page 2, lines 3 to 5, we gave authority or ability of the NHVA to assess the startup costs to kind of add a little bit if needed for the first year or two as the program gets off the ground. So in summary, the citizens in New Hampshire are already realizing savings of about $10 million in vaccine costs per year from the pediatric program. If we extend it to adults, that will lead to about another $4 million in savings to the citizens of New Hampshire, and that's to our insurance companies, but through them with saving them money, that'll hopefully save us money in our premiums, and of course, a much greater amount of savings than $4 million if in the future the COVID issues drive more vaccine uptake, either because of COVID itself or people having a better awareness as to vaccines. I want to take a moment, which this is not what I sent to you before, but we all got a bunch of emails in the last 24 hours. Some of them make some statements that are simply not correct, so I will just quickly address those. Again, this bill adds nothing to the budget. The amendment does not increase administrative costs, and it actually decreases the cost to the state because it shifts some of those DHHS costs to the pediatric program, which DHHS currently has to pay, shifts that to the insurers. It makes them clearer and it caps them. There was a comment made that the administrative costs of DHHS can just be increased whenever they want, but that's not correct. There are caps. It's covered. It's controlled. And there was also concern that it doesn't cover age 65. But again, I do not think that we as a state can tamper with federal program reimbursements. That is, those vaccines, many of them are covered under Medicaid D for the actual vaccine, and the vaccines are covered as in Part B as well. This bill does not interfere with your vaccine choices. Vaccination continues to be voluntary. This just makes it cheaper. Concerns about New Hampshire Vaccine Association, the insurers summarized this the best. They were quite pleased with the financial stewardship of NHVA, which has actually decreased their administrative costs over years. And there were also concerns about oversight of vaccine inventories. There is very robust oversight. That's the major source of the administrative costs, and Dr. Daly can discuss that. The there was also concern that it strips your rights for damages related to vaccines. Not true. It only protects the state of New Hampshire. If you wish to sue a provider, you still have that same right. And then lastly, that it's some kind of thing that's going to be damaging and can't be done. 3 other states successfully run such programs. So that's all I have for statements for you. I'd be glad to take questions.
Representative Cushman.
Thank you, Mr. Chairman. What is the federal program that DHHS uses to purchase vaccines? Is that the Vaccines for Children program?
Actually, I'm going to let Dr. Daly go over that because the mechanics of how that part works is much more in her field.
Okay. I have a different question.
I think if Beth Daly were to present now, it would probably answer a number of questions that we could anticipate, but if not, then I'll come back to you. Chair recognizes Beth Daly from DHHS.
Okay, good morning, everyone. Hopefully I'm off of mute now. Can you hear me okay?
Yep.
Great. Well, thank you so much, Representative Pearson and members of the committee. I'm Beth Daly, Chief of the Bureau of Infectious Disease Control at the New Hampshire Department of Health and Human Services. And I'm here today to provide information on House Bill 604. I want to thank Representative Knirk for bringing forward this bill in support of vaccinations to protect and improve the health of our communities. You all know the benefits of immunization. It's considered one of the greatest public health achievements of the last century. And increasing access for adults specifically is important because our immunity from some vaccines received as a child wanes over time, and because some adults are at increased risk for severe infections due to chronic medical conditions, which are increasing as our population gets older and those chronic illnesses become more common. Additionally, vaccinating adults protects the people around them who may be especially vulnerable to infectious diseases and can't be vaccinated themselves, such as small babies who aren't able to get the pertussis vaccine, pertussis or whooping cough, and they can actually go on to die due to that infection. So vaccinating those adults around a baby will help protect that baby as well. So we have some of the highest childhood immunization rates in the country. However, our adult coverage is much lower, and we continue to see vaccine preventable diseases that result in preventable hospitalizations in adults hospitalizations and deaths in adults. So during my 16 years here at the department, we've had an adult die from chicken pox, a newborn baby die from whooping cough after contracting that illness from their unvaccinated parent. And then we recently experienced a very large outbreak of hepatitis A, which is also a vaccine preventable disease with over 300 cases, 200 hospitalizations, and 2 adults who died from that very preventable illness. So just to bring home those public health benefits, not to mention influenza, which you probably know there are 50 or so adults who die from influenza every year in our state, not to mention all the people who die from pneumonia, which is probably due to influenza as well. Currently, the CDC Advisory Committee on Immunization Practices recommends immunization against as many as 15 different infectious diseases during adulthood, and this really depends on your age and any special risk factors you have. We want all adults to get their influenza vaccine every year, as well as their tetanus, diphtheria, and acellular pertussis vaccine every 10 years or sooner. And then you heard about that important pneumococcal vaccine that Representative Knirk talked about. So now I'm just going to switch gears to talk about financing. In terms of how we pay for vaccines in the state, we have that federal Vaccines for Children program. This provides vaccine to all children who are on Medicaid, uninsured or underinsured, or who are American Indian or Alaskan Native. The way that we purchase vaccines for the rest of the children, because that VFC eligible group is about 40%, the remaining 60% are purchased through our partnership with the New Hampshire Vaccine Association and is paid for by the payers. We consider our state then a universal purchasing program for children, which means that we purchase all of the vaccines in the state for children off of that CDC contract, which allows us to save those funds. So this bill is proposes to create a universal purchase program, likewise for adults under the age of 65. There are 10 states in our country who have those universal purchase programs for children, and there are the 3 states, Alaska, Rhode Island, and Vermont, that have universal purchase programs for adults. In terms of how we oversee these programs, obviously we have very strict standards from the federal government around operation of our childhood program. This includes oversight of all of the vaccines that are purchased through our program. We oversee the shipping and administration of every vaccine dose that's purchased by DHHS. It's tracked in our vaccine ordering management system. And we have a very robust quality assurance and accountability program. So any healthcare provider who is receiving doses of vaccine through this program must sign agreements and meet very strict requirements for accountability of the vaccines they receive. This includes implementing the required vaccine storage and handling practices so that we don't have any loss of those vaccines, maintaining emergency procedures to prevent loss of vaccine during power failures, and making sure that there's that accountability for every dose of vaccine. We provide training to them and technical assistance, and we also visit every location that has our vaccines on site at least once every 2 years to assure their compliance with our program policies and procedures. So these oversight and monitoring activities, along with the care taken by our healthcare providers in handling the vaccines, has led to New Hampshire's exceedingly low vaccine wastage rate. It's less than 1%, which is well below CDC's goal for state immunization programs, which is 5%. So with the new adult program that's being proposed, we assume that we would have to enroll about 350 to 400 additional provider office locations. This is above and beyond the childhood program. And so in order to implement that oversight of their vaccine ordering, safety, and accountability, we have assumed that we'd need to hire those 4 positions that have been outlined in the fiscal note. So in conclusion, DHHS, the insurers, healthcare providers, and the Vaccine Association have all been able to work in partnership to successfully offer vaccines to all children in our state. And as a result, we enjoy high immunization rates and low rates of vaccine preventable diseases. An adult program that's modeled after that childhood program is feasible and would offer public health benefits of increasing access to vaccines and decreasing infectious diseases. It would also offer the cost savings that Representative Konerko outlined for us. So thank you very much for the opportunity to testify, and I'd be happy to address any questions you have. Thank you.
Any questions?
Yes, Mr. Chairman.
Yes, Representative Merchant.
Thank you for taking thank you for that, Mr. Chairman, and also Ms. Beth Daly for taking my question. This is more probably in the details in the weeds, but as a pharmacist today, when we bill for the vaccine, we also bill for the administration of the vaccine and so forth. It sort of dovetails together. My question to you or someone else, maybe in the insurance industry, if I don't have a vaccine to bill for, am I going to be able to bill for just the administration of the vaccine? And is that going to go to the insurance company under the drug benefit or go to the insurance company under the medical benefit?
So I can start by answering to say that you can bill, in fact, you do bill separately for the vaccine dose itself and the administration fee. So under the childhood program, those providers who are administering the vaccine, they do not bill for the dose itself because we have already purchased that for them and the payers have provided the funding for that. They do charge the administration fee and that will get covered by the insurance company then or the insurer. I don't know the answer to the more detailed billing side of that because I don't know insurance billing.
Thank you. Could we have someone do some research? Because my concern is that we get into a billing issue where we want to expand, if you will, vaccinations for adults, which I totally support. I just don't want to have a situation where all of a sudden in the pharmacy, we don't have a billing mechanism to accommodate the expansion of the program. Today, we don't deal with that with children because for the most part, we don't bill for children vaccines per se, because they're not really part of our scope of practice. But as we expand this to adults, I think that could be a problem.
So
Thank you.
just to
Yes.
reaffirm, you can bill for the administration fee. I just didn't understand the second half of your question, which maybe the insurance department is on and can answer, or an insurer.
What I understand is that when you bill for the vaccine, for the product itself, at that time, you also bill for the administration of the vaccine. If we don't bill for the vaccine itself, my concern is a mechanism to bill only for the labor and not for the product.
There. But you can.
Can you, I heard Representative Gnurk.
Yes. Well, am I allowed to speak? I'm sorry. I didn't realize I wasn't muted. I was just whispering to myself. Yes, you are allowed to bill for the administration. The provider can bill for the administration of the vaccine. That's currently there. It would still be there. It's not precluded.
If I may, Mr. Chair, not to get into a discussion with Representative Kirk, but I just take it offline. But my concern is that that's in the medical side. I'm just concerned a lot of things in the pharmacy on the drug side, which operates differently than the medical side.
We're going to hold this for the exec session, please. Representative Snow wishes to speak.
Yes, thank you, Mr. Chairman. My question is, I got emails from a couple of members of the public who were against this bill because they thought it was going to require them to be vaccinated even if they didn't want to. And I can find nothing. I don't believe that has anything to do with this bill, does it? I didn't think so. Thank you.
Representative Cushman.
Thank you, Mr. Chairman. Dr. Daly, these DHHS administrative costs, does that include, is that all staff and programs, or does that also include new costs for the state vaccination registry?
So the cost for the adult program are new staff who we need to go do that to assist with the vaccine ordering and go out into those provider offices and make sure that they are following all the policies and procedures to prevent vaccine wastage.
So follow up. So then none of this money that you anticipate to be needing to spend is going to go toward bolstering or expanding or at all going toward the New Hampshire immunization information system?
So remember that the immunization information system does two things. One part of it is a registry. The other part is the vaccine ordering system. So in order to run this program, we have to have an information technology solution to order vaccines for those provider offices. So it might be possible that we might need funding to support the ordering aspect, but it would not support the registry component of the system. What we have presented in the fiscal note is the new costs that are associated with the adult program. And we have asked the Vaccine Association to support our vaccine ordering system in the past, but that has not been approved because it was not allowable under statute.
Thank you.
Any other questions for Dr. Daly? Seeing none, the chair calls Dr. J. Smith from the New Hampshire Public Health Association. Dr. Smith.
Let's see, there we go. It says I can now be unmuted. Great. Hi, I am fully in support of this bill, SSR Association. We're very happy to see this. And actually, my only reason for being here is to iterate support. And we did send a letter, did a bunch of research on the part of one of our members of our policy committee. And my main purpose is just to be here in case anyone wants to speak to someone who is a primary care physician or was. I guess I am retired. I've been doing advocacy for about 5 years now after retirement, but I have a lot of knowledge of vaccines in both my clinical capacity and as a healthcare, public health person. So I really have nothing more to add to all of the wonderful stuff that Dr. Knurk has said. But I do realize that despite your having medical expertise on the committee, you don't have primary care people on the committee that I know of.
Any questions for Dr. Smith? Seeing none, the chair calls Holly Stevens from New Futures.
All right, are you guys able to hear me?
Yes.
Thank you, Mr. Chairman. New Futures appreciates the opportunity to testify in support of House Bill 604 relative to expanding the New Hampshire Vaccine Association to include adult vaccines. And just for the record, my name is Holly Stevens. I'm the Health Policy Coordinator at New Futures. New Futures is a nonpartisan, nonprofit organization that advocates, educates, and collaborates to improve the health and wellness of New Hampshire residents. In this role, we work extensively with policymakers, healthcare providers, and families to improve overall public health and improve health equity across the Granite State. House Bill 604 is a great step in moving New Hampshire's public health needle in the right direction. Expanding the state's vaccine program to include adults will save money while making CDC-approved vaccines available to all adults in New Hampshire, regardless of insurance type or status. And I did just want to hit home that point, that this program will also include individuals who are uninsured and individuals who are underinsured, meaning they have a plan that does not require it to have the requirements of the ACA to include all preventive medicine costs. So anybody who has a catastrophic plan or things like that, they would also be able to get vaccines under this program. As you heard Representative Knurk say, that this bill, if it were to pass, would join only 3 other states that have universal vaccine programs. And also, just to really hammer this point home, while it does make these vaccines available to all adults 18 to 64, it in no way mandates adults to receive any vaccination. The adult vaccine program is entirely voluntary. I also did want to just point out too that I did some research. There's very limited research about whether a universal vaccine program would increase the uptick of individuals becoming vaccinated, but I did want to let the committee know that in 2018 to 2019, Rhode Island, which is one of the states that has a universal vaccine program, they were #1 in the country for adults receiving flu vaccines. And again, I just want to point out that's a correlation. It doesn't mean that one caused the other. It's just fodder for thought. And although this bill was introduced originally in advance of COVID-19, because of the pandemic, it was left on the table, as you know. The COVID-19 virus has not affected all populations in our state equally. Offering no-cost vaccinations to all adults will help improve racial health disparities for historically marginalized populations and will assist in improving the health and wellness of all Granite Staters now and into the future. And also, as Representative Knurk mentioned in his testimony, last fall, the New Hampshire Vaccine Association, the Department of Public Health, and I just want to say thank you if Dr. Daly is still on this call. She actually did provide, I would say, a significant amount of her time, given what's going on right now in the state, to this endeavor. But the Department of Public Health, Representative Knurk, and New Futures, and the insurers virtually met a few times to discuss the language of this bill, and the amendment that Representative Knurk sent to you, 2021-0032H, was the language that all of us were able to come together and agree upon. It ensures that the insurers cannot be what they thought might be double billing. But it also ensures that patients cannot be charged for that vaccine either, regardless of where they obtain it. So it ensures that the insurers can't pay for it twice, but it also, there's language in there that ensures that that cost can't be passed on to the patient in the way of getting paid twice either. It also has administrative cost controls that were requested by the insurers so that the department couldn't just raise administrative costs willy-nilly to cover other things as they wanted to. And I'm not in any way saying that they would or that they do. It's just a protection so that something like that could not happen. And it also has transparency requirements so that all of us can ensure that the program is functioning the way it's designed to, which essentially is allowing adults to obtain vaccines at no cost to them, and that the insurers are receiving a savings as well. The expansion of the state's vaccine program is cost neutral to the state because the assessment collected, as has been mentioned a couple of times, comes from the insurers to cover both the vaccines and the administrative costs of the program. House Bill 604, as amended, is a bill that truly is a win-win for all involved. Even if the expanded vaccine program and the COVID-19 pandemic experience don't result in more adults getting vaccinated, it will still cost the insurers less than they are currently paying now for their covered adults who do choose to obtain vaccines. And lastly, if there's anything that the COVID-19 pandemic has taught us, is the importance of vaccines in preventing illness and death. And so for all of those reasons, New Future strongly urges the General Court and this committee to vote ought to pass as amended on House Bill 604. Thank you. And I would be able to answer any questions if anybody has any.
Thank you, Ms. Stevens. Any questions for these? Yes, Representative Gay.
Thank you. Thank you, Mr. Chairman. Thank you for taking my question. It's extremely simple. You talked about, everybody talks about the two costs. One is of the vaccine liquid itself, and the other is administration. I've heard multiple times that patients won't pay at all for their adult immunizations. So then who pays for the administration?
The administrative cost, that's the cost of actually putting the needle into the skin and pushing the plunger, is a cost that is billed to the insurers. Now, one thing that I would like to make clear is somebody who doesn't have insurance, unless a provider is willing to waive that cost, like if somebody walked into their local pharmacy, didn't have insurance and said, I want the flu vaccination, the pharmacy might say, well, we charge X amount of dollars to actually push that medicine into your skin. That being said, the state already has a list of providers that will provide vaccines that are purchased by the state, and they are given to folks without insurance at no charge anyway. So there are still places that somebody without insurance, if the pharmacies weren't willing to say, take that cost on themselves, that they would be able to go to another provider and receive that vaccination for free, which wouldn't cost them a dime, not for the administrative cost and not for the vaccine.
Thank you.
Any other questions? Representative Cushman.
So if a patient is uninsured and if a physician's office, sees uninsured patients, do they have to purchase a separate inventory for those uninsured patients that isn't covered by this?
No, I mean, if Dr. Daly is still on this call and she wants to correct me, it's my understanding that say I do have insurance, but say I didn't, and I walked into a convenient MD, and I said, I want the flu vaccine. They might say to me, well, the vaccine itself is going to be offered to you at no charge. It's free. We get it for free, but we're going to charge you $5 to put the needle in your arm. So all of the entities that have the vaccine, they get it for free. So they absolutely should not be charging anybody for that vaccine, whether they have insurance or whether they don't have insurance.
Follow
up.
Are any providers able to opt out of this program and then the added oversight and regulations that come with it?
Can anybody tell me if they see if Dr. Daly is still on or whether she had to hop off?
She still is on.
Okay. If it's okay, Representative, if it's okay, I'd rather leave that question to her since she's involved in the state and the contracts with the state with these providers.
Dr. Daly, could you answer that question for us?
Yes, so thank you for the question and the opportunity to answer it. The program is voluntary from the perspective of the healthcare provider. They do not have to administer vaccines to the patients. They're going to want to do that though. And they are already should be doing managing their vaccine inventory in the way that we will train them and ensure that they're actually doing.
Can I clarify? I was trying to ask.
Yes, Representative Cushman wishes to clarify her question.
My question is, can they purchase vaccines outside of the program? If they don't want to be a part of this program, but they still want to purchase vaccines to administer to their patients, do they have the option to do so?
So yes, they can still purchase those vaccines at the higher cost on the private market. I'm not sure why they would want to do that, but they can do that. The problem is that they're not going to be able to bill insurance for it, though. They can bill that administration fee, but they will not be able to bill the insurance company for the cost of the vaccine because those insurers are already contributing to purchase that vaccine at the lower cost. It's based on the number of insured individuals they have. And so they're already paying for the vaccine and they're not going to reimburse that provider who chooses to buy it off the private market for a higher cost.
Any other questions for Ms. Stevens? Seeing none, thank you. And the chair recognizes Tyler Brennan from the Insurance Department.
Hello, Tyler Brannon from the New Hampshire Insurance Department. I am the Director of Health Economics. We do not have a position on the bill. And as was mentioned earlier, in response to legislation last year, we did an analysis of our claims data on vaccine use in New Hampshire and the prices. And there has been background on that already. Just to say a little about the CHIS, this is the New Hampshire Comprehensive Health Information System, which is basically a claims data set of anonymous healthcare claims that we get from health insurers. It is not all of the data on all of New Hampshire residents, but it is a really good sample. So that's relevant, I think, because of some of the comments I've seen around the analysis. But the analysis and the report are public information. They're available on the Insurance Department website. I will send a link to the report to committee members so that you have that at your disposal. Because we don't regulate all of the entities, we can't collect data on all of New Hampshire residents. So if somebody is under a self-funded employer, in other words, the employer retains the risk for the actual administration of claims, but a company like Anthem is paying a healthcare provider, we wouldn't necessarily see those claims data. So within the database, there in the report, it is mentioned that there are about 13.5 million in vaccine that was billed in 2018, with about 8.2 million that was actually paid out according to the negotiated prices. The report also does say that the CDC contracted rate would be about half of that amount. What I want to be clear about is that 8.2 million does not represent the vaccines for all of New Hampshire residents. Within the report, there is also an analysis of approximation of how many people we have in the claims data versus how many people there are in New Hampshire. And it's about half. So if you wanted to get a kind of a better understanding of the total amount spent on vaccines in New Hampshire, you'd probably be going down the road of doubling those numbers quite a bit. So some of the findings in the report are that about half of adults have received a vaccine. Almost 80% of the people in the 55 to 64 age group have received a vaccine. By far, the most common is for the flu, and that's about 70% of vaccines being administered. 87% of the vaccines are just for the top three. So in addition to the flu, there's the vaccine for tetanus, diphtheria, and pertussis. And 90% of the time, the vaccine was obtained in a provider office or a pharmacy. We have reviewed the amendment, and we also agree with the very important conclusion that our insurers do not get assessed and billed for the vaccine. So that's our understanding of how this would work. Representative Merchant raised the question about billing for an administration fee without actually billing for a vaccine. And our expectation is that carriers would continue to pay that administrative fee. They may ask a provider to do something to clarify that the administration is for a vaccine that's covered under the program. But that's something that can be worked out, I think, between the provider and the insurer. We did an analysis of the vaccine data several years ago and observed that many providers were billing like 1 cent for the vaccine. I think just to clarify that was the reason the administration was being billed. How a pharmacist would bill would be different than I think a medical care provider. And that just has to do with the types of coding systems and billing forms that are used. But I do believe that the claims processing system between a PBM and a pharmacy does allow for payment for vaccines and the associated administration. So I wouldn't envision that being a problem either. But clearly the department would be happy to work with the parties if issues do arise. Don't have much more to say. I appreciate the chance to testify and happy to answer any questions.
Any questions for Mr. Brennan?
Mr. Chair,
Yes.
if I could to Mr. Brennan, thank you. Is it okay, Mr. Chairman?
I am. I don't know who's speaking.
This Representative Merchant, sorry.
There you are. Yes.
There. That's right. Question to Mr. Tyler Brennan. Thank you for taking my question, first and foremost. My concern is that it's assumed that under the PBM contracts that will be the case. I'm just concerned that if we don't clarify that, we could potentially have an unintended consequence where the PBMs are not playing ball, which is different than the insurance carrier because they really work under the insurance company through a contract. So going forward, we have a possibility that patients going into a pharmacy may not have reception because of the financial situation.
Okay, so your question is perhaps whether or not we need some sort of provider contracting standard for PBMs. This may be solving a problem that doesn't exist, but I'm trying to think the carrier is responsible for sort of making sure that a patient has access to the vaccine. So if they refuse to pay an administrative fee or something that is equivalent to that to a pharmacy, I think that would raise some concerns about coverage. But I'd have to kind of go back and look and think about this a little bit more to be absolutely certain that your concern would be fully addressed, at least in existing statute now.
Thank you for taking my question.
Any other questions for Mr. Brennan? Seeing none, thank you for your testimony.
Thank you.
The chair now recognizes Sabrina Dunlap, who is with Anthem.
Hi there, that took a while. Thank you, Mr. Chair. Thank you, members of the committee. Sabrina Dunlap, Director of Government Relations at Anthem, and just really briefly wanted to offer our support for the amendment and thank Representative Knirk for working with us on this. So happy to take any questions, but don't have much more to add. Thank you.
And thank you. Chair recognizes Laura Condon. She identifies herself as a member of the public and she wishes to speak against the bill.
Can you hear me?
Yes.
Okay, thank you. Well, good afternoon, Chairman Pearson and committee members. My name is Laura Condon. I live in Bedford and I'm a volunteer advocate with the National Vaccine Information Center. And I have worked for a nonprofit in the insurance industry for 29 years. I have served for 5 years on the board of directors of the New Hampshire Vaccine Association. As a public member, I was appointed by the Senate President, and I continue to be an active member of the public in those meetings. And I served as a member of the audit committee while I was on the board of directors of the Vaccine Association. I am opposed to this bill that will provide for DHHS and Vaccine Association taking over the purchase of adult vaccines because it would greatly increase the cost of vaccines by over $3 million. Private industry is doing very well and a financial analysis will demonstrate that. I wish to thank Representative Knirk for bringing this bill forward for discussion of this important issue and to finally force an appropriate review of the costs. Information and documents that Representative Knirk has provided assist in this proper review of costs and will show a significant cost increase under this bill. I also recognize Representative Knirk's motives to be genuine and sincere to insist in bringing down costs of vaccines for New Hampshire consumers. However, this bill will actually do nothing to change the cost of vaccines to New Hampshire consumers. Under the Affordable Care Act, it is required that vaccines be provided without cost to all covered persons. There may, however, be, as you've heard discussed, a charge for the administrative cost, injection of the vaccine, but also a cost perhaps for the office visit with the doctor. This bill does not change those costs. Those over age 65 are covered by Medicare, and this bill would have no effect on them. This bill would have no impact on the poor without insurance, and DHHS provides, as you've heard, under current law, many vaccine clinics where the poor may receive vaccines free of charge. They will not be able to, and it was a misrepresentation, go into a doctor's. If you are uninsured, you would not be able to go into a pharmacy and receive this free supply as an uninsured person because the uninsured person had nobody who paid into the purchase of these vaccines. So that's how it works with the child program. You need to be insured to access this supply of vaccines. So that was a misstatement I wish to clarify there. Between private businesses, the insurance industry, and DHHS, there's currently ample supply of adult vaccines provided cost effectively in many locations, from your doctor's office to clinics to the corner drugstores. Gosh, you can even get vaccines in a grocery store. We do not have an availability of vaccine issue. I wish to remind all that this bill is not about the benefit or risk of vaccines. It is not about whether or not people should get vaccines, and it's not about mandating vaccines. This bill is squarely focused on the cost of vaccines. There are a number of concerns relative to this bill, and I did send the committee an email yesterday afternoon, and those concerns include that the child vaccine purchase program would be put at risk. Currently, the child vaccines are being purchased through the federal contract with the VFC program. That VFC program is originated from the Section 1928 of the Social Security Act that provides for that federal program that provides vaccines for poor children. It is exclusively a pediatric vaccine purchase program. There is no authority to use that VFC contract in that program for the purchase of adult vaccines. And the concern is, of course, if there is effort to violate that federal contract, that the VFC program in New Hampshire could be shut down and poor children could be left without vaccines. So I caution us not to pass legislation that would violate that federal contract. In that email, I did provide you with Section 128 of the Social Security Act. The cost comparisons here are not accurate. There has been comparisons of the CDC market price numbers, which are actually manufactured suggested retail prices that no one actually pays. Doctors, hospitals, pharmacists are purchasing all their medical supplies and pharmaceuticals, including vaccines, through provider discount programs, group purchase programs, and they recognize significant discounts for those programs, including rebates. But actually, that's not even a relevant number here. The true cost comparison is to compare the price that DHHS would purchase these vaccines for through what is the negotiated claim amount that insurance companies are paying. Because we're talking about what insurance companies are going to pay, either what they're paying now under the current model or what they would pay through this vaccine association. So that is the cost comparison that we need to make here. And the costs keep growing with this, this amendment that's been added to this bill. There is now administrative costs totaling up to $848,000 a year, plus whatever additional costs that DHHS, which has 3 seats on the board of the Vaccine Association, might deem as quote unquote reasonable. And reasonable is actually the language used in the amendment. The funding of DHHS staff, their vaccine registry, their vaccine ordering and inventory program should be funded through the general fund. It should not be borne on the backs of New Hampshire health insurance consumers who already pay some of the highest insurance rates in the nation. This bill won't provide vaccines for many adults and may increase costs and limit availability. Let me explain that. The bill will not provide vaccines if you're age 65 and older. It will not provide vaccines to the poor. It will not provide vaccines if you're uninsured. Your doctor and pharmacist will still need to purchase vaccines for that population of adults. Remember, they are getting their vaccines as a significant discount. This doesn't speak to the cost, this speaks to availability of vaccines because they're buying in bulk. If now a portion of the adult vaccines they purchase are being offloaded to be purchased through this program, they will no longer have their bulk discounts that they currently enjoy. So that would create a disincentive for them to continue to stock adult vaccines for those age 65 and older, those on Medicaid, those who are uninsured. So it could put the adult vaccine availability at risk. And will if they abandon it as not a viable business if they lose those discounts. This bill will be burdensome to those vaccine providers. There will be a requirement that they maintain separate vaccine inventories for adults. Those that they get quote unquote free from the state need to go in a separate refrigerator and freezer from the refrigerator and freezer they now currently have for the inventory that they purchase and they own. And there is no mechanism here for controls on that multi-million-dollar inventory. It appears to be on the honor system that a busy pharmacist or their college intern or administers vaccine isn't going to reach into the free supply and use it to administer somebody who's not covered under this program. And I mean, that's not a solid or sound business practice. And we would certainly want oversight over that inventory. The other things to remember is that it's not a broken system. The system we have now, vaccines are already supplied at like I say, you can get them at a grocery store. They're already free under the Affordable Care Act. Consumers cannot be charged for the cost of vaccines. Under Medicare, you cannot be charged for the cost of vaccines. And the poor people are provided by DHHS. This bill was actually not a request of the insurance industry, not a request of DHHS, and not a request of the Vaccine Association. It was brought forth by contact that Representative Knoerk had in the community concerns about costs of vaccines. It appeared to be somebody over the age of 64, which of course wouldn't cover. The final consideration here is that DHHS is working around the clock during this COVID crisis, and now is certainly not the time to burden them further with trying to set up this new program. So let's get back to normal first before we burden them. I can walk you through the financial analysis that shows that this bill will increase costs $3,131,997. I did provide you with an email late last night that had some attachments to it. And let me walk you through that and remind you again, this is not about the cost that doctors and pharmacists purchase vaccines for. This is squarely talking about the cost to health insurers, what they're paying to doctors and pharmacists versus what they would pay to DHHS for vaccines. That is the cost comparison. So please do not be distracted by any sort of CDC pricing.
Ms. Condon, this last night, we will be able to read it. We do need to move on. We have several people who need to testify, and we have a snowstorm coming. Would you take questions?
I will take questions.
Does anybody wish to ask a question? Representative Cushman.
Thank you, Mr. Chairman. Ms. Condon, will you confirm your position, what your position was at the New Hampshire Vaccine Association?
I was a public board member there. I was appointed by the Senate President. I served for 5 years, and I was on the audit committee there. And what I brought to that board is there were significant deficiencies in oversight and reporting and accountability, policies and procedures, and I pushed for a good number of changes there.
Follow-up.
Follow-up.
So do you believe, I understand that this organization has to submit annual reports to the President of the Senate, Speaker of the House, and the Governor. Do you believe that those reports that are submitted offer sufficient disclosure of the association's activities and their financial reports?
Thank you for that question. Again, as a member of the board and the audit committee, those, two-sided brochures essentially amount to, a marketing brochure, and were not full disclosure at all. They did the erroneous cost comparison of the VFC pricing compared to market pricing costs, which is not the comparison we need to look at. And I've long argued that the comparison needs to be between what the DHHS is paying for the vaccines compared to what the insurance industry pays on claims, that negotiated discount. Because every service that insurance companies engage in with a provider, they negotiate discounts. They negotiate discounts on, office visits, vaccines, and everything. And as we saw in the New Hampshire Insurance Department document, is they negotiate a discount of some 40% on vaccine claims. And that's the information that should be provided. I think the amendment is deficient in what it calls for disclosure to the legislature. Thank you.
Thank you. Representative Merchant.
Thank you, Mr. Chairman. Ms. Condon, my understanding is that in the vaccine world, as far as what's free, this goes back to the prior Medicare when it was created, that would include influenza and also pneumococcal and ones for emergency like tetanus and so forth. Having been a practicing pharmacist, I can assure you that there's many times in a pharmacy that patients have to pay for a vaccine, and many times the cost of that vaccine is exorbitant, even though it's being paid for by the insurance company because of the co-pays and deductibles. So that does become a barrier to a lot of the patients getting a vaccine. So I want to be clear, at least my understanding, having worked in the pharmacy for a long time, that not all vaccines are free.
Under the Affordable Care Act, it is required for insurance individuals that there should not be a charge for the vaccine. There may be charges for the administration of the vaccine, subject to deductibles and copays, and that's for insured individuals. You might be talking about Medicare patients, Medicare individuals covered under Part B or D, but again, this bill does not address that population, would have no impact on that.
Thank you. Representative Kelsey.
Yes, thank you, Mr. Chairman. Ms. Condon, do you think it would be fair and even reasonable to fund a state vaccine registry and associated Department of Health and Human Services staff through the Vaccine Association?
I actually think that's tremendously unfair to impose that, burden on New Hampshire insurance consumers. The statute provides for every dollar of this cost to be funneled through and included in premiums as medical loss. And I think that's a violation of the Federal Affordable Care Act, that it protects New Hampshire consumers from excessive administrative costs. And what this does by placing on the burden of insured individuals, it means that the rest of those in the state who might be using these DHHS services of the vaccine registry, which include Medicare, Medicaid individuals, the uninsured, are not paying the burden of that. So this is very much unfairly imposed on New Hampshire insurance consumers, driving up our rates further. Thank you for the question.
Anyone else from the committee who hasn't asked a question? Thank you for your testimony. The chair now recognizes Jessica Kliske, who is a member of the public. We have Jessica Kliske.
Can you hear me?
Yes.
Yes, okay. Thank you, Mr. Chairman Pearson, for taking my comment. I second everything that Laura Condon said, but I wanted to point out a figure for the people who in New Hampshire that are enrolled in the Medicaid program, which is around 45,000. That's significant for people who won't be at, this bill would not be effective for. And also, because we're talking about costs, I think it's important to remember that back in 2014, we spent about $1.4 million on a contract to build an immunization registry that was failed. And, we heard a lot about we have the highest rates of vaccinations, then we need this money to spend on this bill. So I just question, if everything is as it seems. That's pretty much all I have. Laura said everything else that I was going to point out. So thank you for your time.
Thank you. Thank you. It's from the committee. Representative Gay.
Oh, thank you. Thank you, Mr. Chair. Thank you, Ms. Kliske, for explaining. You said something about in 2014, we spent over $1 million on what, that it failed?
We hired Science Technologies Corporation to build what I'm assuming is a technology piece to an immunization registry. That was not completed from what I understand. So I just wonder if we need to consider that not everything, that we're going to have taxpayers pay is necessary.
Thank you.
Anyone else? Thank you very much. The chair recognizes Andrew Hosmer.
Thank you very much, Mr. Chair, members of the committee. I'll be very brief here. Again, my name is Andrew Hosmer. I'm representing Harvard Pilgrim Healthcare, New Hampshire's largest not-for-profit health insurer. We certainly support the bill as amended, and I'd second comments made by previous proponents, including Sabrina Dunlap. So we are anxious to continue working with stakeholders to increase the number of people who receive needed vaccines, that lowers the cost of acquiring and dispensing vaccines, and puts in place a process that allows for transparency and accountability. So for these reasons, we are in support of Representative Knirk's amendment. Thank you very much.
Thank you. Will you take a question if there is one?
I'll do my best.
Seeing none, thank you for your testimony, Mr. Hosmer.
Thank you.
Chair recognizes Joanne Rainville, a member of the public.
Hello? Hi, good. You can hear me. I'm kind of new to Zoom. Yes, I am a member of the public, and I am also the executive director of the Tamworth Nurse Association. And I was the one who went and got Jerry Knirk's ear and said, we need help getting vaccines into people, and they shouldn't have to come with their hat in their hand to be able to get a flu vaccine. And with the Tamworth community nurses, we don't bill anyone. So we don't bill Medicare or Medicaid or any of those things. But we really try and get people, be a conduit for people to be able to get health care. When I started at TCNA 20 years ago now, a vial of vaccine was $38. It's now about $175. When you're not billing anybody, it's kind of hard to make up that cost. And it's too important to turn our back on people who need it. We also have to keep in mind that there are people in New Hampshire, and I'm sure in every state, that are not signed up for Medicaid or health or different health options that they may have. And that's for their own personal reasons. But we want to keep those people healthy too, because they turn around, if they get the flu, then they're probably going to infect other folks. And then there's just the fact that when, especially frail people or people with pre-existing conditions, they don't get the flu shot, that, you know, we see an increase in hospitalizations, ER visits, doctor's office visits. And we've also got, with COVID, people who are very reluctant to get near any healthcare provider. So my thought when I first went to Jerry was, let's just remove one barrier that stops one person from being able to get an inoculation. And Jerry, I thank you for your hard work on this. And I thank this whole committee for letting me speak. If you have any questions, I'm here.
Any questions for Ms. Rainville? Seeing none, the final person on my sheet is Heidi Kroll from America's Health Insurance Plans, AHIP. Ms. Kroll.
Good afternoon, Mr. Chairman. Are you able to hear me?
Yes.
Great, thank you. Yes, good afternoon, everyone, Mr. Chairman and members of the committee. My name is Heidi Kroll. I represent AHIP, America's Health Insurance Plans. I work at Gallagher, Callahan, and Gartrell. And I am home with my son this afternoon, so I apologize if you hear background noise. AHIP does not take any position or is neutral on the underlying question that all of you are facing as to whether or not to expand the vaccine program to adults. But we certainly are supportive of promoting the use of vaccines to prevent disease, save lives, and reduce unnecessary healthcare costs. And if the commission's decision, or this committee's decision is to expand the program, then AHIP is supportive of the amendment to House Bill 604, which you've been discussing here for the past hour or so. From AHIP's perspective, there are several important aspects of the amendment that I would just like to quickly touch upon. One is the capping the Department of Health and Human Services administrative costs associated with the vaccine program. There's two aspects happening here. One is that carriers will be assessed for the full cost of DHS's administrative costs associated with the adult program. In addition, carriers will be asked to bear through assessments approximately 60% of HHS's administrative costs associated with the childhood vaccine. So both of those costs coming from HHS's administration of programs would be new in terms of being part of the assessment on carriers. So we were concerned to make sure that There's kind of a checks and balances on the administrative costs so that we don't erode these savings from purchasing vaccines through the program. The second piece that's important to us with this is the enhanced annual reporting on program costs and savings. Having listened to the discussion this morning, there's perhaps more that can be done to further enhance that, but our intention at least was to increase the transparency and accountability in terms of making sure that the public and legislators have easy and ready access to good information about the cost and the savings. And the final piece that was important to us, and I should say that Representative Knirk and other stakeholders really spent a lot of time talking with the carriers, talking with me, and just a lot of stakeholder dialogue over many weeks. And we're very appreciative for that process. So I neglected to say that in the beginning, but I wanted to mention that it was a very good process. So the third piece that was important to us and we think has made an improvement to the bill with the amendment is simply clarifying the duties of the assessable entities, namely the carriers. And there's been some discussion about that, but carriers are committed to paying for the administration of the vaccine, namely paying providers to put the needle in somebody's arm and administer the vaccine. But because we are or would be paying for this vaccine through the assessment, we were concerned about being double billed, if you will. And so the language in the amendment, I think, alleviates that concern. And it should also help ensure that the savings are maximized for the benefit of New Hampshire citizens. So with that, I'd be happy to answer any questions, or if I'm not able to, I can take them back and respond later, but I appreciate your time this afternoon. Thank you very much.
Any questions for Ms. Kroll? Representative Gay.
Thank you, Mr. Chair, and thank you for taking my question. How do we get the actual cost of the vaccine, since it's been pointed out to us that the comparison of the new purchase price, if we pass the bill, if we get that price and compare it to what is currently being paid, is not the retail. What is the real? So that we can see the real cost savings.
I'm not the best data person to ask your question of. My understanding is I have seen the report that the insurance department prepared. I believe it was last January when the last year's version of this bill was being considered. And so, my understanding is that in that report, it sets forth information about what the carriers were billed by providers for the cost of the vaccine, the actual product, and then what carriers actually reimbursed.
Exactly.
That, and that report also includes some estimates or averages of what the CDC price would have been had we paid a CDC price instead of a carrier reimbursement. That's the data that I'm aware of, but I can't speak to some of the other data that's been discussed here this morning. I apologize. It's just not my area of expertise.
Okay, thank you. Thank you for your testimony. We have one more, and that is Patrick Miller. Mr. Miller, if you would care to give us your testimony, please.
Good afternoon, Chairman. Can you hear me okay?
Yes, I can. Thank you.
Thank you so much. For the record, my name is Patrick Miller. I'm the Executive Director for the New Hampshire Vaccine Association. As mentioned earlier, we were created by statute in 2002 to manage the childhood vaccine program. We don't set any vaccine policy or create vaccine laws, but we do collect the assessments and place those assessments on the carriers, and then provide that funding to the state's Department of Health and Human Services to purchase the vaccines. While the New Hampshire Vaccine Association cannot take a position for or against the bill, the Vaccine Association has worked closely with Representative Knirk, the insurers, and other stakeholders that have been on this call regarding the bill's language revisions. Our goal is to just be ready to implement the program changes and ensure that the department receives the necessary funds to support the universal vaccine purchasing program. I think in terms of Representative Gay's questions around the costs, there is publicly available data that I can provide to you that we receive from the department that shows the essentially the purchase price that the department is paying today compared with the retail price. So that data is currently available and can certainly provide that. I would say also in terms of the public reporting piece, we have worked to try to increase what would be reported publicly in terms of the amendment to the bill, and certainly would be willing to work with the committee or others to continue those discussions and to make sure that there's full transparency. We do operate under the state's right to know laws, and all of our information is publicly available on our website. So if you have any further questions, I'm just here today to be able to answer them around the mechanics of the New Hampshire Vaccine Association and the work that we do on a daily basis. So thank you for your time this morning, or this afternoon at this point.
Questions? Yes, Representative McMahon.
Thank you. Mr. Miller,
Yes.
I will assume that you heard the testimony of a former member of your organization, Ms. Condon.
Yes.
And she stated that the cost would be over $3 million based on the database that she provided all of us. Is that factual or made up?
I think it differs from the cost estimates that the insurance department and the Department of Health and Human Services have already provided testimony on.
Well, follow up. So the follow up then, and to ensure I get the benefit of your guidance, Mr. Miller, is that the testimony provided by Ms. Condon should not be taken as factual and based on reality.
Could you perhaps clarify that question? I'm not sure that I
know
exactly what you're asking.
Mr. Chairman?
Yes, go ahead.
I asked a question specifically as to on the basis of being a state rep deciding policy for every citizen in our state, and that what we hear in testimony is in fact the truth. And if you hear someone with your background and expertise saying that it's a dog on Monday, and then someone else saying it's a cat on Wednesday, what's the right thing for us to do?
Understood. I guess what I can certainly report about the program is based upon, again, the data that's been provided through the insurance department and the health department. It's believed that, it's a fact, that vaccines will be able to be purchased for a lower cost. It will increase access. And ultimately should allow theoretically insurance premiums to be decreased at some level, given the fact that the insurers are receiving discount on the vaccine. So from my perspective, I'm working with the data that's been provided to us by the two departments, and that's really what we use for our actuarial models that sets the rate every year. We also, I think, just in terms of our board composition, it's important to point out that we do have representatives from the insurance industry that sit on that board and provide oversight. But we also have oversight board members that are from the government, from healthcare providers, and public members as well, self-insured entities. So their focus, as I mentioned a few minutes ago, is not to set the policy, but it's really to make sure that we raise the funds from the insurance carriers that we're required to raise by the statute to make sure the department can meet their obligations in terms of vaccine funding.
And I'll leave it at that.
Yes, Representative Cushman.
Thank you, Mr. Chairman, for taking my question. Thank you. So I just want to know, now that we allow direct primary care in New Hampshire, how is this going to affect those physicians who who participate in that model of providing healthcare? Doesn't this disenfranchise them if this is passed from then providing vaccinations? Because they can only purchase it through the state, and they can only do it if they're going through insurance.
So I think if Dr. Daly's still on, this might be a better question for her. But my understanding, again, what she said earlier too, is that it's voluntary on the part of the provider to participate in the program. So if they wish to continue to purchase outside, they could do that, but they wouldn't be able to be reimbursed for it, is my understanding.
Thank you.
Thank you. Any other questions?
Yes.
Representative Gay.
I'll ask, thank you, Mr. Chairman. I'll ask you the same question about the cost, because it seems like the whole point is to save money. So that depends on cutting the cost of the vaccines, and thus making them available to people who don't have insurance. I wanted to see how to get the cost that we pay now as compared to the cost we are being promised if we get it from the CDC. So I don't want the comparison of the price we pay now to retail. I'd like the price we pay now compared to what we anticipate to be cheaper.
This is Patrick Miller. I'll attempt to answer that. So in terms of the pricing, again, there is the difference between the CDC price and the retail price. And the providers would essentially would not be billing, as they do today for the vaccine itself. They'd only be billing for the administrative costs for those vaccines.
Go ahead.
We're talking apples and oranges here. I'm trying to find out the actual cost of the vaccines that we pay now, not the retail, compared to the anticipated cost savings if we go through this program, if we create this program to buy through the CDC. Retail, nothing.
Right. So that's provided in Table 5 of the Insurance Department's report, where they basically compare by the different types of vaccines what the average paid per vaccine is, because each insurance carrier and PBM will have a different contract relationship with their provider networks. And then it also compares the private sector and then the CDC. So that table shows that essentially for all the different vaccines that are listed, the savings, if you will, between what's currently being paid and then what would be paid. I believe that's the table that would answer your question, Representative.
Representative Folsom.
I think what we're looking for is how can we get that form and see that information in print? Do you have it available to send to us?
May I speak, Mr. Chair, for a moment? I sent that out in the packet. The report of the New Hampshire Insurance Department was sent to you in the email by me, so that you have that. So if you look in your email from me, that was one of the documents I sent. And the comparison was not between the retail price and the CDC price. It was between the price that was paid on claims, that's the negotiated price, and the CDC price. So that what Patrick Miller is referring to, you have that available to you.
Thank you.
Not at all. Any other questions? Any other questions? Thank you for your testimony.
Thank you for your time.
I'm going to give us about a 10-minute recess, but before I do, a couple of announcements. Number one, Representative Acton, will you write the blurb on HB 378, which we accepted last week?
Yes, I will.
And send me a copy and one to the clerk. Thank you. On the bill 187, Representative Marsh is writing a positive blurb. Two people voted against 187. Would one of them wish to write the minority report? Dr. McKay begs off. I forget the other person who voted no.
It was me, Representative Shapiro. I was extremely ambivalent about my vote, and I would certainly defer to Representative McKay.
It's not necessary to have a negative or a minority report. I just wanted to give you both the option. He declines, and you don't have to, but if you wish to, you may.
I will decline as well.
Thank you. Tomorrow, we will meet tucked in snug in everyone's home. We will be going all virtual tomorrow. I was waiting for cheers. On February 16th, we will meet. We have to exec some bills because they're early bills. And it looks like, but it's not 100% confirmed. Aaron Goulet, who's Chief of Staff to the Speaker, has suggested that date. And I'm asking Christina if that could be confirmed by the fourth floor, so we'll know. One other announcement.
Was that February 16, sir?
February 16, which is Tuesday. The place is closed on 15 for President's Day. So it would be Tuesday, the 16th.
Time?
Yes?
Is there a time?
Time, what time?
9 o'clock. A partisan thing, there will be a Republican Zoom caucus meeting at 7 p.m. Representative Acton, please send it out. I would ask the ranking member if she had an announcement for her people.
Are we talking about with respect to the, no, not for this week, no. And if you're asking me about the 16th, we don't know yet.
We do not know about the 16th yet. I was making an announcement for Republicans to meet tonight at 7 on Zoom. And I'm giving you the opportunity if you wish to speak to your fellow Democrats.
I appreciate the opportunity, but I tend to just email my fellow Democrats about those issues. And but I thank you for the opportunity.
Anytime, please request. Be happy to.
I will do that. Thank you.
And it is okay if you promise not to spill to eat at your place. And now I will give us about 7 minutes to stretch and do whatever. And we will resume with this same bill after about 7 minutes are up.
Not lunch.
No, this is lunch.
7-minute lunch.
Eat quickly. Here we go. Eat one.
Do you know? Does anyone know? if there's any questions?
75 sweet.
I'm ready to go and so by Marcia driving on Stumford. 7.
Work works too.
Oh, they
Marcia,
do. Which one would you prefer?
A spoon, yeah.
And.
Hold over.
I mean,
Reason why they fought. And then the young. Representative Mark, are we on mute for you?
My best friend's just gone.
Oh. Representative Pearson.
Representative Marsh, can you hear us?
Even trying to.
Hello, yes.
It's that shirt, well, how do you dry?
Hey, Joe Shapiro, are you in the room now? Sure, yeah. Joe, are you there?
I kind of had.
Guess not.
I tried.
And Ken, remember that this is going out to everybody over the airwaves.
Hi.
We gotta behave.
Betty, on your way back, could you pick up my?
Are you asking for me?
It's on the floor.
Are you saying their identities on the floor?
Was somebody talking to me? Joe?
Yeah, Ken Snow was.
Hi, Joe.
There you go.
The commission on opioid deaths, are you gonna try to go to that today?
I am going to try it, although we only have an hour until 5 o'clock.
I know. I was gonna call the office to see which is more critical. I would say the caucus is, but anyway. So I agree with you.
I'm going to go for a little while anyway.
Ken, Representative Snow, remember that we may be voting at any time here.
I know. This is the first meeting of this commission that we were appointed to last August. So we, at least we, even if we're late, we'll, if as long as we make an appearance, I guess that's okay.
I'm only going to go if this ends.
Oh, yeah, that's the same thing here. I agree. All right.
And
We're not going to be voting today anymore. So if somebody has to leave, I want you to know that we will not be voting because we're quite a bit behind, and Representative Soloway is texting me every 15 minutes. He wants me to leave because he wants me to be safe. I appreciate that. So with that in mind, we are now back on House Bill 604, and the chair recognizes Joan Pajot. And I would say to anybody who's going to be speaking from now on, we've heard a lot of testimony, all the questions have been asked. It could be all the information that could be has been. And so each speaker on the rest of this bill will get 1 minute. I have instructed the technical people to shut off mics at 1 minute. So tell us what you wish to tell us. We want everybody to have a chance to have a say, but we're running quite behind. So the chair recognizes Joan Pajot.
Ms. Pajot has dropped off the line.
The chair recognizes Nicole Nordlund.
I don't know if you can hear me.
I can.
You can? Hello?
Yes, we can hear you.
Great. As an elected, but thank you for hearing me. As an elected budget committee member in my town, we paid close attention to health insurance increases. I oppose this bill because, as mentioned, the cost and increases of administrative costs are borne by the insured. And it is not my understanding that a health insurance company is willing to give up that revenue without trying to find recourse, thus resulting in increase of health insurance rates for all of us. So therefore, I oppose this bill. Thank you for allowing me to speak.
Nicole, you are my hero. You said everything that needed to be said, and you did it in crickets. So you're my poster child. Thank you.
Thank you.
Anyone else? Then I will close the hearing on 604. It is an early bill, and February 16th, that's tentative, but it sounds pretty good. It's a Tuesday. The bills that are early have to be done by the 18th, and we will take it up and take a good look at it, I believe, at that time. Now open the hearing for House Bill 103, establishing a dental benefit under the state Medicaid program. Yeah. With that, I have to find, who is presenting that bill while I find it in my notes?
Representative Shapiro.
Would you please present your bill? Thank you.
Thank you. Thank you, Mr. Chairman, colleagues, and members of the public. For the record, I am Joe Shapiro, Cheshire 16, Keene. I come before you today to introduce House Bill 103, a bill that establishes a dental benefit for adult Medicaid recipients. In order to explain the specific need for HB 103 and what it entails, it will be necessary to give you a little history. Before I do, however, let me be clear about the issue before us. While dental coverage for children on Medicaid is guaranteed under federal law, coverage for adults is a state prerogative. In New Hampshire, low-income adult recipients receive no meaningful benefits. That means when they have a toothache and the pain becomes unbearable, they have no option except to go to their local emergency room where they may be offered pain medication, antibiotics, or frequently extraction. There is no treatment, no help for the root cause of their problem. I am well aware that many of you here today have been involved in this campaign for access to oral health care for a long time, far longer than myself, so I will attempt to be brief. Recognizing poor oral health as a serious public health concern, the legislature enacted a commission to study pathways to oral health care in New Hampshire. In November 2015, the commission, chaired by Senator Jeb Bradley, issued its report. Noting the link between oral health and overall health, the considerable challenges to access dental services for low-income people, especially those in sparsely populated regions of the state, it recommended the establishment of a comprehensive adult Medicaid benefit. In 2019, House Bill 692 established an adult Medicaid benefit. It was passed and signed into law. Eventually, it was rolled into House Bill 4. It created the Adult Dental Benefit Working Group within the Department of Health and Human Services. Under the leadership of Dr. Sarah Finney, that group has been meeting to determine appropriate levels of care, or the actual benefits to be covered, delivery models, and very importantly, cost estimates for implementing such a program. Meanwhile, another House bill was passed last year, which would have provided the framework and timetable for the actual implementation of dental benefits. Unfortunately, Governor Sununu vetoed that bill. In his veto message, he cited immediate concerns about COVID-related budget shortfalls, but affirmed his general support for a dental plan. In fact, the morning after this past election, responding to a reporter's question about the possibility for bipartisanship in the next biennium, the governor said he was confident that Republicans and Democrats could work together to create a dental benefit. So that brings us back to HB 103. HB 103 is a roadmap to implementation. It will take the excellent work done by the HHS working group and set clear guideposts going forward with specific dates. A date to put out RFPs from managed care companies, a date to apply for waivers from Centers for Medicare and Medicaid Services, and most significantly, a date to actually implement coverage. It also outlines what benefits will be included: preventive and restorative services, treatment necessary to relieve pain and prevent imminent tooth loss, and dentures when necessary. There are countless reasons to establish an adult dental benefit: the correlation with other serious and costly medical conditions, the long-term savings related to appropriate treatment rather than repetitive emergency room visits, and the disproportionate impact on oral health for those with developmental disabilities and mental illness are just a few of those reasons. I will leave these issues, as well as the specific complexities of rolling out such a program, to others who are here to speak and are more knowledgeable than I. Why, you might ask, if so much progress has been made? A bill has been passed establishing a benefit. A DHHS working group is doing its job. DHHS has put in a priority need request for funding for the next budget. The governor appears to favor this new program. Why, you may ask, is the bill even necessary? The answer is simple. The progress made is real, but it is also erratic and unpredictable. The reality is that after all these years, as we sit here today, there are no dental benefits for adult Medicaid recipients. Instead, people are maxing out credit cards to get a root canal, or living with chronic pain, or having their teeth extracted one by one. Passing HB 103 will ensure that within a reasonable time frame, a program will be established and our neighbors will be able to have the care that they need and the dignity that they deserve. Thank you, and I'm willing to take questions.
Representative Marsh.
Thank you, Mr. Chairman. This is not a question, but Representative Shapiro spent a considerable amount of time talking about costs and funding. I would like to make a motion that we have a fiscal note prepared for this bill pursuant to RSA 1446(5)(a).
Representative Shapiro, you okay with that?
I am completely okay with that. I think it's necessary. I do have a procedural question, which is that I have an amendment that moves the date of implementation, which I think would have an effect on the financial note because it moves it further out and the inflated Medicaid population should go down as COVID recedes. So my procedural question is it possible to introduce the amendment before we send it for a financial note?
Representative Weber, would you help me here, please?
I would, Mr. Chairman. My understanding is that they will not prepare a fiscal note. Well, no, actually, because the committee is requesting it. I think that perhaps the thing to do is for the committee to vote to request a fiscal note, and for the chairman, when he is requesting it on behalf of the committee, to let them know that a different date is proposed, because normally they only prepare fiscal notes on something that's actually passed the committee, and I think at least passed the committee and maybe adopted by the House after the initial one. So I think if we just vote for one and if you let them know that there are two different dates that are being contemplated, that would be helpful.
I would like then Representative Shapiro a copy of your amendment emailed to me so that when I ask for a fiscal note, it will be on that basis.
Mr. Chairman, I've already emailed it out to everybody, but I'll email a copy directly to you.
Thank you very much. Representative Weber, do we need a roll call to do this?
Yes, you need a roll call to do everything these days. And I'm seeing several hands sort of waving. I'm not sure if it's in relation to this or something else.
I see Representative Soloway.
I have a question for Representative Shapiro. Is that in order, Mr. Chairman?
Why not?
Representative Shapiro, thank you so much for a thoroughly competent presentation of the bill. And this is a follow-up to the request for a fiscal note. Representative Shapiro, in order to do an intelligent fiscal note, it's necessary to have the data. We have to know if we're going to calculate the impact of this program, how many people are out there who are likely to need these services, what the cost of the services are. So has Dr. Finney, who runs Medicaid's dental services program, prepared for you the data describing the number of emergency visits by adult Medicaid recipients for dental treatment? Has that department ever given us the data that we need to do the calculations?
I can partially answer your question, Representative Soloway, which is that the working group has done a tremendous amount of work, and they have done all kinds of actuarial studies related to different tiers of benefits and how much it will cost. And my hope is that Dr. Finney is on this call and she will be able to answer with more of the specifics.
Thank you.
Yes, Dr. Soloway. Representative Soloway, would that, in your opinion, that data that she might provide, would that make the asked for fiscal note more accurate?
Unequivocally, Mr. Chairman.
Representative Representative Shapiro, I'm wondering if we could approve the request for fiscal notes, but with not only your amendment, but with data supplied by Dr. Finney. In other words, if we're going to get a fiscal note, it should be as accurate as possible. Could that happen? Could the two of you speak with each other? And so when you send me some things to ask for the fiscal note, it'll be that accurate?
If Dr. Finney is not actually on this call and does not answer that question for herself, I will contact her.
It looks to me like she just popped up.
Good. I would also just like to take this opportunity to say that I have tremendous optimism that this benefit will come into being. But there are an awful lot of moving parts. So this fiscal note is one moving part. Another moving part is that there's a parallel bill in the Senate and discussions and negotiations there about that bill. So we'll have to take this one step at a time with each of these bills and make decisions based on what's going to result in the best possible benefit in the long run.
This is not an early bill, so we could bat it around for a little bit and then defer the rest of the hearing, perhaps until after we see conversations between, I would guess, if it's a Senate bill on this, Senator Bradley and the governor. Is that amenable to you, or how would you like us to proceed?
Yes, I think there are negotiations between several of the senators, Senator Rosenwald and Senator Bradley, and I think that it would be wise to not be in a hurry with making a decision about this bill.
Well, then, since I cannot start the next hearing until 2 o'clock, we have about a half an hour to get ourselves more and more up to speed on the necessity for this, and that's, I think, how I'd like to proceed. The chair recognizes Sarah Finney.
Excuse me, Mr. Chairman, you still haven't taken the vote on the fiscal note?
And this was moved by Representative Martin. Is there a second on the fiscal notes? And that was Representative McKay seconded, and the chair may call the roll. The clerk may call the roll.
I got a promotion. Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson. Representative Nelson,
Please skip my vote because I was not here for the rest of the discussion. Not voting.
okay. Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Colfault,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow, Representative. Smith,
Yes.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
One with one absent.
Committee requests officially a fiscal notes, and Representative Shapiro with Sarah Finney, you can provide as best of information you can for them to produce the fiscal notes. Thank you. Chair recognizes.
Mr. Chairman, before you recognize the next person, I just have one other suggestion. Representative Weber.
Yes. Yes.
When we are all gathered together, if one is in the room when the question is put, one must vote. And because we are not together, it seems to me that if one is if one is present to say, I don't want to vote on this, one was sort of present. So if one is not present for voting, I think the thing to do would be to simply not answer. The clerk has been very clear about calling each person's name twice. So if you were not there when the question was put, the thing to do is simply not respond, and we don't get into the question of at what point did one come back into the discussion.
Representative Nelson, are you willing to vote, please?
I'm not questioning Representative Nelson's presence or absence. I'm just saying for future reference, if he says he wasn't there, he wasn't there.
He may not.
I thought it would be best that I did not vote in fairness to the sponsor of the bill.
Your vote will not significantly impact the outcome. So if you would like to vote, fine. And if not, I didn't see you in the room at the time the question was called.
I will not vote.
Okay, now, we're ready. Thank you, Representative Weber. I'd like to recognize Sarah Finney, please.
Good afternoon, Mr. Chairman. Thank you very much for this opportunity to speak to this committee. I will certainly do whatever is necessary to create a completely informative fiscal note worksheet for this bill. I agree with you all. I think that it is very important that there is a clear understanding of the cost estimate for the benefit, what the benefit will cover, where there can be savings in other parts of Medicaid where we're spending money now, such as Representative Salloway mentioned with emergency department costs. So I look forward to working with you and providing the information that you need so that you can make an informed decision about how to move forward with this bill. And I don't know if you have any additional specific questions.
Mr. Chairman. Representative McKay, please.
Please tell us who she is and what her position is.
Would you please introduce yourself, Ms. Finney, as to who you are and your position?
I'm sorry, I apologize for not doing that. My name is Dr. Sarah Finney. I'm a dentist with over 30 years of clinical experience. I've been with the department as the Medicaid dental director for 6 years now. And I have been leading the work group along with Henry Lipman for about 16 months now. And that work group has done significant work towards defining what the adult dental benefit would look like.
Thank you. Thank you. You were signed up to testify before we looked at the possibility of you working with Representative Shapiro. Would you present the testimony you were going to give us in favor of this bill?
Certainly. The department supports this bill. We would like to see there be an adult dental benefit in Medicaid for all of the reasons that have been spoken about. We realize that oral health is integral to overall health. There are many areas that we are spending money on other things that are not addressing the root cause of the dental disease. And we're trying to put a Band-Aid on those folks who have some serious issues. I was going to mention that we did have HB 4 signed into law, and that the working group had been in process, like I said, for 16 months now. And I just think that it is time to try to move this forward. What we have to keep in mind, though, is that there needs to be an appropriation because we need to know that the benefit is going to be funded. So currently, the Medicaid director, Henry Lipman, has included a priority need request for the state fiscal year 22-23 budget that would include the cost of providing this benefit, according to a cost estimate that was formulated in August of 2020.
Any questions? I recognize Representative Woods.
Thank you, Mr. Chair, and thank you for taking my question, Dr. Finney. Actually, you maybe will answer two questions for me. The first is, given the significant increase in potential patients, is there going to be sufficient manpower to accept these new patients? I know in the medical community, there are physicians who don't take Medicaid. I used to cover orthopedics for the state hospital, and to get dental coverage there was quite difficult. Do you have a sense of manpower with this expanded patient load?
I think that there is the potential for an adequate provider network. One of the members of the working group is the New Hampshire Dental Society. So they have been working alongside everyone else in the work group, and we have discussed at great length what an adequate network would look like and what we need to look for in the design of this plan. But I do feel that there are enough dentists in New Hampshire that we could have an adequate network.
Well, I have another question. I'll wait for other people to ask first.
Representative Snow.
Thank you, Mr. Chairman. And I don't know if this is directed to Representative Shapiro or Dr. Finney, but I think in addition to all the health benefits that we see, I would hope they would agree that the increased employability of Medicaid patients once they have received dental benefits is a very significant factor in passing this bill. Toothless waitresses and toothless sales clerks, et cetera, have a very hard time finding jobs, and having that kind of care would certainly increase their employability and have an impact. Thank you.
Any additional questions for the doctor?
Mr. Chair, could I ask another question?
Representative Woods is recognized.
Well, thank you, Mr. Chair, and thank you again, Dr. Finney. On page 2, on line 23, it is part of the outlining what services would be included in including smoking cessation counseling. At least in the medical community, and I think for this committee in the past, counseling has had a fairly significant and well-described definition. Is that word the appropriate word we need there? Counseling would mean the dentist would then take them under consideration in terms of their medical condition, the availability of medications that would be applied, all of the things that we think of counseling in a physician's office relative to a particular medical entity. Is this the word we want here?
I think that this is a good starting point. What would actually happen is during the process of having an RFI go out prior to an RFP, we would be asking some specific questions about how certain care would be delivered, and we would get more definition under what smoking cessation would include besides counseling. And then that would move forward into the RFP. Did that answer your question?
Partially. We'll watch it as it goes along. I have some concerns about the use of that term. I understand that the dentist should be saying you should be stopping your smoking, but rather than that individual counseling, my surmise would be you should be in touch with your family doctor or someone like that for the best way to do that.
I agree. And I think that one of the other things that we are looking for after much discussion with the work group is making sure that we have integration of the medical plan side with the dental plan. And this is a perfect area where the two need to work together to treat the patient appropriately.
I completely agree. Thank you.
You're welcome.
Representative Gay.
Thank you, Mr. Chairman. I guess I'm new at this committee, and I am surprised that everybody knows smoking's bad for you. So I don't think there's anybody would say there was a problem with trying to get people to stop smoking. But in this issue, I would expect the people who treat people for heart disease would be even more interested in getting people to stop smoking. It just seems like adding something to the Christmas tree at this point, especially when we need to get it paid for. To add counseling on top of dental care seems like it's just adding one more cost that doesn't need to be right here. So somewhere there's a question in there. How did y'all decide that smoking cessation counseling, or however you treat smoking, trying to get people to stop, how did you figure it really needs to be in dental?
I would say that the reason that it's very important to be in dental is that when you visit a dentist, part of the examination that we do is an oral cancer exam, a screening exam. And so if your patients are smokers, they are going to be at higher risk of oral cancer. And it absolutely fits into what we should be doing as part of our care for our patients.
Representative Folsom.
Thank you, Chair. Thank you for being here and answering all of our questions. My question for you is, will this include implants? Dental implants?
Not at the last cost estimate did not include implants.
Any further questions? Seeing none, thank you for your testimony.
Representative Snow has his hand up. My apologies.
Representative. Who? No.
I had it up for the last question I asked, and I'm no longer, have no other questions.
Thank you. Then thank you for your testimony. And the chair recognizes Henry Lipman from DHHS.
Good afternoon, Mr. Chairman and members of the committee. I think Sarah's done a nice job in answering a lot of the questions about this. We have worked with actuaries to develop several estimates, and the most recent one being in August of 2020. Part of the estimate addressing Representative Wood's question about provider network adequacy was an assumption that there would need to be a rate adjustment over current Medicaid levels to get the level of dental participation, and that's built into our cost estimate. And I believe with respect to the smoking cessation, that smoking cessation is part of the overall Medicaid benefit, so I'm not sure it represents an increase in cost per se, but we can come back with that specifically to address that question. I think the other issue that I would like to raise is sort of one of timing. I think Representative Shapiro, in introducing the legislation, talked about the enrollment. Enrollment before the public health emergency was in the Medicaid program was 176,000 individuals, including about 90,000 children. Today, we're probably around 214,000 individuals enrolled in Medicaid. The largest group that has grown is the expansion, the Granted Advantage program. And I'm not sure whether with all the other budget challenges in terms of we would need to wait for the public health emergency, I think, to really realistically finance this. We have not prepared our cost estimates to this point, including that we would do it at the peak of the public health emergency.
Thank you. Would you take questions?
Absolutely. Thank you.
Questions, Mr. Lippman?
Mr. Chairman,
Yes?
if I may.
Yes, Representative Merchant.
Thank you, Mr. Chairman. Thank you, Mr. Lippman. With Medicaid, there's a cost sharing with federal government, right? Is it applied to dental benefits as well as to medical and drug benefits as well?
Yes, it does. The assumption is for standard Medicaid program, the cost sharing would be 50%, and for the expansion Granted Advantage program, it would be 90% federal.
Mr. Chairman, a follow-up?
Follow-up?
When the fiscal analysis is performed, will that also be noted in the fiscal analysis for us?
Yes, it will be, and we have been running it on that basis all along.
Thank you.
Any further questions for Mr. Lippman? See, where I'm sitting, I really barely cannot see folks. So what I've been having is people have been texting me, telling me whose hand is up. And I appreciate that. When the person doing that is quite busy doing something else, I don't always see you. So it's not out of order for you to ask, as Representative Merchant just did. Anyone else? Thank you.
One little bitty number.
The representative from Salem is recognized for, as she puts it, one little bitty question.
Thank you. Could you repeat the number, the cost sharing? Was it 50-50? All of a sudden I heard a 90 and a 10 somewhere. So what's the real number?
So there are two cost sharing situations. There's one for people who obtain their eligibility, adults, say, for example, someone who has a disability is in the standard Medicaid program. The federal participation is 50% and the state participation is 50%. In the Medicaid expansion, or otherwise known as the Granted Advantage Healthcare Program in New Hampshire, the federal participation would be 90% and the non-federal share would be 10%.
Thank you.
You're welcome. Thank you for the question.
Chair now recognizes an alumna of this great committee, Polly Campion, RN. Welcome back.
Good afternoon, Mr. Chair and members of the committee. It's so good to see you all again. For the record, since there are new members of this committee, hello, Representative. I'm getting a lot of waves, which is fun to see. My name is Polly Campion, and I was a recent member of this estimable committee. It's a pleasure to see everybody. Today, however, I am speaking as a public citizen from the town of Etna, and I'd like to very briefly share my support of this bill. As you've heard, HB 103 is based on last year's bill and a history that Representative Shapiro discussed. That HB 250 that was passed in both the House and the Senate and came out of your committee actually unanimously with a vote of to pass. Governor Sununu then vetoed the bill based on anticipated state revenues, and there's been much discussion about that to date. While he did support the addition of an adult benefit to the state's Medicaid program. What I'd like to share is my perspective as a recent member of the HHS Oversight Committee. And I think the last committee meeting I attended was in possibly November or December. I can't remember, frankly, at this point. But as a member of that committee, I had the opportunity to hear regular updates from the working group that has been discussed to date. And the working group shared with us the fleshing out of specifics of the cost, of the number of potential beneficiaries, of a range of potential sets of benefits. And Dr. Sarah Finney, with Mr. Lipman and other members of the committee, did a wonderful job engaging in an earnest effort to understand what might be the best pathway forward to cover the necessities while making the benefit more affordable to the state. And as you've heard, there are potential amendments coming forward that may address extending the timeline and potentially describing more explicitly what the covered benefits would be. Others have spoken about the need to provide dental care to New Hampshire's most vulnerable adults. The COVID-19 emergency has resulted in a greater need as more low-income wage earners have lost their jobs and therefore potential health benefits. A growing body of evidence exists in an association of poor oral health and chronic health conditions, poor dental health and unemployment, poor oral health and the use of emergency departments for treatment of dental trauma, pain, and infection. Medical cost offsets are anticipated, as has been mentioned, as a result of implementation of a dental benefit to those that previously may have accessed emergency care only. Thank you for the opportunity to share this perspective, and thank you explicitly to Dr. Finney for all of the work that she has led, and to Representative Shapiro for introducing this bill to help move this critical benefit forward. So I ask the committee to vote to move this bill forward as amended, if that makes sense. And thank you for your time and attention.
Thank you, and again, welcome back. Any questions?
Thank you.
Thank you very much.
Thank you.
The chair recognizes Michael Auerbach from the New Hampshire Dental Society.
Just want to make sure you can hear me.
Yes.
Thank you, Mr. Chair, and thank you through you to the members. For the record, my name is Michael Auerbach. I'm the Executive Director of the New Hampshire Dental Society. I'm here today in favor of HB 103. The New Hampshire Dental Society is a statewide organization representing over 1,100 members of the dental profession, including dentists, dental hygienists, dental assistants, and dental practice managers. Our mission is to advocate for the practice of dentistry and the advancement of the oral health of the public. And these two items are not mutually exclusive. For many years, the NHDS has consistently advocated to create an adult dental Medicaid benefit. The first most important step was the passage of HB 692 and its subsequent iteration, HB 4, in 2019. Of course, that bill lacks specific details about what form such a benefit would take in New Hampshire, instead creating the HB 4 working group, which is comprised of committed oral health stakeholders, including the NHDS and Dr. Finney. We have since been working diligently with the group to give greater structure and scope to this developing benefit. We all know that provider participation in the state's children's Medicaid program is very low. When surveyed in the fall of 2019, our membership identified reimbursement, the lack of care coordination and navigation, especially with vulnerable populations, and increasing administrative burden as the greatest impediments to participation. This bill represents a great first step, an opportunity to implement vital patient navigation and case management, streamline the system, and bring reimbursement rates up to national averages. The NHDS and other members of the HB4 working group concur that an adult Medicaid dental benefit must consider the pent-up need of this population that has persisted for decades, perhaps their entire adulthood, without dental care. Achieving oral health may require considerable time and effort from both the provider and the patient. We must also consider that some cases may be so significant that removable prosthetics like dentures and partials may be necessary to aid in a patient's employability. The NHDS supports the principle of an adult dental Medicaid benefit and is working diligently with the HB4 working group to make this critical concept a reality for New Hampshire patients. We hope that you will take into consideration the concerns I've just outlined and utilize our dentists' extensive resources and experience as you move to expand the dental benefit to include adults. The NHDS will proudly work with this committee and all legislators to achieve better oral health outcomes in our state. The NHDS strongly believes that an adult benefit, crafted in such a way that it fosters dentist participation in Medicaid, is needed in our state. We believe that HB 103 is an important step forward in achieving this goal, and we ask that you vote it ought to pass. Thank you. I'll take any questions you may have.
Any questions for Mr. Auerbach? I'm going to take one more, and then we will recess this hearing to a later date. At that point, we should know more about what the Senate and the governor are talking about, and we should have information for fiscal note. But one of the co-sponsors, the state representative, I'd like to call on her, Representative Wazir.
Are you doing it now?
Oh. Oh, God, no.
Thank you so much, Mr. Speaker. This is a Representative Wazir representing District 17, Merrimack. And I will not take much of your time to repeat what already been said. And I want to say thank you to Representative Shapiro for outlining all the details. So I just want to echo of what he said and giving my support to this bill. And hopefully you can and your committee will support this bill to pass and give some of those Medicaid recipients have a joyful life and a smile to their face. Thank you so much. And I'll just end with that.
Well, thank you so much, and thank you for co-sponsoring. With that, I'm going to, what's the right term? Well, for now, this hearing to be reopened at a later date when we have more information.
Recess.
And we'll begin here on House Bill 363, creating a committee to study appointing an inspector general for nursing homes in New Hampshire. Representative Fanning, would you introduce your bill, please?
Hi, Mr. Chairman. This is Representative Alexander speaking. I know you didn't recognize me, but Representative Fenton right now is having a child currently, so I'm the one that's going to be introducing this bill, if that's okay.
Yes, thank you, Representative Alexander.
I am. Well, thank you for the opportunity for letting me introduce this bill. For the record, my name is Representative Joe Alexander. I represent the town of Goffstown, or Hillsborough District 6. Representative Fenton contacted me earlier this year, just as another young representative. He outlined that New Hampshire has the second oldest population in the union, and perhaps the nation's oldest nursing home population. And it's critical that we as legislators can do what we do to make sure that no stone is unturned in protecting our most vulnerable. So just recognizing that the COVID crisis has really shown that there are cracks in the system, and it's been stretched. Although we have tried our best, and DHHS and nursing home staff have done a wonderful job, we've still seen 80% of our COVID deaths involve residents in long-term care facilities, which is over twice the national average. We've seen non-medical staffing crunches, including short staff, overtime, extended overtime. And I personally heard from some constituents from the Hillsborough County home that just staff being burnt out from overwork. So while there is already existing oversight, this bill would look at the feasibility to have an independent branch of its own category with an inspector general that's just in charge of general accountability of our current system, regulation, and inspection. So we would first of all, with this committee, study if the position is currently needed given the current system, and what independent audits this inspector general would be responsible for in the long-term care facilities. So just to reiterate, I think this position could be needed, but I'd like to study that further with some representatives. So with that, I would be happy to take questions.
Any questions for Representative Alexander? Representative Cushman.
Thank you, Mr. Chairman. Thank you, Mr. Alexander, Representative Alexander. As a nurse who's worked in long-term care facilities for quite a while, my experience is that we undergo extensive inspections as is, and I just don't, can you tell me the demonstrated need for a separate paid position, separate from the inspections that the long-term care facilities already undergo, and, you know, aside from them having their ombudsman, what is the need for this extra?
Well, Representative, thank you so much for the question. When I was actually contacted by a Hillsborough County administrator as well, that was asking me this very question. And I guess I would say that this committee would look at to what extent this position would be needed, but also like we've seen, like even with that thorough inspection already, we're still seeing problems in the system. So I guess having something that the legislature is doing our due diligence to make sure that these people are taken care of, the most vulnerable, I guess that position, if we determine that that's needed, I think that's an important thing to spend our money on.
Follow up. Do not the county commissions, which are made up of state legislators, already have the ability to inspect?
I mean, I believe they do. I guess I would say is that we are a different body than the county government. So we'll do what we can on our side, and the county governments can make their decisions for themselves on where their funding goes.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman, and thank you, Representative Alexander, for taking my question. I understand that this is that this bill really calls for a study committee. So perhaps reasons why this would be a good idea are premature. But my question is really why the study committee would be made up exclusively of senators and representatives and not have other stakeholders involved.
Well, thank you, Representative, for the question. So I've only been on one other study committee, but the committee itself has only been legislators, and then the legislators would call on others, as opposed to a commission, which has different stakeholders on the actual board. The legislators are the ones that call witnesses and ask for information.
Thank you.
Representative Weber. Representative Weber, you're recognized to ask a question.
I'm sorry, Mr. Chairman, I had my hand up for a question that has been answered, so thank you.
That's quite all right. Thank you. Any other questions for Representative Alexander? Seeing none, I would like to call on, my phone tells me that the prime sponsor, Representative Donovan Fenton, is on the call now. Representative, would you like to speak?
My apologies, he's not here. He was just on the list.
Okay, then chair recognizes, well, they pulled their hands back down. Hey, this is a lot. Then the chair recognizes Teresa Rosenberger to speak.
Thank you, Mr. Chair, and good afternoon, members of the committee. I'm Teresa Rosenberger. I work for the law firm of Bernstein Shore, and I represent the New Hampshire Healthcare Association on this bill. And the Healthcare Association represents most all of the private nursing homes in the state, as well as one of the county homes. Needless to say, we're always happy for you all to do study committees, and particularly this one looking at appointing an inspector general. However, we're not quite sure how this position would fit into the existing regulatory framework. For example, there's Appendix PP of the State Operations Manual, which is guidance to surveyors for long-term care facilities. It's 745 pages long. And it spells out specifically the standards which the nursing homes are held by the state survey agency. And in the case of the nursing homes in New Hampshire, that's the Department of Health and Human Services. So that's already one oversight. There's also oversight at the federal level. And there's in fact, an Office of a Long-Term Care Ombudsman, which advocates on behalf of the residents and conducts on-site visits. And that does some of the same similar things. It's very similar to also what DHHS does, which is investigating and addressing complaints. So I guess our question would be, where does it fit into the structure? How does it fit into the structure? There's tremendous oversight now. I will say during the COVID crisis, the Department of Health and Human Services has been absolutely fabulous to work with. Needless to say, this has been a very stressful situation for the nursing homes, but I will say there is not a telephone call that is made that someone that at HHS doesn't respond to, and really has been working hand in hand, trying as best as possible to deal with this pandemic, as well as protect the residents, as well as keeping the nursing homes going. So we're more than happy to work on this. Needless to say, the most important thing right now for nursing homes is finding the staff and figuring out how to get the census back up so we can actually have the dollars to keep these nursing homes going. It's a really tough situation at the moment. I'm happy to answer any questions. I signed up neutral. We're happy to participate, but also the real question for us is, where does this fit in with all the other regulatory schemes? Thank you very much.
Anyone else to speak? And I would like to.
I have one hand that just shot up. I do apologize, Chairman. It's Carolyn Virtue has just put her hand up.
She beat the falling gavel by a nanosecond. Well done. You are recognized to speak.
Thank you. I believe I am unmuted. Carolyn Virtue, Granite Case Management. I work in community-based care. I have a company that does case management for a home and community-based care waiver. A number of states have taken similar actions such as this. I would ask that as this moves forward, that you include the home and community-based care portions of long-term care as well, not just the nursing homes. Thank you.
Will you take a question from anyone if they have one?
Yes, I would.
With the question. Thank you for your testimony.
Thank you.
Anyone else? And I would like to close the hearing on Bill 363 and open an executive session on the bill. Does someone have, I see a hand, does someone have a motion?
I have a motion to
Representative Cushman has a motion, and your motion is?
to make it inexpedient to legislate.
To make it what?
Inexpedient to legislate.
ITL is the motion. Is there a second?
Representative Marsh seconds.
Marsh, second. Okay, now we may discuss. Would you care to elaborate on your motion of ITL?
Yes, sir.
I'll get Soloway next.
I make the motion to recommend this bill be inexpedient to legislate because I think that it is unnecessary. It's very redundant. We already have the ombudsmans who advocate on behalf of patients and families. We have the county commissions that oversee the nursing homes and can investigate, and they work with the nursing homes. If there's any problems, they can go in and with permission and look. And then we have the state and the federal government who have oversight.
Thank you. Representative Soloway.
Thank you, Mr. Chairman. I'd like to draw your attention to an interesting contrast. This morning, we gave our blessing to HB 187, establishing an oversight over the Commissioner of Health and Human Services. I thought this was a very responsible thing to do. As legislators, it is imperative that we provide regulation over the executive departments of state administration. Okay. Now we take a look at the nursing homes, and we are aware that the nursing homes are inspected by the federal government. They are inspected by the state. They are in about 50% of them in the state. Actually, it's less than that, are run by the counties and have county boards that are overseeing them. That's a lot of existing oversight. The imperative for the legislature is to keep state government lean, effective, agile, and I think all of this does is to add a layer of regulation that repeats sets of regulations that are already in place. It will cost in terms of time, in terms of money, and I don't think it adds anything that isn't already in place. And I thank you for listening.
Anyone else wish to speak?
Mr. Chair, this is Representative Marsh. I wanted to elaborate on my second.
Yes, please.
Yes, and I thank Representative Soloway, who stole a great deal of my thunder. But I wish to also add that the Office of the Long-Term Care Ombudsman adds yet another layer of accountability in this, the most regulated sector of our economy in New Hampshire. And therefore, I don't think adding yet another layer on top is necessary.
Thank you. I would like to hear from other members of the committee on this, please, if you would.
Mr. Chairman.
Yes, Representative Merchant.
Thank you, sir. I would echo both Representative Marsh and Soloway. I see a cost factor being added onto an already burdened system with very little, if any, value proposition to it. So I would be opposed to it because of those factors. We're adding a lot of cost to it with very, if any, benefit accomplished by it.
Thank you very much. Representative Gay.
Thank you. Thank you for taking my statement. This Association of Inspectors General that we all got emailed, this sounds like they just found a nice representative to do what they want to do, which is expand their organization and get more people to pay dues.
Point of order, Ms.
Chair recognizes Representative Weber for point of order.
I'm just going to remind everybody that we do not speculate on other representatives' motivation or you know, what their motivations are or how they were motivated. I think that's an unfortunate step in the wrong direction, and it's very much against the traditions of the House. You know, opposing something is one thing, but attributing motivation or otherwise to a representative is, or anyone else for that matter, is improper.
The chair recognizes Representative Gay.
Well, I apologize for imposing motivation on a representative. Let's just restrict my imposition on the Association of Inspectors General.
Representative Woods.
Thank you, Mr. Chair. I too feel that this is not a necessary entity. I have viewed nursing homes while I was in practice here in Concord for 34 years and used to make rounds at the nursing homes on a monthly basis, each one on a monthly basis, as well as having family members at different nursing homes. And having seen some of the difficulties that they encountered, there are currently mechanisms that are available to both the medical side as well as the patient side if there are difficulties. It's just a matter of, like most things, being aware and then advocating in that particular setting. So I agree. I don't see the necessity, at least at this juncture, for this entity.
Thank you, Representative Woods. Anyone else, please?
Yes, Representative Shapiro.
Yes, sir, please.
I would just like to say that hopefully this is not attributing motivation to the sponsors, but I would just like to point to their intentions, which I think we would all agree that there was terrible tragedy in our nursing homes during the past year. And that's not to blame it on improper or lacking oversight. But I think everybody is struggling with the very high percentage of deaths that occurred within the nursing homes. So I would like to vote for this, but I would have to agree with all the other people who've spoken that I don't really understand how this is a solution that would add value. So I'm going to vote against it.
Thank you. Someone who hasn't spoken, what are your thoughts? It's not just that I like to hear the thoughts of my colleagues, but in begging you to speak, I'm trying to undo my painting myself into a corner. I had said that there would be no votes this afternoon, meaning if somebody needed to go somewhere, you wouldn't be missing anything. So what I was trying to do is see if we had a consensus, because then one or two people absent doesn't make any difference in the vote. So thank you for bailing me out here. Representative Knurk, your hand is up.
Yes, I just wanted to say that my initial impression on this was that I favored it, and I favored it for the idea of being able to bring together all the input of the various other people and have one person who kind of had some responsibility centrally. And in particular, because we did see also some disparities, as I understand, in terms of response to COVID with infection control between different nursing homes. However, I also am quite open to listening to the very important comments made by people who I respect, who have made them, and they have convinced me that I will actually vote against this, even though I initially favored it. Thank you.
Thank you. Representative Copalt.
Thank you, Mr. Chairman. Yes, so I would say my views on this echo what we have already heard. I think that it adds an unnecessarily additional level of regulation and oversight. It's not clear how that would interface with existing oversight, and so I would vote in favor of the motion to ITL.
Thank you. Representative Nelson.
I agree with that, what everybody said. ITL.
Thank you. I represent my county delegation job is to oversee the nursing home, and having visited people in the nursing home all my professional life and much of my childhood, I do see a lot of inspection going on already. Anyone else before we call a question? Representative Snow.
I'll be very brief. I also don't think this is necessary.
Thank you. Anyone else? The motion is ITL, moved by Representative Cushman, seconded by Representative Marsh. Would the clerk please call the roll?
Representative Marsh,
Votes yes.
Representative McMahon,
Yes.
Representative Nelson,
Yes.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
Yes.
Representative Folsom, yes. Representative Kelsey,
Yes.
Representative King,
Yes.
Representative Copal,
Yes.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knirk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes. Yes.
Gibson.
Yes. 21-0. Where am I?
Yes.
Thank you. All right, the next bill is called for 3
How
o'clock.
about consent? Should that go in consent?
Unless there's an objection that you can give a reason for it, it should go on consent, yeah. Thank you. Representative Cushman will write the word. The next,
No objection.
Representative Soloway.
Mr. Chairman, a point of personal preference. It is nearing 2:30, and in the comfort and warmth of my own home, I have been watching the national weather forecast as it pertains to New Hampshire. I'd like to point out that snow is forecast to begin in earnest about 3 o'clock, and members of the committee who are in Concord, who live in Hillsborough, Rockingham, and Stratford counties, are very likely to encounter snow on the roads as they leave Concord. May I respectfully recommend that the committee adjourn or go into recess until tomorrow and give people a chance to get home safely.
Any discussion on this?
I will just say, I don't think we can, I would check with the House Clerk on this because I have been chastised about it before and I'm not sure how it came out, but I think if we recess today for a hearing scheduled for today, I think we have to renotice it, but I'm not sure. I think, but you would have to check that with the House Clerk.
Okay, please stand by. Please stand by.
This bill.
Bonnie, did you have a sandwich?
Yeah.
Okay.
A question for Christina. Christina, can you hear me?
Representative Mark Pearson.
Yes, I can.
Do we have a lineup of people wanting to testify on HB 350?
Yes, we have about 10 people.
Oh, wow. Okay, thank you.
Could we possibly start early on 350?
No,
No,
we
we can't do
cannot
that.
start before
Can't,
another
okay.
time. That one I'm
Actually,
clear on.
yeah, I would like to point out though, looking at the forecast for Concord, it is not starting heavily. It will be starting to snow, but the hourly between 2 o'clock and 7 o'clock is only a half an inch.
No.
5 hours, half an inch is not going to be a real big problem. It's going to be much more than that afterward. And that's Concord. And so I think that even if we're down there, if you're down there, I'm not. I don't think it's going to be that horrendous because this hearing probably shouldn't last that terribly long. And if we're out at 4, you should be home before it really hits with the teeth. And that fits with the radar from the projected radar as well.
Mr. Chairman,
As one of the longer serving members, I will say time was, we didn't stop for anybody. I've had hearings with 3 committee members available for them, but
Right.
I understand the concerns that people have about, but I think it's for the chairman and the person and people in the room to decide that.
Right, and actually,
We're all
if we're
sitting
not going to vote too, people could conceivably say if they're really worried, they could leave if we guarantee no votes.
Right. You don't have to have a quorum to have the hearing. You have to have a quorum to vote.
And we'll all be here on remote anyway.
We have a lot of people here. on
Mr. Chairman, if I may, with Representative Weber, can we start the hearing, but then recess it? Although we started it?
That's what the chair, I think, is discussing with the clerk right now, because I think that I started a hearing on one day and recessed it to the next day. And I think I was told very firmly by the clerk that I couldn't do that. Although I know that I did do it under a previous regime. So I didn't want to.
Either I will give you the official answer or you can continue to guess.
Oh, okay, you go for it.
Mr. Chairman, if you wish us to continue the hearing remotely and the people in Concord have the opportunity to leave, I will be glad to continue the hearing remotely and you can leave if you desire.
And Representative Knirk,
leave.
Yes, sir.
With all due respect, those of you who live in what we refer to as the provinces need to look at the weather, not in Concord, but along the seacoast and in such urban locations as Hampstead in particular, to figure out if people are going to be at risk on the way home.
Not a flake in sight here in
We up
Fremont.
here are so used to it.
Perhaps we could all let our chairman deliver his
Yes.
deliberations and
Verdict.
concerns.
According to the clerk, who is now a co-author of Masons.
Yeah.
I must start the hearing at 3 o'clock. At 3, I can recess the hearing. I just can't bail on it.
Yeah, okay.
I'm prepared to stay for a while. I've got these big long snow tires on and we'll drive slowly on back roads.
Oh.
Here, to leave, I would encourage you to do that, or you'll have to answer to Representative Soloway for the next year. And everyone that's at home, tuning in, can continue. I think what I want to do is get the thing going. at 3 o'clock. I can't move it up. I'd like to go for a while and then recess it, get some of this finished. We have few days to do much stuff. So,
Mr. Chairman,
to leave, if there's no penalty or punishment, I won't think you bad for doing so. But somebody wanted to Marsh.
yes, Mr. Chairman, this is Representative Marsh again. I will point out that you noticed that this hearing that we could hold executive session during the day, and we now have a half an hour to kill before we can begin the hearing on the next bill. So if you have anything you wish to exec, you could bring it up at this time. But if not, we can all chat.
Representative Weber, is that privilege just for bills we've heard today, or can we go back a week?
Well, you have that particular notice in the calendar. I've never liked that notice, but that's not my call. So you can take up any bill that we have heard at this point. You texted me in some consternation some minutes ago because you told people that there would be no more voting today. And then we proceeded to take a vote. So that is between you and your conscience. I think most of us are still here. And perhaps the thing to do would be to have the clerk go down through the roll and just find out how many of us are still here. If we're all still here, there's absolutely no harm, no foul for proceeding as you would. And I think you have the right to proceed anyway. So,
Okay.
But that's up to you.
There's something, so go slow.
Okay, we'll take this in a nice leisurely pace. Okay, this is for attendance. Representative Marsh,
Present.
Representative McMahon.
Here.
Representative Nelson,
Here.
Representative Ashton,
Here.
Representative Gay. Here. Representative Cushman. Present. Representative Folsom. I'm not sure. Representative Kelsey.
Present.
Representative King.
Here.
Representative Colfax.
Here.
Representative Weber.
Here.
Representative McKay.
Here.
Representative Snow.
Here.
Am I going slow enough? Representative Knirk.
Here.
Representative Soloway. Representative Soloway. He has walked out of his room because I see his chair empty. But he's on. But he's still on. Representative Cannon.
I'm here.
Representative Nutter Upham.
I'm also here.
Representative Shapiro. Representative Shapiro. I see you, but you're muted.
I am here.
Thank you. Representative Woods.
I think I'm still here.
Representative Merchant.
Here.
And Representative Pearson.
The body's here, the mind left the building a few hours ago.
And I would really, really like to be sitting in the same couch or whatever it is that Representative Nutter Upham is sitting on. It looks incredibly comfortable.
All right, let's take a look at,
Thank you. It's pretty good.
once this is all over, we'll have a party at your house.
I might have it cleaned up by the end of the pandemic, so.
Yeah. Representative Woods, you introduced your Bill 131 relative to reporting of
Oh,
health.
wonderful. Thank you. I had to open the door for Jennifer, and let Sophie out.
You're unmuted, Jeff. Jeff, you're unmuted. Don't say anything bad.
All right, on January 26th, we looked at, the clerk says we can exec anything we want. Okay, I want the Red Sox to win next year. Relative to reporting of healthcare associated infections, Representative Woods, are we enough along on this that we could go into an executive session, or would you like us to defer it somewhat?
At this juncture, there were a couple of questions from Representative Kofalt and one from Representative Cushman. And I was trying to look at those, and I had a conversation with HHS, and we have a Zoom meeting Wednesday morning with CDC and New Hampshire HHS to just get definitive clarification of exactly what the terms mean, which the term that came into question was measures, and what that meant and what that might imply as far as what this would allow the reviews to accomplish. The second thing was relative to vaccines and relative to what that would imply relative to the administration of those vaccines and whether they're required or not. And if so, yes or no, what that would imply. So I was in the process of getting it clarified. I could only get a Zoom meeting with HHS, and the earliest I could get was Wednesday morning.
You've done diligence, sir, so it's not ready for us to vote on yet.
I would, yes.
Looking at a couple of others that might be ready.
What about HB 290?
You mean the one I have in my hand?
Perfect. Great minds think. Oh, I didn't even have that elbow that I felt.
You know, without being near each other to elbow each other, we're still doing pretty well.
Yeah.
But I have a sort of a general nod or a general You know, we're flying by the seat here. See on 290? Looks to me from my notes that there's not questions, it's just we agree or we disagree, but it doesn't look like it needs a lot of work. All right, then we'll do it. Opening a hearing on House Bill 290 relative to, excuse me, I'm opening an executive session on House Bill 290 relative to policies required for health facilities and special health care licenses. Anyone may speak. I can even read the text of the bill if you don't have it handy. Adopt and enforce a written policy to ensure that the facility provides its services to all persons who require the services the facility provides, regardless of the source of payment for services provided to any person. And here's the change. Unless the facility exclusively provides services to persons who make direct payment for services. For the purposes of this paragraph, a direct payment is one that is paid directly by the patient and not reimbursed or otherwise paid by a third party. And the question, if you remember in the discussion, was wouldn't this be skimming off the cream, and people who couldn't pay or couldn't pay at all would wind up going only to certain facilities which financially might swamp them. That was the general tone of the discussion. So I'm open for further discussion.
May I, Mr. Chair?
Yes, please, Representative Knurr.
To initiate the discussion, may I move ITL?
You may.
And I would second it.
And that was?
Representative Weber.
No, you. Yes, thank you. Okay, so there is the motion on the floor. Now let's discuss. Would you
May
like?
I speak to my motion?
Yeah, continue, Representative Knurr.
Okay, thank you very much. Yes, the reason I move ITL on this is that it will do precisely what you were alluding to a moment ago. I served on the legislative committee with Senator Jeb Bradley a year and a half ago, in which we were looking at this issue about the impact on critical access hospitals of facilities which are licensed somewhere in the area of the critical access hospital, and that was for license. This one allows people to just go ahead and just do whatever they want. And I think the problem is that this will skim off the high-paying cash customers or people who have deductibles but are still paying some cash, and it will significantly impact our critical access hospitals. Many of them run on margins that are either in the red or barely in the black by perhaps 0.5%. And when we looked at this, even just the whole idea of an urgent care opening somewhere in the vicinity of a critical access hospital could be a death knell, because as anybody knows a little bit about how we finance hospitals, you don't get a lot of money out of things like labor and delivery, because that's mostly Medicaid. You don't get a lot of money out of emergency room visits because they're often uninsured or underpaid. And you get it out of the high-paying things such as orthopedics, elective procedures, physical exams, things like that that are reimbursed better, and they subsidize what happens, and including also imaging and all those things. So if we allow somebody who says, hey, you pay cash in the barrel, you can come here and no problem, and we can be anywhere we want, that may have a significant impact on our critical access hospitals, which are critical to serve people. And the comment was made earlier today, I think, about losing, for example, labor and delivery hospitals. We have already lost some. And if we lose some more, it's going to be a real long time. And in fact, I already understand in Laconia, the fire department has delivered many more babies in the last year than what they did in previous years, because people can't make it to a hospital in time to have their child. So that's the major concern that I have with this bill, is that it really is going to negatively impact a lot of our hospitals, but particularly critical access hospitals. And it looks like it really deals with, lots of facility type of things. It's not just a surgery center, but that will also be an important impact, because if it takes away the surgical business, that eats into the hospital. And lastly, the comment was made that this money would probably not be tracked in terms of their deductible. And so they still would end up having to pay a deductible later for something else. I think I understood that part. Enough. Thank you.
Thank you. Representative Weber.
Thank you, Mr. Chairman. I was going to speak to my second, but I think that Representative Knirk has said everything that needs to be said on the subject. So I will just say that I agree with him. Thank you.
Representative Snow.
Thank you, Mr. Chairman. I believe we did get an email, and I don't remember the source, that I can't go through. I only have one computer, so I can't go off here to go look for it. But I think it came from someone within the Department of Health and Human Services that said there's already a law that states that listing facilities, hospitals, blah, 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 must take care of everybody that comes. Certain other ones like recovery houses, support homes, group homes, adult daycare, home and community service facilities, and doctor's offices and some kind of clinics do not have to take everybody who walks in. And so to me, it becomes kind of meaningless. I think I agree that it should be ITL, because it just draws attention to the fact that there's already laws that allow certain people that should be taking everybody that comes in and don't come. If anything, we ought to take a look at that other law and look at ones that should no longer be excluded from having to take everybody that comes in.
Representative Marsh.
Thank you, Mr. Chairman. I am in some ways conflicted, because I do support free market health care. As you know, it was my bill that was the direct primary care bill that the sponsors referred to when they gave their testimony. That being said, as I said at the hearing, I am troubled by the association of hospital bankruptcies and closures in Oklahoma, close to the Surgery Center of Oklahoma, which is the model that this bill would follow. And I don't believe that there are adequate protections for such facilities in the state of New Hampshire. We've lost enough hospitals in New Hampshire already, and we certainly don't need to lose more. There was analogy made between direct primary care and this bill. And as I pointed out at the hearing, I don't think that that is quite true. Direct primary care pays physicians on a retainer. And in order to have something similar to that for facilities, you would have to pay the facilities on a retainer. And in many ways, we could create a free market system that's very much like ambulatory care organization, like accountable care organizations. And I think we might find that the left and the right meet in the middle if we were to explore that further. So I'm afraid this bill is drafted. I will regrettably have to vote in favor of ITL.
Anyone else?
Mr. Chairman, if I might follow up, I looked up in my notes, and apparently that mention that I talked about came from Paula Minahan at the New Hampshire Hospital Association.
Thank you for that clarification, Representative. Representative Cushman.
Thank you, Mr. Chairman. I will speak in opposition to the ITL recommendation motion that's on the floor right now. I support this bill as it's written. I believe that it will help to drive healthcare costs down by allowing practitioners to only accept direct payment. There will be less administrative costs, no need to be under an umbrella reimbursement system. It'll help the gig economy and others who work and people who work in it who don't have traditional employer-based health insurance and may not qualify for Medicaid. And I believe that it's only can do good things for the healthcare market in New Hampshire, and that closures of hospitals around the Oklahoma facility that offers this kind of service, there's no evidence that those closures are directly related to that. And we have bankruptcies of hospitals in New Hampshire without this in law. So I ask that the others of the committee will vote no on inexpedient to legislate.
Thank you very much. Representative Acton.
Thank you, Mr. Chair. You know, I understand both sides of the story here, and it just seems to me that we're stifling innovation to prop up a system that really just isn't working. And when hospitals are going into bankruptcy, that's a sign of problems that need to be fixed themselves, rather than shutting down and in essence creating monopolies for these facilities and or for the existing traditional hospitals. So if someone has, I'm still on the fence here. So if someone wants to try to convince me, feel free.
Well, maybe Representative Woods can do that. You're up, sir.
Thank you. I'm not a policy guru as much as some of the folks here, but I guess my sense would be if this were taken to its extreme, let's just pretend that would it in fact put us back to the way insurance was to beginning. There was no direct contracting. You had your insurance, you got a bill, you paid it, and then you had to get the insurance company to pay you. And it seems like taken in its extreme, that's where we might end up going. I may be wrong, but and that's not where we would want to go. So I'm not in favor.
Anyone else?
He's not in favor of what?
Of ITL.
Of ITL.
Mr. Chairman, if I may.
Representative Merchant.
Thank you, Mr. Chairman. I support ITL. I believe at this point, the intent of the bill has some merits to it, but the way it's written, I think it's problematic. I do believe that right now, when you're talking about trying to get a group of providers together to deal with some of the high level cost of things like hospital costs and so forth, I don't know where primary care providers want to get into that arena to begin with. Is very costly. Number two, I think it, to Representative Marsh's point of view and some of the other folks here on the call, I do see a slippery slope where we're starting to take some of the opportunity for some of the critical access hospitals to keep themselves afloat. And right now they're on the edge of going below water financially. And I think this is going to be a possibility of causing more disruption in that marketplace and ultimately lead to not having healthcare in some of the rural America that we need to have. So therefore, I would vote to ITL it.
Thank you. Representative Kofalt.
Thank you, Mr. Chairman. So I guess I'd like to start by correcting what I believe is a misconception that came out of the last hearing when we were talking about, or when someone was talking about reimbursement. For those who direct pay would, if they're on a high deductible plan, that they would subsequently need to meet that deductible again. Having been in a high deductible plan, I can tell you that whenever our family has direct pay for services, we hold on to those receipts. We can submit those to the insurer, and they do count towards the deductible. So that's just a point of fact around that question. I guess my concern is that we've talked about the value of free market healthcare, and the concern is that direct pay providers are siphoning off the most profitable customers from facilities that will otherwise be left with a less profitable or unprofitable population that they're serving. I guess to me, that's a sort of a de facto admission that there is a hidden subsidy built into this. And while I don't believe that we're necessarily going to solve that problem by passing or not passing this bill, my concern is that there are forces in play that discourage innovation and that discourage effective cost containment. And that by encouraging this kind of free choice for consumers in the healthcare market, as well as encouraging innovation and competition, we are encouraging the kind of cost containment and innovation that ultimately benefits everyone. So I will vote against the motion to ITL.
Representative Weber.
Thank you, Mr. Chairman. To speak to Representative Acton's question, I think the thing is this. If we had a completely free market in medical care, we would be back to where we were pre all of the existing rules and regulations and insurances and everything else. And that would mean that people who had money would get care and people who didn't have money would not get care. And I'm not for going back to that. Some of us would actually like to see universal health care wherein everybody gets care, and that's that. But I realize that also is not the situation in which we live and may never be, who knows. But what we have, the way I look at it is we have to deal with the system as it is now. And if we thrust ahead with this innovation, which, is going to certainly change things in some direction, we don't know what, the real risk is taking what we have now, which is providing critical care to people who will be without it, unless we keep some of the current structure until we figure out what to do for the best to replace it. I think it, for me, it's not a great idea to kick one of the props out of a three-legged stool before we've got another prop to put under it. So my thought is that let's keep our do everything we can to keep our critical access hospitals going, because they are providing very, very needed services that are not going to be readily replaced by anybody else, because they're not the ones that are the most lucrative. So that's my plea. Thank you.
Thank you. Anyone else wishes to speak? Representative Gay.
Thank you, Mr. Chairman. I agree with Lucy that, well, I agree with both sides, because yes, I would like to see the cost of medical care drop, because as we would take care of our own processing with our insurance. The real issue that I've seen ever since my mother went into, excuse me, a private pay plus Medicaid nursing home, is that Medicaid simply does not pay enough to keep hospitals open. And so right now, the way the fee schedule is, if a hospital only has Medicaid, what's the right word, patients, it can't stay. It just can't make it. So we have to come out, if we want to change it and cut some costs, this will not do it, because this will just wipe out the positive flow of money that's keeping the hospitals open. So I agree there's a problem. I agree we ought to find a solution, but right now, this is not the solution. We'll just stop keeping hospitals open that right now cannot survive on Medicaid.
Thank you. Representative Knurk.
Yes, I just want to reflect back to some previous comments about getting the free market to work. The problem is that healthcare simply doesn't function as a free market. Healthcare is infrastructure, and in a free market, and it's a great option for a consumer good. You can have different companies working to produce the best good at the lowest price, and you can buy it, and you can compare and shop, and you also have the choice to not buy it if you think it is more money than you wish to spend for that good. Medicine doesn't work that way. If you're sitting there in the EW with a broken ankle, or better yet, an inflamed appendix, and you need it taken care of, you're not going to be able to shop around other hospitals to find out who has a better deal. And it's probably not going to be wise to be able to say, I think that costs too much, I will not elect to have that surgery. That's not going to lead to a good outcome. So it simply doesn't function as a free market. And so what happens here is, again, these places work 9 to 5 hours, or maybe 7 to 5 hours. They take the elective stuff that pays well. And the problem is then you cannot, as Representative Gay just pointed out, support a local hospital on the reimbursements that are left over. They will not be there. And the reason they're called critical access is that they're there to provide the critical care for people in the community, because when you do get run over by a truck, you can't necessarily be transported 100 miles to some other hospital because there's none around. We need them in our rural areas and even our more urban areas for people who can't afford the other hospitals. But the key issue is, no matter how you shake it, if you pull out the money from them, we're going to lose them. And that will have an enormous impact on the accessibility of all of us to healthcare, and because it just doesn't function like a free market. Thank you.
Thank you. Representative Shapiro.
Thank you, Mr. Chairman. I think it's great that we had this extra time so we could have a philosophical debate about open markets, but we're probably not going to convince one another. I mean, there are those of us who feel like the problem with medicine is that it's based on free markets, and then there's others of us who feel like the problem is that it's not free market enough. So we're probably not going to convince each other, although I think it's a good thing to talk about. I also served on that committee with Representative Knurk, and for me, when people came to speak from critical care hospitals in the North Country, they spoke about the possibility of having to do without obstetrics in their communities. But to me, the most poignant thing was when people talked about a hospital, the risk of a hospital closing and there just not being an emergency room in a community. And, we are lucky to live in a country where we are used to and feel like we deserve to be able to go to an emergency room in case of a critical emergency. And that just might not be the case if financial pressure causes some of these hospitals to close. So I would support voting to ITL this bill.
I'd like to move on to our 3 o'clock hearing in a minute, but the last name I have is again Representative Kofal.
I did not have my hand up. I had already given my comments.
Thank you very much. The motion on House bill, I get so many.
290.
is 290. The motion is inexpedient to legislate, moved by Representative Knurk, seconded by Representative Weber. Would the clerk call the roll, please?
Representative March,
Reluctantly, yes.
Representative McMahon,
Yes.
Representative Nelson,
Yeah, yes.
Representative Acton,
Yes.
Representative Gay,
Yes.
Representative Cushman,
No.
Representative Folsom, yay. Representative Kelsey,
No.
Representative King,
Yes.
Representative Copal,
No.
Representative Weber,
Yes.
Representative McKay,
Yes.
Representative Snow,
Yes.
Representative Knurk,
Yes.
Representative Soloway,
Yes.
Representative Cannon,
Yes.
Representative Nutter Upham,
Yes.
Representative Shapiro,
Yes.
Representative Woods,
Yes.
Representative Merchant,
Yes.
Representative Pearson.
Yes.
18-3.
18-3, the motion inexpedient to legislate passes. Representative Knurk, would you write the majority report?
Yes, sir.
And would you wish to write the minority report?
Sure.
Representative Cushman, thank you. This closes the executive session on tonight. The committee hearing on Bill 350, permitting qualified patients and designated caregivers to cultivate cannabis for therapeutic use. And I will point out to those on this bill, it is an important bill. We respect what you are bringing forward to us, as we do with all bills, but because of impending weather, numbers of us will be leaving. I'd like to hear from 3 or 4 good speakers on this bill, and then we will move it to a continuance on another date. Representative Acton, would you introduce your bill, please?
Okay, thank you, Mr. Chair, and thank you all for your time. What we have here is HB 350, permitting qualified patients and designated caregivers to cultivate cannabis for therapeutic use. Now, this bill has passed the House several times, so I'd originally considered, to be honest with you, rather than going through the same thing again and again, of retaining this bill and dealing with the next session. But I think that does a disservice to patients who are suffering right now. And let me explain why I think that way. Basically, what we're doing is we're allowing patients and designated caregivers to grow their own cannabis at home. And it allows for 3 mature plants, 3 immature plants, and 12 seedlings to be cultivated in a secure location out of sight of neighbors, within the either the caregiver's home or the patient's home, so that you can't set up a commercial grow room or anything like that. So a lot of work has gone into this over the years. We put a lot of work into it in 2019, did a lot of changes and so forth, but we're not unable to get it through. Maybe this time will be the time it works. Let's just a lot of people who are against this can't seem to comprehend how we could allow people to grow cannabis. How do you not control that? Well, let's take a look at the states around us. In Maine, any adult, not just medical, can grow up to 6 adult plants in their own home. Anyone. It's recreational grow. The same with Massachusetts. In Massachusetts, you're allowed to grow 6 plants and 2 people in a home you can grow 12 plants. You're also allowed to give an ounce of cannabis to other people. In Vermont, you're allowed to grow 9 plants, and this is all, once again, not just medical, it's anyone. Rhode Island, 6 plants. So this is already happening for anyone in the rest of New England. Connecticut doesn't have this, but as far as all the states surrounding us, and even in Canada, adults are allowed to do this, and we've yet to even allow our patients to do it. Now, why patients need to do it is first of all, affordability. It is extremely expensive. We created this program with a lot of overhead, a lot of regulations, and the end result is high prices for patients. And these are desperately ill people, and they really it's difficult to afford going to the alternative treatment centers. Secondly, is variety. There's we've learned over the years that certain strains have different effects for various illnesses and effects for different people and so forth. The alternative treatment centers can't provide that. They can't have that. It'd be impossible for them to have the variety of strains that are needed to treat individual ailments. So this would allow patients or designated caregivers to grow the specific strains for the specific patient. So really, that's what we're trying to do here. We hear a lot of fear mongering sometimes about how people, what are they going to give it to their friends? Are they going to, is it, kids and so forth? But boy, we're far behind other states, and I don't understand anymore why we can't just allow patients to do that. So I'm going to go ahead and conclude my testimony, and there's certainly, if anyone has any questions, myself or one of the speakers coming after me can answer them. Thank you.
Any questions for Representative Acton?
I have one.
Yes, Representative Folsom.
Thank you, Chair. Thank you for taking this question. I've been reading all the emails that have been coming in about this, and so it's left me with some questions. I'm kind of ambivalent on this whole thing, but one of the things I wanted to know is what is approximately the current prices for an ounce of marijuana purchased at a dispensary?
The going price in New Hampshire is between $350 and $400, and that's very expensive. That's a lot of money. Some people need several ounces a month for their treatment, so that's that price could be cut tremendously by growing your own.
Okay, then my next question is not incriminating yourself, but what is the going rate for black market marijuana per ounce?
The going rate, it depends. It's usually $150 to $200, probably pushing $200 for the medical quality that has been grown in a controlled facility and so forth. And that is part of the problems. You just, on the black market, you don't know what you're getting. And in this case, growing your own, you can control the process and know that you're producing quality product for yourself.
And how much would an ounce grown at home eventually cost the person thinking about lighting and heat and?
Sure, it's usually for 3 plants you'd use probably a high high power lighting, maybe 1,000-watt light. It costs between $50 and $60 a month to run that. So it's pennies on the dollar less. It's just overhead costs. It's utilities and time doesn't matter, but it's basically the utilities and the fertilizer and the hardware and so forth, which you buy once and you can use repeatedly.
So that.
One more.
So that would equate to what per ounce?
Probably $25 an ounce.
Okay. Thank you.
Any other questions for Representative Acton?
Yes, Mr. Chairman,
Yes, Representative Nelson.
how many plants can a designator caregiver grow for people? Can they grow for 10 people or just 1 or 2?
No, that's been limited. So a designated caregiver can only grow for one person. And we didn't want to create, pot shops or commercial grows where one person can bring on. And they had that issue up in Maine where you could have one caregiver could grow for 6 people, and so we wanted to avoid that. So it's really a caregiver is allowed to grow for only one person, and now a patient can grow for themselves and also grow as a caregiver for somebody else. So that would be the maximum of 6 plants for one location in that instance only.
Follow-up question?
Sure.
Yes.
Are all these people registered who is going to receive it or who could grow it for them?
Yes, everyone has to be a part of the program. So you have to be licensed either as a patient or as a caregiver. And there's strict rules. We created a special felony for diverting cannabis out of the program. And say if somebody was caught selling it to just whoever, they would actually be guilty of the special felony that we created for this program, as well as any other generic felonies that are already on the book. So you're in big trouble if you get caught diverting therapeutic cannabis out of this program to somebody else. I don't believe they've even arrested anybody on that yet.
Thank you.
Representative Gay.
Thank you, Mr. Chairman. Not that I disagree with it, but I thought you just said that you could grow it for a caregiver could grow it for one person. But on page 1, lines 11 and 12, 1 through 15, it says a caregiver can assist with 1 or more not to exceed 5 qualifying patients. And if they live greater than 50 miles away, they can assist grow cannabis for up to 9 qualifying patients. I'm not disagreeing with that. I just wanted to point that out.
Yeah, it's been 2 years since we went through this line by line, so I may have to get clarification. Like if Michael Holt is here, that would be. But yeah, I may have gotten that one wrong there. We'll have to clarify that for you.
I do.
Follow-up question, Representative Gay.
Thank you. So I keep wanting to make a statement and I haven't figured out how to make it into a question.
Actually, Representative Gay, can I just have a follow-up on the last question? A caregiver can assist patients by, say, going and obtaining cannabis at the alternative treatment center for them, but you can only grow for one person. So you can help patients in the traditional role of being a caregiver, which is usually just if someone's too sick to leave the house, you have a caregiver go to the ATC, get that for them. Being the caregiver, they're protected from arrest if they get pulled over or something, but you can only grow for one person. So you can't grow for 5 people and have a house full of pot plants.
Any other questions for Representative Acton?
Yeah, Mr. Chair, Representative Knurk.
Representative Knurk, yes, please.
Just a quick one. We spent a lot of time talking about financial barriers. Is it true also that they are geographical access barriers for patients in the therapeutic cannabis program? And could you discuss those?
Yes, well, that's been a problem from the get-go is the location of the ATCs and the small amount of licenses. Like for instance, for me to go to the alternative treatment center, it's in Dover. It's about a 45-minute drive, but it gets much worse as you go north. And so being able to grow at home, as always, you guys get the raw end of the deal up there. But what we've allowed, and we've made some in the law itself. There's some things have been changed for that, but in general, it's hours of driving if you're in the North Country to get to a treatment center. So growing at home, and thank you for reminding me about that, Representative Knurk, because that is an issue. that us flatlanders down here forget is that it takes, you got to drive 2 hours to do anything, you know, so it's unfair to patients up north.
Thank you.
Anyone else? Yes, Representative Folsom.
Thank you, Mr. Chair. Representative Acton, are there any guidelines with regards to training or classes of some kind for individuals who are going to grow the cannabis on their own and then turn it into whatever form of product they want, so that they understand potency for gummy bear?
Yeah, there's not much formal training. Certainly not in New Hampshire, because it's really not, there's just no market. All information you'd ever want to know is all on YouTube. So there's thousands of hours of training videos online that people can watch, and that's how I got a lot of my information, just watching, because, you know, this has been going on for over 10 years now around the country. So the body of knowledge is quite amazing. So the information is there. It's just all online rather than going and actually training at a facility or something like that. That doesn't quite exist. Certainly not here in New Hampshire, and I'm not sure where else, but the information is out there, and very specific recipes and so forth to follow.
Thank you. Thank you for introducing the bill. The chair would now like to take out of order, Chief.
I have one more question.
Sure.
All right, go ahead. Go ahead.
Representative Acton, thank you for introducing this. We've talked about relative pros and cons of you know, not wanting to promote use for adolescents, you know, ways that cannabis grown at home might fall into the wrong hands. On the other side, there's the geographical issues and there's the cost issues. But I'm wondering if you could conceive that people who are actually able to grow their own cannabis, that there might be some value added just in being able to grow their own, in terms of self-reliance, in terms of putting their hands in the soil, in terms of, you know, just this is the live free or die state, and might there not be some value gained in people being able to take care of themselves?
Yes, well, that's part of it as well. And patients, I think, want to be, there's a therapeutic aspect to growing. We all understand that who are gardeners, there's a therapeutic aspect to that. And so to be able to produce exactly what the strain that you want, and controlling it in your own home, I think there's value to that. I haven't grown, but I'm an avid gardener, and there's an intrinsic value to that really it is part of the healing.
Dr. came into the living room with his boots on because it was snowing. I guess you're eating, you can't talk on the phone. I'll try you in a few more minutes.
Thank you very much. The chair now recognizes Chief Rafonski.
Yes, good afternoon. Can you hear me?
Yes.
Mute again.
We cannot hear you. Muted. No, you're muted.
And Mr. Chairman, while the chief is unmuting, could I remind Representative Snow to please mute? I think we're hearing background conversations.
Ooh, sorry.
Well, and I'll apologize for my telephone going off when I was unmuted. I'm sorry.
One more chance for Chief Profonsky. Maybe we can hook him up later.
He just,
Can you hear me?
yes,
Yeah.
we could. He's toggling.
You're muted again, sir.
Okay, let me just, I have to hold the space bar down apparently. Okay. Okay, ready to go? All right. So I'm here representing the New Hampshire Chiefs, and sorry for the technical issues. The chiefs of police here in New Hampshire are opposed to this bill for the following reasons. As we all know, cannabis is already widely available to qualifying patients in the well-regulated therapeutic cannabis program. But again, as a reminder, cannabis is not commercialized in New Hampshire like it is in our neighboring states of Maine and Vermont. So that is an unfair comparison because it is not commercialized here. This bill, we're concerned primarily because this bill removes the necessary regulatory and regulation and controls over the distribution, growing and distribution of cannabis for medical purposes. There are ample studies that provide scientific proof that high potency cannabis leads to a host of medical and behavioral problems in adults as well as children. If this bill is passed, members of the committee, there is no regulation of the quality and potency of cannabis that will be used for medical purposes. No medicine in any developed country used by medical practitioners is homegrown and dispensed as medicine without any degree of regulation to ensure its quality, effectiveness, and most of all, safety. If homegrown cannabis is approved, there will be absolutely no effective means for law enforcement to control homegrown cannabis. There are absolutely no provisions in this bill to ensure that the requirements for the number and limitation of the amount and number of plants grown and produced is maintained. That's our principal concern. Now, if the bill had ample regulatory applications that would allow for regulatory inspections of locations that are registered for homegrown and home cultivation, then the Chiefs of Police Association would take another look at the bill. Law enforcement and any other regulatory agency is powerless, as the bill is currently constructed, to conduct any kind of periodic regulatory inspections. And in fact, in the previous testimony, as it was introduced, there have been no cases of the diversion of cannabis from the authorized growing sites. And the reason for that is because of the steep challenge that law enforcement faces in being able to control cultivation of marijuana without any regulatory control. There's been ample cases in other states where commercial growers have exploited homegrown cultivation. So this bill basically takes the brakes off cannabis and unleashes commercialization with no boundaries, controls, or mechanisms under the veil of compassionate care. So we're opposed to this particular bill for these reasons, basically because of the inability for any regulatory agency or law enforcement agency to be able to control it. So thank you for your time and thank you for listening.
Will you take questions, Chief? The chair recognizes State Representative Rennie Cushing, a co-sponsor of the bill.
Representative Cushing does not appear to be available.
Okay. The chair recognizes Kate Steinberg.
Hi there.
Hi.
So is now when I read my testimony?
Now is the time.
Perfect. Thank you so much. Clearly my first time doing this, but something I'm very passionate about. So my name is Kate Steinberg. I am a resident of Ashland and Grafton County, and I'm here today asking for your consideration in supporting HB 350. I have been working in the cannabis space for about 5 years, specifically working for a medical cannabis company, and I have seen and heard both sides to this debate. But I am here today to speak on behalf of the patients who are the very reason the state of New Hampshire initially passed the bill allowing medical cannabis patients to access this alternative treatment option. So I ask that even for a moment, you look at this bill and consider the impact it would have for the thousands of patients in this state. With that being said, I would like to note that these thoughts are solely mine and do not represent the thoughts of the company I work for. I was diagnosed with depression and generalized anxiety disorder at the age of 14 and severe thoracic problems at the age of 20. I had tried various pharmaceuticals with minimal success and maximum side effects until I discovered my home state had a medical cannabis program. Within 1 year of becoming a medical cannabis patient, not only did I start my dream job in the cannabis industry, but I also discontinued all use of pharmaceuticals, lost over 40 pounds, and felt more myself than I had felt since I was first diagnosed. There are 2 reasons I would like to ask for your consideration in supporting this bill today: lack of access to a medical cannabis facility and the proven benefits of horticultural therapy. There are only, I believe, 5 dispensaries in the state at this point in time, which means that patients in Pittsburgh must drive up to 2.5 hours to reach their nearest dispensary. That's a 5-hour round trip. And to a patient with debilitating back pain or severe anxiety, this can be an immense barrier to access. Let's just say that patient had young children and a full-time job. Finding the time to make that 5-hour drive would become an even larger barrier. In addition to the patient who has found success with only a handful of strains due to the cannabinoid and terpenoid content, none of which might be available at their nearest dispensary, this can be an immense barrier. To those of you who may not be as familiar with the medicinal properties of cannabis, there are both the cannabinoids like THC and CBD, but there are also terpenes, which are the essential oils found in there as well. And they all work together to make every single strain different. If you were to try a strain that worked perfectly for, let's just say, your severe PTSD or your severe back problems, and it wasn't at your nearest dispensary, you may not find success with the other strains available. Now, to those of you who may not be aware, there is a practice called horticultural therapy, which is a form of therapy utilizing gardening, growing vegetables, fruits, flowers, and other plants for therapeutic purposes. Studies have shown horticultural therapy to improve quality of life for patients with dementia, PTSD, anxiety, cancer, and even for sexual assault survivors. Horticultural therapy has been shown to help improve memory, cognition, task initiation, coordination, balance, strength, and endurance. So imagine the benefits for the patients of New Hampshire should you pass this bill and allow the option for home cultivation. While patients living hours from their nearest dispensary could utilize home cultivation as their primary source of medicine, those living nearby to an alternative treatment center could just grow 1 or 2 plants therapeutically while still supporting their local ATC. That's what I have today, but I wanted to thank you all so much for your time and to let you know to please consider me as a resource should you have any other questions that I can be of assistance with.
Thank you. Does anyone have any questions for Ms. Steinberg? Thank you for your testimony.
Thank you so much.
The chair calls Justin Johnson.
Hi there.
Hello? Can you guys hear me?
Yes, this is Justin Johnson.
Hello, everybody. Thank you for having me here today. I am a New Hampshire cannabis patient. I have been following the story since the legislation has started in terms of the medical cannabis reforms. Specifically, very interested in how we can continue to work with local communities to help people that have debilitating illnesses and diseases acquire the right type of treatment that they need. at a cost-effective measure, as stated by other people previously. It's very hard for patients that have these debilitating diseases to, one, be able to pay for everything when the cost for just a single ounce is drastically higher in our state and in one location. It's very hard, again, to rely on the strains that you're specifically looking for to treat your ailments or to treat anything specifically. And it's difficult because we're getting to a point where in the hospitals, we're not able to have a conversation or a solution around what's the best method as to getting people the treatment they need with the proper resources available there. It's very hard pulling them all together when, again, we have over-policing still being an issue. And it's not that we don't want to, add more things to the bill. As the police chief was saying, we do want, if needed, to have, people come in and check to make sure that things are going correctly. And it would actually be even better if there was a program by the state to help patients or caregivers grow, or to teach them more, like more horticulture classes or whatever is available, just more for the community, so we can actually grow and continue to push forward in these hard times. It's only made it more clear that traveling out of state isn't an option anymore for these patients. Originally, this started with, a woman suing the state for her right to just get a card so she can go to Maine to get medication that she needed. And that's not an option anymore for anybody, even though the surrounding states are legal. It's not wise for anybody to go out of state to travel with medication from a different state into your own state, just based on the current legislation on a federal and state level. So we still need a lot done. That is obvious, but the first step would still be to make sure that patients have the right or a right to grow the specific strains that they need in the smallest amounts possible. Because again, the centers that are available, we don't always have the amount that you can pick up for the strains that you need. So again, those profiles on the strains that you need aren't helping. So it's a very tough issue, I know. There's a lot of different areas that we still need to work on, but I hope that somehow we can figure out how we can work together, not just on a state level, but the whole Northeast here, to figure out what's the best method to try to alleviate some of the terminally ill people and their treatment and the resources that are available that are just very hard for people to reach and to pay for. But I do think that allowing this bill to be passed would, again, displace the illicit market and make sure that people have equal access and a cheaper cost that would dramatically help their condition in the long term of life.
Thank you, Mr. Johnson, for coming to testify before us. Chair recognizes Lisa Powers.
Hello, can you hear me?
You can.
Hi, everyone. Thank you for being here. My name is Lisa Powers. I live in Manchester, New Hampshire. I am a nurse, a cannabis nurse, a cannabis caregiver, a cannabis patient. I do teach people how to grow safely. And just for the record, you can get by with $30 a month increase in your utility bills if you use the right kind of lighting. 3 months of that, you're under $100, and you can have several ounces of your medication that you need for your condition. And if you do it outside, very little cost, and your plant can grow more for you outside typically. So I'm in full support of the bill, as you probably figured that out by now. Hold on just a sec. So I fully support this, and I sent a testimony in, and I did put a little snippet of a cost of the amount that they charge for cannabis at the dispensaries, because you can just go on Google and see that information in the state of New Hampshire and many other states. As a nurse that supports people and how they use cannabis for their specific treatment options, it's very important that they have education and they do it safely. And I agree that testing would be great, but that's going to be too costly. And there's no at-home test kits just yet. I'm sure that will be developed at some point. But patients know when they plant a seed or acquire a clone of a specific strain, they pretty much know a lot about it already because it's been heavily documented on leafly.com and other sources online where you can read about the common effects that cannabis provides to many, many people. So, you know, it's another way that cannabis growers can figure out what they're growing, how strong is it, and how much should they use. So that's not a big problem in what I'm seeing. And patients do need an ounce to maybe 4 ounces a month, depending on their conditions. And just as an example, I have a female patient who reduced her opiate use by 80% in under 30 days using medical cannabis. She couldn't afford all that she needed, but she went to Maine and other, probably black market, I don't know. I tried to stay out of that, and she managed to do that. She can have bowel movements again. She is very happy. We shouldn't stop people from having this medicine. It's unethical and it's inhumane. And that's my nursing perspective because of all the success I'm seeing. We don't want to give it to the children unless, well, it's medically needed. We don't want to divert. We don't want to sell what we grow because we put our effort and our compassion into that. It's made for us as patients. We're not going to sell it. We won't have enough to sell. We need it for ourselves, because if you harvest, say you harvest and maybe you get 15 ounces, you're not going to get rid of that because you need that for the whole year if you're only growing one time a year. So I'm not worried about diversion like the police said. And yeah, the police did say the word control many times. I know they want to control cannabis, but this is different, guys. This is medical needs. The police have control already. Well, maybe they don't because cannabis is just everywhere, you know, but patients should have a right to grow their own plant, their own medicine for the terpenes, the flavonoids, the cannabinoids. It's all in my written testimony. If you want to see more details, I'm not going to read it to you. And I want you guys to know, I am a federal licensed hemp grower in the state of New Hampshire. If anyone would like to learn how to grow, contact me. You can come over, I'll do a show and tell. And do you have any questions?
Any questions? Okay, thank you, yeah.
How do we contact you?
In my email testimony, just use that email and reach out.
Thank you.
Thank you. The chair recognizes Heather Brown.
Ms. Brown, are you available?
No?
It looks like she may be having some technical difficulties. She's unmuted, but we're not able to hear her.
Chair recognizes John Piergalini.
I don't see anyone by that name.
Thank you. The chair recognizes Grant Ellis.
Good afternoon, Mr. Chair. Can you hear me?
And
Thank you, Mr. Chair, and members of the committee for hearing this testimony today and for consideration of this bill. My name is Grant Ellis. I'm the president of the Massachusetts Cannabis Reform Coalition here in my personal capacity, and I'm offering testimony as a bit of a subject matter expert on medical patient and adult use home grow in Massachusetts, in the event that any lessons we might have learned might be able to assist you in your process. I know this bill is multi-years old at this point, and there's a lot of support, and I'm hoping it will be passed in the short term. So in Massachusetts, the representative who introduced the bill, HB 350, mentioned earlier, we have 6 plants for home grow for adult use if you're over 21, 12 plants for home grow in a single home if you have 2 adults over 21 in the home. Our medical home grow actually just got expanded after 3 years as we had so few issues with it. Medical patients in Massachusetts without a hardship grow license can now grow 12 flowering plants, which is a mature plant, and 12 immature plants, and they can have unlimited clones just by having their medical card. And that happened as a result of the fact that there were so few incidents related to home grow. And one thing I will say, Mr. Chair, through you to the committee, is in response to testimony from earlier, it just does not follow naturally based on human patterns of behavior that someone who is growing cannabis at their home, giving all of their information over to the state, putting that information in a database and basically putting a big red X on their back, would then go on to divert the small amount of cannabis that they'd be able to grow under this bill. One thing I will also note to the committee is related to the caregiver provision. So caregivers in your bill now can only grow for 1 patient at a time and then can go to ATCs for up to 9 patients depending on where they live. Massachusetts just increased the number of patients that a caregiver can grow for at any one time from 1 patient to 5 patients, because what Massachusetts found was there were a lot of patients who could not grow their own due to either lack of space or lack of technical know-how, and those caregivers became a vital resource for access to cannabis at accessible prices. And I myself saw that firsthand. I fell disabled while in graduate school in 2014. After I fell disabled, I was in the hospital for 18 months and on a substantial amount of narcotic medication. Within 30 days of starting medical cannabis, I saw that narcotic usage drop by 30%, and within 12 months, I was narcotic free. So thank you very much for your time, and I'm happy to answer any questions, Mr. Chairman.
Any questions for Mr. Ellis?
Yes.
Go ahead, please.
Thank you, Mr. Chairman, and thank you for taking this question, Mr. Ellis. I'm a little embarrassed to ask somebody from Massachusetts about the specifics of our bill. But in listening to the chief from the Police Chiefs Association and trying to quickly read through the bill, it's unclear to me in this bill or in your statutes in Massachusetts, if someone is growing cannabis at home for medical use, do they have to register that with the state? And if so, wouldn't that contradict what law enforcement's concern about it being completely unregulated?
Mr. Chair, through you, thank you for the question, Representative. The New Hampshire bill, I believe, provides for registration of the caregiver and the patient, and then indicates where the grow will take place, as it may only be at the home of the registered patient or caregiver. Massachusetts, for home grow, goes a little bit beyond that. And what we actually have is, if you want to just grow for yourself at home, either as a medical patient with that 24 plant cap or as an adult use home grow, you don't have to do anything. You don't have to register it. You don't have to be in the system. If you're a medical patient, you have to be in the system. But if you want to grow more than that, if you need a hardship, or if you're a caregiver growing for more than 1 patient, you then have to get an electrical inspection, a fire inspection, and then provide handwritten records for the cost that you put into your grow for inspection by the commission. But I think the distinction there is the size of the grow. So a grow below 6 to 12 plants where the person's name and address are on file with the state through the medical program, I don't think that extra level of oversight would be necessary.
Thank you. Anyone else? Thank you, Mr. Ellis.
Thank you, Mr. Chair.
The last name I have on the list is Matt Simon.
Good afternoon. Can you hear me? Thank you, Mr. Chairman. For the record, Matt Simon. I live in Manchester. I work for the Marijuana Policy Project. We're a nonprofit dedicated to cannabis policy reform. I've been coming before this committee for the last 14 years, often with a number of patients who then testified. And I would strongly encourage the committee to continue the House's longstanding policy of supporting bills that would legalize home cultivation of cannabis for registered patients and caregivers. So for the last 15 years, patients have been testifying in this committee, seeking permission to grow their own cannabis without risking arrest and felony prosecution. It is currently a felony for any New Hampshire resident to grow even a single plant. The House has consistently supported that position since 2009. And I did email you a one-pager that lists all the bills that have passed, often with the support of this committee, sometimes despite the lack of support from this committee, but it's always passed the House floor. When it's failed, it has been somewhere else. So in light of that history, I believe it would be unconscionable for this committee to do anything other than to vote ought to pass on HB 350. 8 years following the passage of New Hampshire's therapeutic cannabis law, patients are still complaining about insufficient access, product selection, and lack of affordability. Since home cultivation is currently a felony, many patients have been traveling to Maine in order to obtain products they need at prices they can afford. And many patients have moved out of the state of New Hampshire and in order to live in a place where they feel safer and less likely to be oppressed by people wearing badges and carrying guns. Today, cultivation of cannabis is legal in all 4 neighboring jurisdictions, not only for patients and caregivers, but for all adults. And there is simply no excuse for maintaining criminal penalties to punish limited home cultivation by patients and caregivers in the Live Free or Die state. HB 350 does not need additional work, and it does not require further study. It only needs to pass. Finally, with regard to the police chief's testimony, I'd just like to remind you, the Police Chiefs Association has opposed every medical cannabis bill up to its passage in 2013. They've opposed every home cultivation bill since. They opposed any form of decriminalization until the legislature finally passed it in 2017. They oppose any bill, period, that seeks to improve cannabis policies in the state of New Hampshire. The last thing that patients need is for police officers to enter their homes, to inspect their plants, weigh their cannabis. That is the last thing that somebody who's battling a serious medical condition needs to have happen to them in their own homes. And as the previous speaker noted, the cultivation location must be reported to the department. DHHS will know who's growing and for whom, but law enforcement only gets involved. And this is something that we had to work out details of when the original therapeutic cannabis bill passed. The police chiefs wanted to be able to search that registry. They wanted to be able to go check on anybody and make sure they're complying. And that law had to be written very carefully to protect patient privacy so that law enforcement could only get involved when there was evidence of some kind of problem that indicated potential criminal activity. And so I would encourage you to pass this bill as quickly as possible. Let's have the state live up to its motto with regard to home cultivation of therapeutic cannabis. I'd be happy to take any questions.
Thank you, Mr. Simon. Any questions? Seeing none, I thank you for your testimony. The chair recognizes Asma El-Huni.
Hi, can you hear me?
Yeah.
Yeah, thank you. My name is Asma El-Huni, and I'm speaking on behalf of Rights and Democracy New Hampshire. I will keep this short. I don't know what to say about this bill except it shouldn't be a controversial bill. This is a way for people to afford their medicine. You heard that there are therapeutic aspects, there's medicinal aspects. You heard people shouldn't need to drive close to 2 hours to get to a dispensary. You heard about this working fine in Massachusetts. So I can't understand why anyone would vote against this. People don't, we don't deserve to have a wall between a patient and their medicine. Let's talk about the fact that if you vote against this, you're keeping people from stopping anxiety or from keeping physical pain away, right? That cannabis treats, for sleep problems, or the many, many other reasons why people need medicinal cannabis, but can't drive 1 or 2 hours to get to their medicine. And I mean, do you think it's okay to travel for your medicine when you get medicine, right? Or do you have the decency and deserve medicine not too far away from you? Yeah, and just want to say, people grow herbs. I know the police officer said, oh, people aren't. No, people grow herbs for medicinal reasons. And there's many different herbs that people grow in their gardens that help them. So this is no different. So do the ethical thing, please, and pass this bill already. The people of New Hampshire deserve this. Thank you so much.
Thank you very much for your testimony.
Thanks.
We need to call on Ellen Brown.
Hello, thank you very much for your time. My name is Ellen Brown. I am a United States Air Force veteran, and I am also a medical marijuana patient in the state of Massachusetts. And I have been a medical marijuana patient since 2010. The reason for that is once I got out of the service, I moved home to my home state of Massachusetts, and there wasn't a medical marijuana program, and there wasn't home grow. So I moved out to California where they had a functioning medical marijuana program. Hear me, I moved from Massachusetts to California in order to be able to obtain my cannabis safely, in order to be able to get the cannabinoids and the terpenes that I needed. And from moving out to California to a state that did allow for home cultivation, I got my medical marijuana card, and within a week, I was able to start growing my own plants at home. And it was a beautiful, wonderful experience. I don't want to reiterate a lot of what we've heard today, except to say that I completely support all of the wonderful facts and information that has been presented in support of House Bill 350 when we talk about the importance of having patients cultivate so that they can have the best cannabinoids and terpene profiles available for them and whatever their ailment and condition might be, as well as the importance of talking about therapy for cultivating. As a veteran and working with the veteran population, it is very therapeutic to be able to cultivate your own cannabis at home and to be able to grow what you need and to be able to have that freedom to do so, I think is very important. What's going on right now in New Hampshire where you only have 5 dispensaries is something that you need to look into as well. We are, looking into expanding home cultivation, but I do think that the medical marijuana population is, no disrespect, but being clearly underserved if you have 5 brick and mortar dispensaries and no way for patients to cultivate for themselves. New Hampshire is a state that their motto is live free and die. And something I would like to talk about is the importance of cannabis for palliative care. And for myself, my mother passed away 5 years ago, and she was in the state of New Hampshire. She lived in Nashua, and this was back before your medical marijuana program was in effect. And just for myself, for somebody who has done hospice care and taking care of somebody who cannabis absolutely could have helped and benefited, but it wasn't available at the time. My heart definitely breaks for those that find themselves in a position where they have to go to alternative states, or they have to, pick between, am I going to be able to pay a bill versus pay for medicine? So by allowing for home cultivation, those would help to alleviate those problems and to better serve the medical marijuana community, to better serve the patient population. We always need to act with compassion, and we always need to take those that are the most vulnerable into consideration, those that are unable to drive for themselves, those that are unable to pay those dispensary prices, and how home cultivation could improve quality of life. And you right now have the opportunity to pass the bill as it is. I agree with the last speaker without any debate or looking for, extra to add into it, just as is passing this bill. So that way we can get on the right track to providing those patients with the access they so desperately need. I truly appreciate you taking the time to hear my testimony. I also hold educational seminars in Massachusetts, and I'll put that into my written testimony, but I'm here to help. Other people are here to help. You have a great network of resources that are ready, willing, and able to help you for free to help those patients. So thank you very much for your time.
Coming to the end of our hour, and we've got one more name that's been given to me. Actually, it's a twofer, and it would be Heather and Joe Pinto. And I'd ask you please to be brief because we're coming near to the end. Chair recognizes Heather and Joe Pinto.
I'm actually Heather Marie Brown.
Okay.
So I apologize. I don't know what happened earlier, but if it's all right, I'd like to go ahead when.
Well, you know your name much better than I do, so go right ahead.
All right. Well, my name is Heather Marie Brown. I have been a lifelong resident of New Hampshire. I am a therapeutic cannabis patient and have been for several years now. I am speaking on behalf of House Bill 350. I heard some comments earlier and questions in reference to cost affiliated with this. And I just want to let you know, I myself would be nothing but an outside grower, which means I have a very limited season in order to produce what I need for myself. It's approximately 3 months. I mean, you guys, some of you are gardeners. I'm sure you're aware of our growing season and the way it is. If I were to be successful and acquire what I could acquire per plant, it would cost me an initial investment of approximately $150, which would bring the cost of each ounce down to $5 an ounce. And that's only if the plant provided me with approximately 4 to 5 ounces per plant. And as a lot of you know from growing outside, that is not always possible to get the yield that we want from our garden. I also want to give you a couple of other facts. My income is only approximately $20,000 per year. Of that, I currently pay $16,800 in rent. I pay $2,400 in electric, and I pay $1,200 in heat per year. Just those 3 utilities come to $20,400 per year. As you can see, that's $400 over my income. In order for me to supply myself with cannabis, I am looking at an expense of spending $8,400 a year. Now, from those numbers I just gave you, where am I supposed to pull $8,400 a year from? It's impossible. I found it very difficult to be able to get what I need to take care of myself for my own health conditions. And because of the location of my dispensary, which is over an hour away, and the fact that I have children, it costs me approximately $60 in order to even just take a trip to the dispensary based on gas, childcare, and some of the other added things. And then, you're looking at $700 for me because I use a THC CBD blend. So I would need 1 ounce of each. And with the discount, it's still $350 an ounce. It's still $700 a month potentially. Currently, I do have a caregiver who lives approximately 35 to 40 minutes away from me in Maine, where I can acquire my medical grade cannabis for approximately $150. I may still have the expenses involved with childcare, but I'm spending less time on the road. I'm spending less money on a product, and I'm getting the same quality as I would receive in the state of New Hampshire. It would be an absolutely ridiculous thing for you guys not to pass this bill. It has been it's time. I am not a criminal, and I'm sick and tired of feeling like I am a criminal in my state. And as far as the comment earlier from the police chief who wants to be able to go in and do random inspections and check out people's homes. Well, I can't think of any other situation in life where you need to disclose your medical information to a police officer and allow them to come in and search your home. Nobody does that for diabetes to make sure that you're using your needles for insulin and not, for something else. Nobody does that for anything. I feel that that would be the chief's way and the police their way of overstepping their boundaries and trying to control a program that they have no business trying to control. I have complete and utter faith in Health and Human Services to be able to control this program and monitor this program so that it would be effective for any and all patient that chose to participate with the home grow version of this. Do I think this will impact the dispensaries negatively? No, I do not. Because for the few of us that want to take on the challenge of attempting to grow at home, there are thousands and thousands more that will still maintain using the dispensaries as they always have been. And I really appreciate you giving me this opportunity to talk. I also have a lot of background in just about every single aspect of cannabis there is from my past, and I would be more than welcome to answer any and all questions and leave you with this thought. By not providing and passing medical home grow and by keeping the restrictions so difficult on a patient, you are in essence helping to continue pushing patients to potentially black market sources where they may not be able to acquire safe and natural product for themselves.
Thank you so much for your testimony. We appreciate that. Looking around to see if there's any questions from anybody or if there's anybody else left to speak.
We have Josie Pinto.
That's where the picture comes in. What's the first name?
Josie.
Josie. Josie. The chair recognizes Josie Pinto.
Good afternoon, all. My name is Josie. I'm here as a lobbyist for New Hampshire Youth Movement, and I'm in full support of HB 350. So last week, the Criminal Justice Committee voted to retain 2 bills that would have expanded cannabis use in our state, allowing voices of out-of-state people to outweigh the massive support from people within New Hampshire. With 963 people signing in to support HB 237 and 1,109 signing in to support HB 629, I want to urge this committee to listen to the clear opinion of people in our state and vote to pass HB 350. Right now, this bill is our last chance to do anything that would meaningfully make a difference in the lives of medical cannabis users. I'm going to keep it brief. I know there's a big storm coming, but being a medical cannabis patient is incredibly expensive, not to mention that most cannabis patients are also paying for a whole other set of medications that they need. We already have some of the highest national costs for healthcare. If we knew it was safe and easy to make these other medications from herbs that grow naturally, would we stop people from doing that? Millions of people use natural herbs to treat conditions every day, and this is the case with cannabis. It's a medicinal plant that's used to grow naturally before we even made it illegal. I urge you, in the live free or die state, let's allow patients to make the decision themselves and allow this bill to pass today. Thank you so much.
And thank you, Ms. Pinto. Since there is no one else, closing now the hearing on House Bill 350. And, everybody be safe, and we'll see you tomorrow remotely, and Republicans, I hope to see you at 7 tonight.
Thank you, everybody.
Good night, everyone.
30 minutes to get north. So.